alcohol 95% or the more common.
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
the wall of the forebrain.
Ethyl alcohol 95% or the more common.
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Ethyl alcohol 95% or the more common.
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Good morning, doctors. Welcome to the session. I'm Dr. Raveerna Reddy, your medicine faculty in Medico. So today we are doing course 6 medicine. So what is this course 6? What do you expect from this? So course 6 is basically we are doing 6 main subjects that will cover 60% of the questions in the NEET-PG. Yeah, that is a big part, right? So that's the most important part. In that, one major subject will be medicine. So in this course 6, I'll be just giving you the overview, the important topics and where should you focus by doing the questions. Because last 15 days for your NEET-PG, very crucial period. We have read, revised. Now this is the most crucial period to do questions. It's the time to apply. You should do questions in this last 15 days. So the same thing we'll be doing. Each topic, each system, each topic will be taking up. We'll be doing the questions and we'll discuss which part to concentrate. So this is not about teaching the whole medicine. Yeah, we'll do that after NEET-PG. We'll be starting daily shots. In that daily 4 hours, we'll be teaching each subject. After that, you'll be having exam. So this will be targeting for the INICET November. So the detailed part we'll do after NEET-PG. But today and tomorrow, this course 6, I'll be just giving you the overview, where to concentrate, from where questions can be asked. Okay, you got me. We'll start the session. And I want this session to be interactive. You should answer because you have read and revised it. So how you should include this in your schedule is, you have read, revised it. This will be an additional revision for you. If you have not read medicine or only done with the first reading, then that is also a good opportunity to know where the questions are asked and to know the important topics and to do a short revision. Okay. No, this session is not about PYQs. PYQs, we have already done it. This session is all about, yes, which topics were covered in the previous years only. We have taken the most important topics and from which questions can be asked. Those competency topics we are discussing now. This is not just PYQs. And we will be going system wise. In each system, we'll take the topics and from each topic, we'll be doing questions. And by doing questions, we'll discuss which parts of the topics you should concentrate more while doing the revision, the last revision before the exam. And for course 6, from course 6, this is the first subject, medicine will be doing. And from medicine, you expect at least 30 questions in your NEET-PG. And that's a good amount of questions. Because the thing with medicine is, if you read medicine, you can attempt almost all the questions. Either they are clinical or factual questions, you can attempt. So that's a good thing. If you read and you can score, that's the good thing. And you have to concentrate on such subjects and on such topics in which that will be easy fetching. Okay, you got me right? Yes, this is for NEET-PG. This is definitely helpful for NEET-PG. This is focusing NEET-PG. Okay. Now let's start the session. You have no doubts, then we'll start the session. We'll be starting with cardiovascular system. So in cardiovascular system, your bedside things, pulse, JVP, ECG are most important parts. Whatever question they ask, they'll be linking this to pulse, JVP and ECG. So these are the important things and you should not miss these 3 things before exam. So first topic, pulse. First we'll discuss the question And after the question, we'll see what parts to concentrate. So first topic in cardiovascular is pulse, arterial pulse. Pulse's bisference is best felt in. It's best felt in. So to look for the character of pulse, where do you look for the character of pulse? Usually carotid, right? But pulse's bisference is exceptional, where you will be looking for radial artery. And even your pulse's paradoxes, you will be looking at brachial artery. So these are the exceptions. Any characteristics of pulse, you will be looking in the carotid artery. So character of pulse, carotid artery. What else do you look in the carotid artery? So for pulse rate, where do you count the pulse rate? You'll be usually looking into the radial artery. For volume of the pulse, normal volume, low volume pulse, to comment on that, you should look into the carotid artery. And this is totally subjective. So the duration of this class will be 8 hours, 10 to 1 and 2 to 7 today. Okay, let's continue the class. So in carotid artery, you'll be looking for the character and volume. So let's look at the other characters of pulse and what is pulse's bisference. Among pulse, in the pulse, the character of pulse is most important. They can ask you pulse's bisference or pulse's paradoxes or water hammer pulse, in which condition you can see this, or they can give you such arterial waves and ask which type of pulse is this. So you should know both the arterial waves and what is the pulse and where it is seen. So this is the normal pulse wave. So now, if we know the normal, we can identify the abnormal, right? So the normal pulse wave, in systole, you will get a peak. So in systole, there is a upstroke. In diastole, there is a downstroke. That we know. So actually, what is a pulse? When your LV is contracting, that contraction that is radiated into your pulse. That contraction, the radiation of that contraction, you feel it as a pulse. The LV contraction force, that radiation of that you see in the pulse. So LV contraction, when there is a systole, there is increased pressure. So there is a peak in the pulse. And when the LV is relaxing during diastole, there is diastolic downstroke in the pulse. And there is dicrotic notch. That is coinciding with S2. Why dicrotic notch? Because, suppose this is the LV. So why do you see dicrotic notch? You have to be interactive. This is LV, and from LV opening is your aorta. In diastole, when the AV valve is closed, the blood from the aorta, when this AV valve is closing, the blood from the aorta is pulled into the left ventricle. So there is some dip in the pressure. That's why you're getting this dicrotic notch. That is coinciding with S2, right? S2 is nothing but aortic and pulmonary valve closure. Now we know what is the normal pulse wave. So systolic upstroke, diastolic downstroke. In diastolic downstroke, there is a dicrotic notch which is coinciding with S2. So each sentence I'm speaking can be a question, potential question. So that is the normal pulse. And let's look at the abnormal characters. In the particular question, we are looking into pulse's bisference. The name itself says bi. So 2 peaks. So 2 peaks in systoles. Bisference. So 2 peaks in systole. That is how you have to remember. Whereas dicrotic pulse is also 2 peaks. There is D. So 1 peak will be in diastole. So mostly you'll be confusing between bisferens and dicroticus because both will be having 2 peaks. So without confusing, you remember in this way, bisferens by S, so 2 peaks in systole, whereas dicrotic pulse D, diastole. So you can see here there are 2 peaks in the systole. Whereas dicrotic pulse, there is 1 peak in the systole and 1 peak in the diastole. See, after S2 there is other peak. So where do you see pulses bisferens? 2 peaked pulse. Where do you see? Only 2 important causes: severe AR with mild AS. So everything is important. Severe AR and HOCM. In these 2 conditions, you can see pulses bisferens. In HOCM, the first peak is like a spike and the second peak is like a dome. That's the reason in HOCM, you specifically call it as spike and dome. Spike and dome pattern. Okay. Now, where do you see dicrotic pulse? Wherever there is severe vasodilation. Like your early heart failure. What happens in your early heart failure? To decrease the preload, there will be increased release of nitric oxide. So there is severe vasodilatation, right? And other thing is your anaphylactic shock, where there will be severe vasodilatation. Okay. Now you know bisferens and dicroticus, the most confusing pulses. We'll see other pulses. Where do you see pulses parvus et tardus? Parvus is short peak pulse. Tardus is late peaking pulse. So the pulse is short peak. That means the flow, the LV outflow is obstructed, right? So what are the conditions causing LV outflow obstruction? Your AS, aortic stenosis. The aortic valve is at the LV outflow, right? Next, pulses paradoxus. So coming to pulses paradoxus, we are not looking at the pulse, it's PP. It's not a paradoxical phenomenon, it's an exaggerated phenomenon. So what is that exaggerated phenomenon? Normally on inspiration, your BP will decrease by 9 mm of Hg. But here on inspiration, in this pathological condition, that is pulses paradoxus, your BP is decreasing more than 9 mm of Hg on inspiration. BP is decreasing more than 9 mm of Hg on inspiration. Yeah, that is pulses paradoxus, right? Where do you see it? Respiratory conditions causing pulses paradoxus is your severe emphysema, next acute severe asthma. See, now you have to be more specific. In mild persistent asthma, moderate persistent asthma, you won't find this pulses paradoxus. If you see or if you demonstrate a pulses paradoxus, or if the question mentions pulses paradoxus in a case of asthma, now came with increased shortness of breath, and we can demonstrate pulses paradoxus, then that is acute severe asthma. And the management of acute severe asthma is completely different. You have to give oxygen to the patient, if necessary NIV, non-invasive ventilation or invasive ventilation, and you have to give IV hydrocot. Salbutamol nebulization. So, and one type of question they can ask is, what is the immediate next step? So, if they ask the best management, you all will answer. But whenever they ask what is the immediate best step, that too in emergencies, they'll ask you. So, any emergency, the immediate best step will be stabilizing the patient. ABC will be the immediate best step. So, this patient of asthma, airway, first airway is important. Maintain hypoxia, ventilator, that is more important. Yeah, this will be done simultaneously. So any case of hypotension, maintain, BP maintenance is more important. So ABC will be the first thing. Other things we'll do simultaneously. And in pneumothorax and PTE also you can see this. What are the cardiac conditions causing pulsus paradox? Your constrictive pericarditis, right ventricular incompliance, like RV failure or RVMI. Okay, all these conditions can cause pulsus paradoxes. Next question, where do you see pulsus alternance? And I have a question for you. Is pulsus alternance and electrical alternance both are same or both are different? If different, in which condition you can see? No, they are different. Pulsus alternance is your pulse is alternating. One high volume pulse, one low volume pulse. Whereas electrical alternance is the waves in the ECG, the amplitude is alternating. One QRS is long, one QRS is short, one QRS is long, one is short. It's completely different. Your pulsus alternance is seen in LV failure. Any cause of LV failure. When your left ventricle is not functioning, you can see pulsus alternance. Whereas electrical alternance you see in cardiac tamponade. Yeah. Yes, it's cardiac tamponade. And one more thing you have to remember is, what is the difference between pericardial effusion and cardiac tamponade? The fluid around the heart. So in your pericardial sac, this is your heart. In the pericardial sac, normally there will be 5 to 10 ml of fluid. If that fluid is increased, you call it as pericardial effusion. But if that is compressing the heart, it's not allowing the heart to perform its diastole, then that is called cardiac tamponade. Okay, so both things are different. And your electrical alternance is seen only in your tamponade, not in pericardial effusion. Why there is electrical alternance? This is the chest wall, this is the heart, and in that cavity, pericardial cavity full of fluid, your heart is swinging. So if it comes near to the chest wall, the amplitude will be high. If it's going away from the chest wall, the amplitude will be low. So that's what is happening in cardiac tamponade. That's why there is electrical alternance. So one of the option will be also pericardial effusion. For suppose they can ask a question, electrical alternance is seen in all of the following. Select the options, cardiac tamponade and pericardial effusion, constrictive pericarditis. They'll give all the pericardial disease. It's seen only in cardiac tamponade. Do not mark pericardial effusion. In these both are same, fluid around the heart, but tamponade, it's compressing the heart. The pathophysiology is different. Okay, we are done with the characters of pulse. And one more important thing they'll ask about pulse is irregular and regular pulse. So normally your pulse should be regular or irregular. It's regular because the contraction of ventricle is regular. Where do you see irregular pulse? Actually, what is irregular pulse? See, one pulse, next one pulse, and there is a drop beat. And again you can start feeling pulse. Again no pulse, drop beat. Again you can feel pulse. Yes, this is irregular, but it's regularly irregular. And this pulse is irregularly irregular. So where do you see regularly irregular pulse and irregularly irregular pulse? So what is pulse? It's nothing but the propagation of your LV contraction. So if there is drop beat, means the LV has not contracted properly or it's not at all contracted. It's due to impaired LV contraction, absent LV contraction, or impaired LV contraction. So absent LV contraction, so there is a P wave, but no QRS. How do you diagnose that? So it is AV block. So in AV block, the impulse is going from SA node to AV node, but AV is blocked. So the impulse is not going to the ventricles and the ventricles have not contracted. In that case, you can get a irregularly irregular or regularly regular. If the block is fixed, the pulse will be regularly irregular. If it's variable, then it is irregular. And coming to impaired LV contraction, it is seen in ventricular ectopics, that is VT. And many impulses are coming from atria, so there is no sufficient time for your left ventricle to contract, that is atrial fibrillation. There are multiple ectopics in your atria that are coming to the AV node, and AV node is sending them. Of course, there is some block, but most of it's sending them. So your ventricle is not getting enough time to contract because of tachycardia. So there is impaired LV contraction, AF and VT. VT can be regular or irregular. Regular VTs can be bigemini rhythms, trigemini or quadrigemini rhythms. So bigemini is one normal followed by VT. Again one VT. VT is due to ventricular ectopic. Bizarre broad QRS complex will come when the ectopic is in ventricle. And there is a normal beat. In trigemini, normal, VT, 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 normal. So you can see that on ECG. Or in pulse also, you'll be having, after one normal beat, you'll be having 2 missed beats. So like that you can see in the pulse. Okay. One more important thing they can ask in pulse is apex pulse deficit. What is apex pulse deficit? The name itself says cardiac apex and the pulse, that is left ventricle and pulse. So what is pulse? It's nothing but the contraction of the wave of LV contraction. But that wave is not coming here. So what's the pathology we'll see? So if normally the apex pulse deficit should be 0. Whenever there is LV contraction, there should be a pulse. But if there is deficit, the deficit is less than 10, then it could be VT. If the deficit is more than 10, then it is AF. So in question, they'll include one key term like apex pulse deficit is 20, 15. Then you have to suspect AF, irregularly irregular rhythm with apex pulse deficit of 15. Or they can ask you irregular rhythm, tachycardia with apex pulse deficit of 5. Then you should suspect VT. Just without showing you the ECG, just they can frame a question on this. And how do you calculate apex pulse deficit? If one person is there, then he'll keep a steth here and he'll palpate pulse simultaneously. For every S1, there should be a pulse. If anything is missed, he'll note down. If there are 2 persons, 2 persons will differently calculate, measure heart rate and pulse rate. After that, they will see the difference between that. So that is 2-person method. Both can do. That's how you have to calculate. And if there is an irregular rhythm, only when there is irregularly irregular rhythm, you will be looking for apex pulse deficit. And if the apex pulse deficit is 0, means that LV has not contracted. So it can be AV block. The apex pulse deficit is there, means there is ineffective LV contraction. So these are the important areas of the pulse which you should concentrate. Okay, this question we have answered. Anything in pulse, you'll be looking at carotid, especially the character. But pulses paradoxes, you'll be measuring in the brachial artery. You're measuring the BP, right? And pulses bisferens, you'll be looking in the radial artery. Okay, let's take the next question. So next topic will be JVP, one more important topic, your jugular venous pressure. So in jugular venous pressure, they will ask you the waves, which wave is corresponding to which cycle of cardiac cycle. And they will ask you the pathology in waves, absent A wave or giant A wave. Pathology in waves. And in JVP, the JVP of cardiac tamponade and CCP. These are the areas mostly they'll be asking a question on JVP. And they can mix and match. They'll give the pulse, they'll give the JVP, they'll give the ECG, and they want you to identify. So first we'll see the question and we'll look into the important areas of JVP. True statement regarding JVP in atrial fibrillation. See, in one arrhythmia, he can also give ECG and he can ask AF ECG and he can ask what is the expected JVP. Or he can give you the cardiac tamponade scenario, clinical scenario, and he can ask you what is the expected JVP. So in such ways, he can ask you the questions, or it can be direct. So we are learning in a specific way. Okay, these are the waves, these are the abnormalities. But in exam, in any way, he can correlate. So to train your brain for that correlation, you have to do MCQs. That is the importance of MCQs. And especially in the last 15 days, do not ignore MCQs, okay? Give a GT at least alternate day. And if possible, if you're well revised, give daily a GT. So what's happening to JVP in AF? Please be interactive. This will be like a revision for you. Even if you are wrong, it's okay. Okay, there is absent A wave in JVP, in AF. So one thing we have seen is absent A wave in AF. What is A wave and what are the waves in JVP? So coming to JVP, there are two predominant positive waves and two predominant negative waves. The predominant positive waves are A and B. And negative are X and Y. So whenever your question is saying predominant positive waves, increased A wave, increased V wave, then the pathology is probably in your myocardium or cardiac. Myo or endocardium. And if your question or clinical scenario is stating exaggerated negative waves, like exaggerated X wave, exaggerated Y wave, then the pathology is in the pericardium. So in such way you can get one clue. So positive waves are pathologic or exaggerated. Think of myocardial or endocardial problem. If negative waves are exaggerated or they are pathological, think of pericardial diseases. And coming to positive waves, why there is A wave and relation to cardiac cycle. In which part of the cardiac cycle you can see A wave? So where are you seeing A wave? It's jugular venous pressure in your internal jugular vein, right internal jugular vein. You're seeing it. Okay, A wave is due to atrial contraction. atrial contraction or systole. Now you tell me, atrial systole is a part of which part of cardiac cycle? It's a part of ventricular systole or diastole. See, whenever I say systole or diastole, I am saying it as ventricular. If I'm not mentioning anything, it's ventricular. If it's atrial, we'll be mentioning specifically as atrial systole. So this atrial systole is the last part of ventricular diastole. So ventricular diastole, ventricular relaxation. So the ventricle should be filled from the atria. So the initial part will be just by decrease in pressure, but the last part and the lesser part of ventricular filling is by atrial contraction. That is the atrial kick. So that this is the last part. And what is Y wave contributing to? It's ventricular relaxation. That's the first part of the ventricular diastole, first and the major part. So your diastole has, what are the components of diastole? One is isovolumetric relaxation. Next is rapid filling. Rapid filling is just due to ventricular relaxation, and that is 2/3 of the filling happens there. And next is atrial contraction. And due to atrial contraction, 1/3 of your ventricle filling will be happening. So this contributes to your Y wave and this contributes to your A wave. So now you know A and Y are a part of ventricular diastole. So the question can be also framed like this. Which waves of the JVP will be correlating to your ventricular diastole? So then you have to select A and Y. The other 3 waves are in systole, ventricular systole. Okay. Why is X wave due to? It's atrial relaxation. C wave is due to tricuspid valve protrusion into the RA. V wave is due to ventricular filling of RA. Okay, so you can easily remember in this way. A for atrial contraction, X for atrial relaxation, C for when will the tricuspid valve protrude? Only when the tricuspid valve is closed and the RV is contracting, only then the tricuspid valve will protrude into the RA. So this is RV contraction. So C for RV contraction, V for ventricular filling, Y for ventricular relaxation or atrial emptying. Okay, no confusion. Now you know the correlation with the cardiac cycle and correlation with systole, diastole, and more specifically. Okay. So this is important. So the next thing is which is important is pathology. Let's see the pathology of A wave. A wave is due to atrial contraction. Absent A wave is due to, now we'll be looking into 2 things. Exaggerated A wave and absent A wave. Where do you see absent A wave? I told AF. So A wave is due to atrial contraction. In AF, the atria is not contracting only, it's just fibrillating. So if there is a single impulse, it will contract, but there are multiple ectopics, so atria will fibrillate. So the implication of this thing is the atria will fibrillate, so there is no A wave. Because there is fibrillation and no contraction, there is pooling of blood in the left atrium, resulting in thrombus formation and thromboembolism. AF, left atrial thrombus formation. And thromboembolism, resulting in stroke. So multiple mini strokes, the patient can land in dementia also. So do not forget dementia as a consequence of AF, okay? Now exaggerated AF, there can be a giant A wave or canon A waves. So everything can be a potential question. Absent A wave, where can you see canon A waves? Where can you see giant A waves? So where do you see giant A wave? See, A wave is due to atrial contraction, but there is some obstruction to the outflow of atrium. Then the pressures will be increased in the jugular vein, right? So there is some obstruction to the atrial outflow, like your tricuspid stenosis. Or your RV is incompliant. The atria is contracting, but RV or LV is not in a position to receive that. It's incompliant. RV failure, RVMI. Next, after tricuspid valve, after right ventricle, yeah, there is pulmonary valve in pulmonary stenosis. After pulmonary valve, there is pulmonary artery hypertension. In all these things, you will see giant A wave. So AV dissociation, atria and ventricle are dissociated. They are no more in connection. In which conditions you can see that third degree AV block. So the connection between the atria and ventricle is the AV node, right? That has been blocked. And your VT, ventricular ectopic. The ventricle is contracting on its own. So when there is ventricular contraction, the tricuspid valve will be closed, and at the same time, if the atria is contracting, you will get a canon A wave. So these are all the questions which can be asked in A wave. And the next important thing is Y descent. Y descent is atrial relaxation. Because the atria is relaxing, the pressure in the atria is decreasing, resulting in, X descent. Where do you see exaggerated X descent? This is important. The prominent X descent or exaggerated X descent you will be seeing in cardiac tamponade. So when atria is relaxing, so while X descent is happening in the atria, what is happening in the ventricle? Ventricle is in systole, right? So what's happening in cardiac tamponade is the diastole will be affected. See, the heart is being compressed on all sides with the water. So the heart cannot be relaxed, but the systole will be completely good. In diastole, the LV cannot be filled. See, LA to LV, the blood should be filled in diastole. But in diastole, it is affected in cardiac tamponade, so it cannot be filled. Now in systole, even the LV is contracting, even though it's contracting, it will be filled from LA. So the pressures in the atrium, not LA, RA. The pressure in the RA is decreased, resulting in prominent Already it's a negative wave, more decrease in pressure, so prominent wave. Where do you see absent? Absent X descent. See, X descent is due to atrial emptying, relaxation, right? Now, during this relaxation, if the blood has been added from somewhere, for suppose this is RA, this is RV, this tricuspid valve is closed, pulmonary valve is open, the blood is going in this way, the atria is relaxing. For suppose there is tricuspid regurgitation, so the blood from RV is being added, or there is ASD, the blood from LA is being added to RA. In those conditions, you will see absent X descent, ASD and tricuspid regurgitation. See, tricuspid regurgitation, there is absent X descent. So when there is absent X descent, after C, directly there will be V wave. So this X descent will be absent. I'm speaking about tricuspid regurgitation. In tricuspid regurgitation, X wave is absent. That's what we have discussed, right? So because the X wave is absent, after C wave, directly V wave will be seen. So that is called CV wave in tricuspid regurgitation. So this is also an important question. Yes, CV wave. So this is also important. Next, why descent is more important? Why there is Y descent? It is due to ventricular relaxation. Now if you tell me where is the Y descent absent? Just now we have discussed. Y descent is nothing but ventricular diastole, right? The ventricle is relaxing. In which condition the diastole is affected? Your cardiac tamponade, right? Y descent is absent in cardiac tamponade. There is no diastole. And the Y descent is prominent in constrictive pericarditis. See, even the constrictive pericarditis is the same. It's like a thick wall, the thickened pericardium around the heart. So what happens here is, this is the thickened pericardium and this is the heart. There is some space for the heart to relax. So the early diastole, so the first part of the diastole, there will be no problem. After some diastole, the mid and late diastole, there won't be any space. It's like a wall around the heart. Early diastole, no problem, but mid and late diastole will be affected. So in the early diastole itself, the whole blood from the LA will come into the LV. So in the early diastole only, there will be exaggerated ventricular filling or ventricular relaxation. That's why the Y descent is prominent. Whereas in cardiac tamponade, early, mid, late diastole, everything is affected, no diastole. So this is also a question. And the statement I told you, mid and late diastole is affected in CCP. Whereas whole diastole starting from early will be affected in cardiac tamponade. Okay. So in constrictive pericarditis, so your exaggerated X wave is also seen in constrictive pericarditis, the same pathology. So in constrictive pericarditis, there is prominent X wave and prominent Y wave. See, this difference is very important. The JVP of cardiac tamponade and constrictive pericarditis, very important. So in constrictive pericarditis, there is prominent X wave and Y wave. So I told you prominent negative waves or any pathology of negative waves indicates pericardial disease. So that was just a brief thing, a simple thing to remember, but this is the actual pathology behind that. And this is looking like a W, right? Yeah, this is looking like an M pattern. What is that sign called? Federic sign. Whereas cardiac tamponade, the X wave is prominent and the Y wave is absent. Okay. And one more important thing, in tricuspid regurgitation, you will be having CV pattern. CV pattern. That is, C wave is directly continuing as P wave and absent X descent. So these are the important things they can ask you in JVP. So they can correlate it in any way. They can give you a clinical scenario, they can give you an X-ray or ECG. Okay. We'll see the other options. Where do you see absent Y descent? Absent Y descent in cardiac tamponade. Where do you see non-pulsatile JVP? See, normally your JVP should be pulsatile. So the changes in your RA are indicated as JVP waves. So if RA and your internal jugular vein are in connection, then it will be pulsatile. So it's non-pulsatile means the connection is lost. In which condition the connection between your internal jugular vein and RA is lost? Your SVC obstruction. Okay. So non-pulsatile JVP. So this question they can ask you in many forms, like which of the following are the signs of heart failure or right heart failure? Right heart failure, there will be elevated JVP, yes, and that is pulsatile. One of the options will be non-pulsatile JVP. Increase JVP with non-pulsatile. You will be only seeing at increased JVP. You have to look specifically non-pulsatile JVP or pulsatile JVP. So non-pulsatile JVP, it's seen in SPC obstruction. And coming to slow Y descent, where do you see slow Y descent? So Y descent is ventricular relaxation. Relaxation means the blood should come from atrium to the ventricle through the tricuspid valve. If there is tricuspid stenosis, blood from the atria is coming slowly into the ventricle. So there will be slow Y descent. So tricuspid stenosis, tricuspid regurgitation, CCP and cardiac tamponade. The JVP waves, how are the JVP waves? In all these things, the JVP is elevated, but the waves are different. So this is about JVP. Next topic is your cardiac auscultation. In auscultation, they'll ask you about heart sounds, S1, S2, and abnormal heart sounds, S3, S4. Next thing, they'll ask about the murmurs and other sounds. Other sounds, you can hear them in systole or diastole. So in these, the abnormalities will be a question. So they'll give you a clinical scenario, or in the question, this can be a key point. So we are discussing the keywords. So everything I'm speaking will be a keyword. Reverse splitting of the second heart sound is due to. So your S2 is split. We know that it has A2 and P2 components. Now reverse splitting he's asking. Reverse splitting means P2 is earlier than A2. He's asking what is the reason for this. See, in any pathology, the delayed component will be abnormal. Here A2 is delayed, right? So the delayed aortic component will be pathologic. And we'll discuss this in detail after a short break.
Ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Okay, sorry for the interruption. We'll continue. We are discussing about reverse split of second heart sound, right? I told you the delayed component. Normal split is A2 followed by P2 because the left atrium, left ventricle more pressure, rapid filling. So obviously A2 will be early. So in reverse split, A2 is delayed. So A2 is the pathological component. So delayed aortic component is the correct thing rather than early pulmonary component. Why there is delayed aortic component? Some problem in the left ventricle. So delayed A2. What is that issue? There is left bundle branch block or there is LV hypertrophy. Large muscle has to be covered. So there is delayed. Or there is a pacemaker. You have put it in the right ventricle. RV pacemaker. So P2 will be earlier. And or there is aortic stenosis, LV outflow tract obstruction. So the LV emptying will be late. So in all these conditions, so if you see here, there's pathology of the left heart. That's why A2 is delayed. Or you have exaggerated the right heart. So this is the normal split. Okay, S1 is fine. In S2, A2 will be first followed by P2. Reverse split is the A2 is delayed. So the best term, instead of saying P2 is coming is in first, A2 delayed will be the best term for reverse split. See, A2 is delayed in expiration. So coming to S2, it is a normal heart sound. It's high pitched or low pitched. This is also important. Like they can ask you a question like which of the following is true about or false about S2. In that they can give one option as it's high pitched or low pitched. So don't confuse. In heart, everything is high pitched except for S3, S4 and your diastolic sounds. Diastolic murmurs. So your diastolic murmurs and S3, S4 are low pitched. Everything is high pitched. So low pitched, you will be using bell of the stethoscope. High pitched sounds, you will be listening with the diaphragm of your stethoscope. Okay. What is normal S2 and what is reverse split? And what is widened split? So patient isn't quiet. So you have to listen to S2 in quiet respiration and deep inspiration. So normally, in a normal person without any pathology, in quiet respiration, there is no split. And in deep inspiration, there is split. But if in quiet respiration, there is a split, it can be widened split or reverse split, I do not know. If it is widened split, in deep inspiration also the split is present. If it's a reverse split, in deep inspiration, the split will be absent. So in question, he may not give you directly as reverse split or widened split. See, everything I'm speaking is a keyword. In question, he'll give you that a patient is being auscultated. In quiet respiration, we have appreciated a split. On deep inspiration, the split was not there on deep inspiration. That is how we can frame a question. So indirectly, he is giving you a keyword or hint that it's a reverse split. Okay, widened split means normally it's A2, P2. Widened means the cap has increased. Which has delayed? P2 component has delayed. Reverse means A2 component has delayed. So these are the causes of reverse split. Where do you see widened split? There is some pathology to the right in the right ventricle or increased blood flow in the right ventricle. That's why P2 is delayed. So in which conditions you can see widened split? So delayed P2, right? RBBB? Yes. Wide fixed S2. Fixed split S2. Where do you see that? It's seen in ASD. Left to right shunt, more blood flow in the right. VSD, right to left shunt, more blood flow in the right. Pulmonary stenosis, delayed blood flow in the right. Or this is RV outflow obstruction, outflow tract obstruction. So if you remember what is delayed, you can derive the causes. Do not by heart it. So this is about S2. And one more thing I want to ask you is S2 is because of what? See, S1 and S2 are because of closure of valves. It's closure of aortic and pulmonary valves. The sound is because of closure of AV and PV valves. S3 and S4 are not because of closure of valves. Remember that. Only S1 and S2 are because of closure of valves. Now you tell me where S1 is coming from. When you're auscultating, you can hear lub, dub, right? This is what you'll be hearing. This lub is S1, dub is S2. That's it. So your S1 is due to the closure of atrioventricular valves like tricuspid valve and mitral valve. See, you can ask me, you can have a doubt. In S2, there is a split or there is a gap. In S1 also, there should be a gap between tricuspid and mitral valve, right? Actually, there is a gap, but that gap is too small to appreciate. Okay, that's fine. Let's leave it. Now, let's look at S2. So, normally, where do you hear loud S1, soft S1? So valves are closing very hardly. That's what loud S1 means. So when the patient is having hyperdynamic circulation, increased blood flow, so more hyperdynamic circulation, the valves are opened hardly, so closed hardly. So if you open a door hardly, it will come back and close hardly, right? The same way. When the patient is having tachycardia, and any pathology of the valve like MS, or a patient with lean chest wall, especially in males, thin person, you can hear loud S1. Where do you see soft S1? Hypovolemia, bradycardia, prolonged PR intervals. So the heart is filled, the ventricle is filled slowly. Obese persons, or there is mitral regurgitation, there is calcified valve, when there is atrial fibrillation. When there is atrial fibrillation, the blood from the atria is not being completely emptied into the ventricle, right? So in such conditions, you can see soft S1. So whenever I say hyperdynamic circulation, where do you see hyperdynamic circulation? Anemia. Yes, your HB is low. To compensate that, there will be increased circulation. Cirrhosis, because there is splanchnic vasodilatation and the pooling of blood in the splanchnic system. In the systemic circulation, there is increased hyperdynamic circulation. In renal failure, wet beriberi, thyrotoxicosis. All these are the examples of hyperdynamic circulation where you will be seeing loud S1. So based on this, there can be a question like a patient of mitral stenosis. So he's diagnosed case of mitral stenosis, but now you can hear soft S1. What could be the cause? So in MS, you should appreciate loud S1, right? But now there is soft S1. What can be the cause? The patient can be landing into MR, MS plus MR, or the valves has been calcified, or the patient have been landed into AF, which is one of the important complication of MS, right? Your left atrium, left ventricle, there is mitral valve, the mitral valve is stenosed, increased pressures in your left atrium, left atrial enlargement, chronic left atrial enlargement resulting in AF, and we know the complications of AF, thromboembolism, tachycardia, tachycardia-induced cardiomyopathies. Okay. So this is about S1 and S2. We'll see S3, S4. I told you S3 and S4 are not due to closure of valves. Then why we can appreciate? So one question I want to ask you is S3 and S4 are heard in the systole or diastole? They are diastolic sounds. So after S2, S3 is early diastole. S4 is late diastole. So there can be a question like which of the following are late diastolic sounds or early diastolic sounds, or question can be which of the following are systolic except, that can be S3 or S4, and there are other diastolic sounds, we'll see. So S3 is due to rapid filling of incompliant LV. So it's nothing but filling of LV is ventricular diastole. The early diastole is all about ventricular filling. So in early diastole, you can see S3. If that LV is incompliant, that is LV failure, you can see here S3. S4 is due to contraction of left atrium into incompliant LV. The last part of the ventricular diastole, that is atrial systole, in that part if LV is incompliant, you can see here S4. So S3 can be physiological or pathological, but if there is S4, it is pathological. Other than S1 and S2, if you are hearing two more heart sounds, S3 and S4, in early diastole if you hear, you call it S3. In late diastole you hear, you call it S4. In late diastole you are hearing it, it is pathological. S3 can be physiological in pregnancy. Also you can see S3. That's why it can be physiological. Also pathological. What pathology? Incompliant LV, LV failure. So these are all the keywords. Anything can be in the question or option to identify it as S3 or S4. So these are the heart sounds. S1, S2, S3, S4, you should not miss. Okay, so it's LBBB, delayed aortic component, reverse splitting of second heart sound. So this is a direct question. It can be framed indirectly also, like in quiet breathing, in deep inspiration, what are the events happening, they'll mention, and you have to derive that it's a reverse splitting. So in exam, there is nothing like tough question or easy question. It's known or unknown. If you know it. You try to derive it in any way. If you don't know, you cannot do anything. You can guess by excluding the options. So even guessing is also an art. You should not do randomly. See, there are 4 options. If you guess randomly, there are 25% chances that each option can be correct. If you exclude one, 33% chance. Exclude 2, 50% chance. Excuse me. So that's why try to exclude options if you don't know. If you know the question, if it's direct, it's okay. Don't make silly mistakes. If it's indirect question, try to derive it. Understand the question, pick up the key points and try to derive to the options. Excuse me. Sorry for the interruption. So what am I saying? So there is nothing like tough question or easy question. If you know, you will know it without fearing it's a tough question. It's indirect or I'm not able to solve it. So don't take it emotionally. Without fearing it, try to solve the question. Okay. So the next topic in the cardiovascular system is murmurs, the same auscultation. So murmurs, they can ask you about which are the systolic murmurs, diastolic murmurs, in that mid, late, and early systolic or diastolic murmurs, continuous murmurs, and the radiation of the murmurs. And one more thing they can ask you is the murmur is exaggerated by or decreased by in which manners. So we'll see all those things. We'll have an overlook after seeing the question. So every question, pick up the key points. What is the key point here? Okay, young patient having a systolic murmur. Systolic murmur at the apex. And it is increasing on hand grip and Valsalva manner. Which of the following is the likely diagnosis? So he has given the clue that it is a systolic murmur. Let's see the options. MR is a pansystolic murmur. At apex, okay, this is apt for my question, but do not hurry, look all the options. VSD, it is pansystolic murmur. At left parasternal. AS, aortic stenosis, it is an ejection systolic murmur. At aortic area. Whereas HOCM, hypertrophic obstructive cardiomyopathy, it is subaortic stenosis. So this is also a aortic stenosis but subaortic region. So the same ejection systolic murmur can be heard. So the difference between these two is the AS can be radiating to carotids. But your HOCM ejection systolic murmur doesn't radiate to carotids. So what is the difference between pansystolic and this ejection systolic? Sometimes they will give the murmur in diagrams. So systolic between S1 and S2, right? So pansystolic, it's the same intensity throughout the systole. So he can give you such diagrams and ask you. He will not directly mention in the question as pansystolic or ejection systolic. He'll give you the images. So make sure you also look at the images, or make sure, or what is the exact definition of that, at least you should know. So ejection systolic murmur, it will have a peak. Crescendo decrescendo type. It will have a peak in the, I cannot say mid systole, the peak will depend upon the aortic stenosis severity. More severe the stenosis, the peak will move more later. More delayed the peak will be. So the difference between pansystolic and ejection systolic is pansystolic, the murmur immediately starts after S1 and continues up to S2. Whereas ejection systolic murmur, there will be a peak and the murmur won't start immediately after S1. Okay, these are all the systolic murmurs. I cannot differentiate just based on this systolic murmur at the apex. The murmur increases on hand grip and Valsalva manner. So what are you doing with hand grip? With hand grip, you are increasing the afterload. And with Valsalva manner, you are decreasing the preload. Sorry, you are increasing the preload. You're decreasing the preload to the left heart and increasing the preload to the right heart. We'll discuss what is this. So in any murmur, so remember, any murmur, if you increase the preload, that is the flow to the heart is increased. And if you decrease the afterload, that is, afterload is nothing but against afterload, against that pressure only the heart is contracting. If the afterload is decreased, the LV will contract very good and the flow through the valves also will increase. So any murmur, if you increase the preload and decrease the afterload, the murmur intensity will increase. So any murmur. The exception is your HOCM, hypertrophic obstructive cardiomyopathy, and mitral valve prolapse. Only in these things, if you increase the afterload and decrease the preload, only then your murmur intensity will increase. So on Valsalva, decreasing the preload, and hand grip, increasing the afterload, the murmur intensity has increased. So this is definitely HOCM. Other than these two, any other valvular lesion, I'm saying all means any other valvular lesions other than these two. So yeah, this is how they can give you the diagrammatic representation of the murmurs. I told you aortic stenosis is a ejection systolic murmur, right? See, you can see the peak, crescendo, decrescendo pattern. And mitral regurgitation is a pansystolic murmur. You can see the similar intensity, right? So whatever murmur you learn, especially your 4 valvular lesions, MS, MR, AS, AR, you should know the diagram. And coming to aortic regurgitation, it is early diastolic murmur, mostly early diastolic. And your mitral stenosis is mid diastolic murmur. See, it's starting in the mid and can extend into late diastole also. Whereas your PDA, even in systole and diastole, the murmur is continuous. So this is continuous murmur. So we have seen AS, AR, MS. The 4 important lesions, we have seen the diagrams of the murmur. The pansystolic and holosystolic both are same. If the question is saying holosystolic, do not get confused. It's the same. Let's look at all the murmurs. Not just these 4 lesions. We'll see into both systolic and diastolic murmurs. Systolic murmurs, diastolic murmurs. Early, mid, late. And pansystolic murmurs. And one more thing that comes is continuous murmurs. Where do you see early systolic murmurs? See, your pansystolic murmurs are seen in large VSD and chronic MR. But when there is acute MR and small VSD, you can see early systolic murmurs. And prominent in the mid systole are your ejection systolic murmurs, AS and pulmonary stenosis. Your late systolic murmur will be your MVP, mitral valve prolapse. See, mitral valve prolapse can be associated with MR. But the typical murmur of mitral valve prolapse is click in the mid systole followed by murmur in the late systole. Click followed by murmur. Now coming to diastolic murmurs. What are the early diastolic murmurs? AS, PS. Mid diastolic murmurs are your mitral stenosis and your atrial myxoma And the late diastolic murmurs are Caricom's murmurs. Your Caricom murmur can be mid or late. Remember that. And Caricom murmur is seen in acute rheumatic fever due to mitral vasculitis. And this named murmurs are also important. They can give you in a match the following. And continuous murmurs, PDA or any AV fistula. So for dialysis, you'll be having an AV fistula on the hand. On that also, if you hear, there will be a continuous murmur. And the murmur, continuous murmur of PDA is called Gibson's murmur. And it's best heard in Gibson's area. Where is Gibson's area? Left first intercostal space, just beside the sternum. So just beside the sternum, left first intercostal space will be your Gibson's area. There you can hear the best continuous murmur of PDA, that is called Gibson's murmur. Left second is pulmonary valve. Right second is aortic valve. So normally you'll be confused. The aortic valve should be on the left side, pulmonary valve on the right side. So right is pulmonary, left is aortic. That is how you remember. But no, it's opposite. Left second intercostal space is for pulmonary and right second intercostal space is for aorta. And these areas are not dependent on the anatomical position of the valve. It's dependent on the flow of the valve. See, the aorta, the flow will be towards this side. That is why the right side will be the best area to auscultate aortic lesions. Whereas the flow of the pulmonary valve, flow from the pulmonary valve will be towards the left side. That's why left side will be the best or ideal side for pulmonary valve. So you'll be confusing between that. So remember that. So this is about murmurs. And one more important thing is inspiration, expiration. Your right-sided murmurs are best heard on inspiration. Your left-sided murmurs are best heard on expiration. Why? Because on inspiration, the flow to the right heart increases. The same thing you are doing in Valsalva manual. Okay, these are the things you should look into in the cardiac sounds. The normal heart sounds, added sounds, S3, S4, murmurs, and next thing other sounds other than your norm S1, S2, S3, S4 and murmurs are. You have to see what are those. So which of the following are diastolic sounds except? So opening snap, ejection click, pericardial knock, tumor plop, these are the additional sounds you will be seeing. So what is opening snap? It's due to the opening of mitral valve. When will the mitral valve open? Just don't get confused. What is the purpose of mitral valve? The blood from LA should go into LV. So when blood from LA is going into LV, in what stage LV should be? LV should be relaxing in diastole. So this is in diastole. And the LV starts filling in early diastole. So this should open in early diastole. Normally, mitral valve will open in early diastole, but you cannot hear that. If you hear the opening of mitral valve, then there is MS, mitral stenosis. So in mitral stenosis, see this is S1, I'll write here because other things there should be space, right? So this is S1, this is S2, S1. So this is the diastole, right? In early diastole, typically there is opening snap, followed by a murmur in the mid diastole, okay? Followed by pre-systolic accentuation. This is the typical murmur of mitral stenosis. Opening snap followed by mid to late diastolic murmur with pre-systolic. So this after S1 it's nothing but systole, right? So this part will be pre-systolic. Presystolic accentuation. Why that presystolic accentuation? Because there is mitral stenosis. The filling from LA to LV is decreased. The area through which the filling should have happened is decreased. Now in the late part, the blood is pooled in the left atrium. So the left atrium will contract. That is atrial kick. This is because of atrial kick. So if presystolic accentuation is absent, then the patient might be in AF. So the patients of MS are totally dependent on their left atrium for the ejection fraction. So almost 30 to 40% of the ejection fraction will be dependent on the left atrium. Because from the left atrium should contract, then only the blood will come into the LV, then only the LV can contract and you will get an ejection fraction, right? So it's dependent on LV. So if there is AF or LA failure in MS, they will land into severe heart failure. So LA failure and AF, the patient will be completely decompensated. So AF in a patient of MS is devastating. The patient will be in the ICU. That's what you have to imagine. Devastating means. Okay, that is about opening snap. What is ejection click? Ejection click is opening of aortic valve. Ejection click is opening of aortic valve, seen in AS, right? So aortic valve is opened in systole, right? So this is a systolic sound. Coming to pericardial knock onto the pericardium. So when there is constrictive pericarditis, the pericardium is thickened and is like a thick wall. So in the early diastole is okay, but in the mid diastole, the heart wall will be knocked to the pericardium, hearing as pericardial knock. So it's a mid diastolic sound. Constrictive pericarditis and it's a mid diastolic. And coming to tumor plop, the name itself says there is some tumor. So the most common tumor in left atrium is LA myxoma. So this is normally in the LA cavity attached to the atrial septum. But when there is flow of blood from the LA to LV, this tumor will come and plop to the mitral valve. This tumor is like pedunculated. It will come and plop to the mitral valve. So the mitral valve is obscured, closed. So it will be behaving like MS. So your mid-diastolic murmur will be also seen in atrial myxoma. That's why I've written that. So tumor plop is seen in atrial myxoma. So along with the features of malignancy, like young males with fever, intermittent fever, weight loss, cachexia, along with that they will also have features of mitral stenosis. If you auscultate, you can hear MDM murmur, and that will be intermittent and it will be changing in position. With position, it will change. So patient will have intermittent but sudden symptoms. Suddenly your mitral valve will be blocked, so patient will land in failure. So where do you see tumor plop? I told you in diastole, when the blood is flowing from LA to LV only, then the tumor will come and plop to mitral valve. Otherwise, if the mitral valve is closed, the tumor will be nicely floating in the left atrial cavity. So it is a early to mid diastolic sound. So these things they can ask you. Whether this sound is a diastolic sound or systolic sound, if it's diastolic, early, late also. To this diastolic sounds, you can also add S3, S4 because S3 is a diastolic, early diastolic and S4 is a late diastolic. So the same thing is given here. So this is a diastole, and in diastole, you can, in early diastole, you can hear opening snap seen in MS. Next, in mid diastole, you can hear, see, S3 is a early diastolic sound. In mid diastole, you can hear tumor plop, and pericardial knock. S4 is a late diastole sound. Ejection click is a systolic sound. So that is whatever we discussed is in a diagrammatic picture. That's it. S3 and opening snap are early diastole. So this is what you should be doing in your last 15 days. You should integrate everything. So you'd be learning in MS that there will be opening snap, in aortic stenosis that there is ejection click, in constrictive pericarditis that there is pericardial knock, and in cardiac myxoma you'll be learning that there is tumor plop. Everything should come together. You should organize everything. If possible, make a notes. If you have already made a notes, that's very good. So these things, if you note down in a single page, everything integrated and writing in a same area, you would remember, and it will be easy for you to remember, revise. If there is one more chance to revise, it's good, right? So this is what your last minute revision notes should look like. You should not go on reading everything again. Yeah, you have your notes, but you should not read everything again. And pathophysiology, you have already a good idea of the pathophysiology. You have read and revised it. Again, you should not go into the details of everything. Wherever you tend to forget and whatever correlation can happen, do that and just read it. You should do a fast revision. For suppose first reading you have done medicine, you have done 7 days or 14 days first reading. Now in first revision and second revision, you have done it in 4-5 days. So now last minute revision medicine should be 1 to 2 days only. Because in this last 15 days, you should revise everything. Every subject you should revise. Whatever you have read should be revised, especially the things you tend to forget. And whatever are the volatile subjects, the volatile subjects differs for some. Some feel biochem is volatile, some feel forensic is volatile, some feel surgery is volatile. Whatever is volatile, just read 1 to 2 days before the exam. Better retention, that's it. And whatever you're confident, read it just before 1 week. So pulse, JVP, cardiac auscultation, which parts to concentrate. We are done with it. Next important thing is your ECG. So in ECG, he can give you the arrhythmias. See, whatever it is, emergencies are always important. In any subject or any topic, if it is an emergency, it's important. Arrhythmias are emergency. At least you should be able to identify the arrhythmia. That is what he wants. So examiner wants you to identify the arrhythmia. And what is the immediate management you want to do? So identify whether it's supraventricular or ventricular. In supraventricular, it's AF or atrial flutter or multifocal atrial tachycardia or paroxysmal supraventricular tachycardia. In ventricular tachycardias, mostly he'll be giving VTs and VFs. So these are the important ECGs. Among them, AF is very important. AF, he can give JVP correlation, he can give pulse deficit correlation, he can ask you in what are the anticoagulant part of AF, rate control of AF, rhythm control of AF, all these parts. AF you should read in more detail because AF is most important among all these things because AF is the most common arrhythmia you'll be seeing. So remember this, any topic, if it's an emergency, most common emergency, that can be a probable question. That is the important topic. Do not miss it. And one more important thing. So some students will be asking, should I read that topic, this topic? See, the main essence of NEET-PG is you should know everything. Everything, basic knowledge you should have. That is what he's testing. One topic you are reading too deep, but other topic you are leaving it, you are doing injustice. But both topics you have read the important parts, that's what you are doing justice. So this is what is smart reading. If you want to read everything in deep, your PG preparation period won't be enough. Then you have to do post-graduation. That is what it is for. So do some smart study, know your limitations, don't go deep and don't look for multiple materials on the same topic. It's really wasting time, because any material you see, it's the same concept, right? Especially in this last 15 days, don't go for new materials. Whatever you have read, revise, and any important topics you have missed it, just go for a superficial important parts of those topics. Okay, now coming to ECG. He'll be asking you about named waves, like your Osborne waves, epsilon waves, and atrial enlargements, left atrial and right atrial enlargements, and he may give you ECG of bundle branch blocks. Next, special ECGs, for suppose he can give low voltage complexes like this, and in which condition it's seen, or he can give you a clinical scenario of cardiac tamponade in heart. Along with this ECG and basics, ECG, pulse, JVP, the pericardial diseases are very important. Do not forget to revise them. That can be correlated in any way. So he can give a disease, MI and pericardial diseases mostly. And that what are the ECGs and arrhythmias. Most commonly he'll be asking tachy. Tachy more than brady are important. And in tachy, your supraventricular tachycardias are very much important, and ventricular, in that AF is important. So these things you should be covering. Okay, let's take the question and we'll be looking all these important topics. Low voltage QRS complexes on ECG are seen in. So in pulmonary embolism, what is the ECG? How is the ECG? So pulmonary embolism, there is a thrombosis in your pulmonary artery. So the blood flow to your left heart is decreased. So the preload is decreased. So to maintain the ejection fraction, the heart rate will increase. So there will be tachycardia, sinus tachycardia on ECG. That is most common. One more sign, it's rare to find, but if you find that, it is more specific to pulmonary embolism. What is that? S1, Q3, T3. S wave in lead 1. Q wave and inverted T wave in lead 3. So this is most specific for pulmonary embolism. Yeah. Pericardial effusion. What can be the ECG signs? There can be low voltage complexes, because what is ECG? It's measuring your electrical activity of the heart. But between the leads and your heart, there is something which is decreasing or impeding the conduction. Here, that is water in the pericardial area. So low voltage complexes. What do you see in cor pulmonale? So cor pulmonale is nothing but due to chronic lung disease, there is increased pressures in your pulmonary system resulting in right heart failure. So chronic lung disease resulting in right heart failure is nothing but your cor pulmonale. So all right heart features, right heart abnormalities you will be seeing, like right axis deviation, right bundle branch block. And what is the P wave you will be seeing in cor pulmonale? P pulmonale, right? Tall peaked T waves or Himalayan P waves. And in infective endocarditis, what are the ECG changes? You cannot specifically say these are the ECG changes. If there are some valvular lesions, there can be ECG changes according to that, but there are no specific ECG changes. If there is this ECG changes, this is infective endocarditis. There is nothing specific. Okay. Now, low voltage complexes are seen in pericardial effusion. That thing we know. But what exactly is low voltage complex? So he'll give this ECG as a question. You understood that this is a low voltage complex. And in the options, he can give you the definition. Less than 5 mm, less than 10 mm to 15 mm. So you should know. Less than 5 mm in limb leads. And less than 10 mm in chest leads. The chest leads or the precordial leads are V1 to V6. In V1 to V6, the QRS complex, the amplitude should be less than 10 mm. Whereas your limb leads 1, 2, 3 and AVR, AVL, AVF, it should be less than 5 mm. 5 mm. So definitely there are low voltage complexes in this ECG. Also, there is associated LBBB with T-wave inversions in V6, but he's asking about low voltage complexes in this question. This is low voltage complex plus LBBB, this ECG. So where do you see low voltage complexes other than your pericardial effusion? So first thing is, between your heart and the chest wall, the gap has increased. Or something is infiltrating into your myocardium, so the conduction has been impeded. So the complexes, the QRS waves are due to conduction, it's due to electrical activity, right? But that electrical activity has decreased. So increased gap, it's seen in obesity. So obese individuals also, there can be low voltage complexes, and these all can be in the questions. So everything I'm saying is a key point. Pericardial effusion, and the effusion significant enough to cause diastolic failure is cardiac tamponade. In emphysema, the lungs are inflated, severe emphysema. Sometimes in pleural effusion, massive pleural effusion, sometimes. So these are the conditions. And decreased electrical activity in restrictive or infiltrative cardiomyopathy. Something is infiltrating your myocardium, like amyloidosis, sarcoidosis, and dilated cardiomyopathy. Okay. So here one question which can be a possibility is, normally in LVH, left ventricular hypertrophy, there will be high voltage complexes, right? There will be increased voltage. There will be increased voltage QRS. But LVH plus low voltage complexes are seen in. So if you do a 2D echo, there is LVH. But if you do a ECG, there is low voltage complex. What can be the probability? And the cause is in this. The answer is in this causes only. It is seen in amyloidosis. So basically what is happening in amyloidosis, there is extracellular deposition of this amyloid hyaline material. Because of this deposition, the thickness of the myocardium is increased, which will be appearing as LVH on 2D echo. whereas that deposition will impede the electrical activity, resulting in low voltage complexes in your ECG. So this is one exception and a possible question. And even in hypothyroidism, you will be having low voltage complexes. So this part we have seen. Let's look into atrial enlargements and bundle branch blocks. So what is the best lead to look for atrial enlargement? That would be lead 2 and V1. Why lead 2? Because lead 2 is in the axis of the heart. So this is lead 2 and your heart is like this. This will be lead 3. AVF, AVL, AVR. So these are the leads. 1. So the conduction of the electrical activity is in the direction of 2. That is the reason 2 is the best lead. So everything I'm speaking is a question. They can ask you why is lead 2 is the best to assist for P wave. And in AVR, it's exactly opposite to the heart. So everything is negative. Your P wave is negative, your Curate complex is negative, your T wave is negative. Negative waves in AVR is normal. And this is the reason for this negative waves in AVR. Coming to lead 2, normally there is a uniphasic wave P wave in lead 2 and a biphasic P wave in V1. Coming to right atrial enlargement, you can see tall peaked P wave in lead 2 and increased positive component of V1, P wave in V1. Whereas left atrial enlargement, you can see bifid P wave in lead 2 and the negative component of P wave has increased in lead V1. So not just, we'll be mostly concentrating on lead 2, but V1 also they can ask a question, but it's very simple to remember, nothing complicated. This is tall peaked, this is bifid. So left atrial enlargement is seen in mitral stenosis. So this bifid P wave is called P mitral. Right atrial enlargement is seen in cor pulmonale. Hence, this tall peaked P wave is called P pulmonale. So, Dr. Sara, I did not get your question. Is this normal condition? Write your question in detail. So this is about atrial enlargement. Next look into bundle branch blocks. So bundle branch block, this is your SA node to AV node. This bundle of his, which will be dividing into right bundle, left bundle, and dividing as Purkinje fibers. So the bundle branch can be left bundle branch block or right bundle branch block. How do you identify right bundle branch block? In V1, there is RS, R dash pattern or M wave. So rather than M wave, the most clinical, better thing to name it as RS, R dash pattern. Whereas in LBBB, in V1, you will be seeing W pattern. In V6, it's M. Here it's opposite. In V6, it's W pattern. One more important thing is, When do you call it as complete LBBB and incomplete LBBB? It's just based on the duration. See, the pattern is same. If that pattern is there, you call it as LBBB or RBBB. If the duration of QRS complex is 0.1 to 0.12 seconds, then that is incomplete bundle branch block. If it is more than 0.12 seconds, then it is complete bundle branch block. More than 1.2 seconds means more than 3 small boxes. So each small box is 40 milliseconds, 0.4 seconds, right? So it's more than 3 small boxes, then it is LBBB. So the durations you have to remember in seconds and in boxes also. If you know the easy conversion, it's okay. In exam, if you can do it, because in that stress, doing calculations is very more stressful and you can do mistakes. If you can do the conversions, it's okay. Otherwise, remember both. They can ask you in either way. And one more important thing, in atria, the normal P wave should not be more than 2.5 boxes, either in amplitude or duration. Amplitude or duration, it should not be more than 2.5 boxes. So these are the important things in the ECG about the chambers of the ECG, chamber enlargements showing on the ECG. Now let's look at arrhythmias, which are the most important part. So I told you supraventricular tachycardias are more important. So first we'll solve the question. Every topic will be solving the question. Okay, after that only we'll discuss. So from this question we'll take up after a short break.
Ethyl alcohol 95% or the more common.
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here
The wall of the forebrain.
Okay, sorry for the interruption. So we'll be continuing it. So every topic we'll take up the question first, and then we'll be looking into the important things, because doing question is more important now. You have just 15 days for your exam. So let's take the question. All are the ECG findings in Wolff-Parkinson-White syndrome, WPW syndrome. So what do you think it is? It's a arrhythmia or it's a pre-excitation syndrome? So we'll look at the options. So I asked you one question, is it arrhythmia or a pre-excitation syndrome? Based on that, only these options will be depending. So we'll see first the options. Narrow QRS complex. Okay, maybe. Normal QT interval, slurred and tall QRS, and short PR interval. So definitely this is a pre-excitation syndrome. And the ECG of this will be, the P wave is normal. The PR interval is shortened, because the PR interval is nothing but AV nodal conduction. But here, the conduction is not by AV node. There is an aberrant pathway through which more fast conduction is happening. In AV nodal pathway, there is AV nodal delay, right? Some delay, refractory period will be there. But this aberrant pathway, there is no refractory period, more fast conduction. So the PR interval will be shortened. And after that aberrant conduction, initially in the ventricles there will be some aberrancy, but the bundle of His and all the pathway is normal, right? But later the QRS complex and the T wave, everything will be normal. So initial part of the ventricular depolarization, there will be some blurring. After that, the Q wave is normal, the T wave is normal. Because of that initial blurring, the QRS complex duration will increase. And the PR interval is decreased. QT is normal, because after that the ventricular conduction is completely normal, right? So what he asked, short PR interval, yes, because it's a pre-excitation, aberrant pathway. Slurred and tall QRS, yes. Normal QT interval, yes, because the ventricular conduction is completely normal. Narrow QRS complex, no. Because of the initial aberrancy in the ventricular conduction, there is a small slurring of the upstroke of the QRS complex. That is the reason the QRS duration will be slightly increased, not narrow. So narrow means it's less than 0.10 seconds. It's narrow. So this initial aberrancy, what do you call that wave as? So you can see here clearly. The P wave is normal. There is no PR interval only. It's very short. And the initial aberrancy in the QRS complex, you can see that the QRS complex duration is increased. But after that, everything is normal. What do you call this part? It's a delta wave. That initial aberrancy with a slurring in the upstroke of QRS complex. See, there is a slurring in the upstroke of QRS complex. That is delta wave. That is seen in WPW syndrome. And a few important things about WPW syndrome. What is that aberrant pathway called? It's called bundle of Kent. So because of that, it's a pre-excitation syndrome, and because of that pre-excitation, there can be arrhythmias, mostly AV nodal re-entry tachycardias. Pre-excitation resulting in tachyarrhythmias, that is how they can present. So there can be underlying abnormalities, some electrolyte abnormalities or structural abnormalities, but most of the people, the heart will be normal. So some other named waves, where do you see Osborne wave? Epsilon wave. Osborne wave is nothing but J point elevation. You'll be seeing it is the most specific sign of hypothermia. You can also see it in hypercalcemia. What is the other ECG sign of hypercalcemia? Shortened QT interval. Hypocalcemia, prolonged QT interval. Epsilon wave, what is epsilon wave? What is Osborne wave? J point elevation. So this is very important. They'll give you an ECG. In ECG, you have to identify what is J point. So this is J point. The QRS is ending and the ST segment is starting. That is J point. At the J point, you will have a wave or you will have elevation. That is called Osborne wave. Epsilon wave. So after QRS, there will be normal P wave, normal QRS. But after QRS, there will be some slurring followed by normal ST segment and T wave is epsilon wave. Slurring after Q wave. It is seen in arrhythmogenic right ventricular cardiomyopathy. It's due to delayed depolarizations. The conduction through the right ventricle is impaired. That late conduction is what's seen as a slurring in the end of the QRS complex. That is called epsilon wave. So these are the named waves. Now looking into other arrhythmias. Can be tachyarrhythmias or bradyarrhythmias. So in supraventricular tachycardias are most important, so we'll see them. So among them, AF and MAT. This differentiation you should know. So first thing, tachy or brady, that thing you can identify on ECG. If the rate is more than 100, definitely it's tachy. In tachyarrhythmias, how do you know whether the origin is supraventricular or ventricular? It's just the QRS complex. If the QRS complex is narrow, it's supraventricular. If it's broad, that is more than 0.12 millisecond, it is ventricular origin. So just by seeing the ECG, now you have identified its tachyarrhythmia, the origin is supraventricular or ventricular. In supraventricular, if it is irregular, it's mostly AF or MAT. So in AF, there is no P wave. There are fibrillatory waves. In MAT, there are P waves. But the morphology of P waves, more than 3 morphological P waves are seen. There are P waves, but the P waves are not identical. The morphology of a single P wave will be different. So if the P wave is nothing but atrial depolarization, right? So if the origin of the impulse is from the SA node, every P wave should be same. But the P wave morphologies are different, means there are multiple ectopics. Coming to multifocal atrial tachycardia. The name itself says atrial tachycardia and it's multifocal. That's why more than 3 P wave morphologies, and it's seen in COPD. In COPD, there is inflammation. Due to chronic inflammation, the inflammatory cells will act as a pacemaker in the atrium, resulting in ectopics in the atrium. So multiple P waves, and it's irregular. So these two are irregular. And coming to regular, one is your atrial flutter. So atrial flutters, most of the times they are regular. Sometimes, whenever there is variable AV block, it can be irregular. But how to differentiate? In atrial flutter, there will be multiple P waves. Those are seen as sawtooth P waves, followed by a QRS complex. Multiple P waves followed by a QRS complex. See, this is a P wave. Whereas in atrial fibrillation, there is a fibrillatory wave. Fibrillatory wave. QRS complex. Fibrillatory wave. QRS. Fibrillatory wave. QRS. And that QRS is irregular. So now you got the difference between fibrillatory wave, that is AF, and atrial flutter. So these are sawtooth P waves. Why the difference? The difference is also important. In atrial flutter, it's a single macro reentrant ectopic. It's a single ectopic in atrial flutter. Whereas AF, there are multiple micro-reentrant ectopics. So multiple small waves, fibrillatory waves, single macro reentrant, so single large P waves, and they're of same morphology. Whereas MAT, multiple ectopics, hence multiple morphology P waves. So most of the times AF and atrial flutter, they can be coexistent. Atrial flutter can progress to AF. AF can decrease to form atrial flutter. But in exam, mostly they'll give you a clear X-ray. In next thing, paroxysmal supraventricular tachycardia. So this paroxysmal supraventricular tachycardia, you cannot see P waves because the QRS complexes are overlapping on the P waves. Just you can see is narrow QRS complexes. Tachycardia with narrow QRS complexes and no P waves, that is PSVT. And the patient will present with palpitations and post palpitation diuresis. This is very important. The question will have these key points: elderly female with palpitations and post palpitation diuresis, and they can give this ECG. What is the diagnosis? That can be the question. So whatever I'm saying is the key point. And explanations are also important because they can ask that why there is post palpitation diuresis. So because of tachycardia, there is atrial natriuretic peptide which is released. So natriuresis, sodium and water lost in the urine, resulting in post palpitation diuresis. And this PSVT responds to carotid sinus massage. Have you seen a case of PSVT? Mostly in your EMDs or AMCs. The PSVT case, we'll be advising the patients to do carotid sinus massage, and next thing we'll be doing is adenosine. Have you ever seen the administration of adenosine? Adenosine is very short acting. We'll give IV adenosine. Immediately following that, we'll give flush, and whatever limb we have given adenosine, we'll be keeping it in the upright position to increase the blood flow, because that adenosine should reach the heart, right? So it's very short acting. So immediately after giving adenosine, we'll give some flush so that the adenosine reaches the circulation very fast, and the limb will be keeping in the upright position. And after giving adenosine, just will look for 1 to 2 minutes. We'll repeat the ECG, no improvement, repeat adenosine. Like that, we can give it for 3 times. No improvement, will not give adenosine. And what are the complications of adenosine? That can precipitate seizures, that can precipitate your bronchoconstriction. So look for those things. If the patient is already known case of seizures, giving adenosine can precipitate seizures. So be careful. Not responding to adenosine, you can give beta blockers. So any supraventricular tachycardia, you can give beta blocker, calcium channel blocker. Why? Because these are AV blocking agents. The origin of tachycardia is supraventricular. Now you have blocked AV. Those impulses are not coming to ventricle, and the ventricle rate will decrease. So beta blocker, metoprolol, and calcium channel blocker, verapamil or diltiazem. Diltiazem is better for rate control. So metoprolol is a cardioselective beta blocker. So what is cardioselective? It should act on beta 1. Is it cardioselective beta blocker, and what are the other cardioselective beta blockers? So while revising medicine, you should also correlate pharma, micro, your pathology. So everything you should correlate, anat, physio. So that will be integrated learning and you will remember it better, and in exam also you can connect the dots easily because most of the questions will be integrated questions only. They will not ask simply an anat question, simply a physio question. So what other are your cardioselective beta blockers? It's very easy to remember cardioselective beta blockers. It's car, bus, metro. Your carvedilol, bisoprolol, and metoprolol. So these are the cardioselective beta blockers. Here we are using cardioselective. I don't want other actions. And non-cardioselective beta blockers, what are the contraindications? Asthma and peripheral vascular disease. Especially for suppose COPD is landed into MAT, multifocal atrial tachycardia. Avoid non-selective beta blockers because they will cause bronchoconstriction and aggravate the condition. Better use selective beta blockers or go for calcium channel blockers like verapamil or diltiazem. In AF also, for rate control, you can use both beta blocker or calcium channel blocker. Both are efficacious. So this part we are discussing about SVTs, right? Most important parts of AF. AF can be age related. So age is one of the risk factor. And one more important thing you have to look into is AF can be valvular AF or non-valvular AF. So valvular AF only when there is severe MS. Mild MS with AF, it's not valvular AF. And there is prosthetic valve. Non-valvular, no valve pathology, but there is still AF. You have to look for electrolyte abnormalities, mainly your potassium and thyroid. Even hyperthyroidism can cause your AF. So if you have seen the evaluation of a case of AF, they'll send for electrolytes and thyroid profile in AF case, to rule out those causes, right? And they'll do a 2D echo. Why? To look for valvular AF. And yes, you can auscultate in AF. You can say yes, MS, you can auscultate and look for mid-diastolic murmur, right? In a case of AF, it will be very difficult to appreciate a murmur, especially. So this AF can be controlled. The rate can be controlled with irregular AF or uncontrolled. Uncontrolled, you have to act immediately. So in exams, they'll be keeping MS case mostly, right? In our practical exams. So you can hear or cannot hear those murmurs and sounds are purely subjective. Only your professor can hear those sounds and you have to just say yes, right? So one simple thing to escape is if you ask why didn't you hear, patient is in AF, so that's why I did not hear. That is just an escape way for us to escape from MS case. Anything if he asks why didn't you listen, patient is in AF, that's what we used to say in our PG. Because only professor will hear those murmurs, we cannot hear. Because they have seen many cases of valvular diseases. Previously, valvular diseases, the rheumatic heart disease was very common. The ward was full of valvular cases. But in our time, the cases have reduced. We used to search for valvular cases. We used to go to cardio and ask HOD, cardio HOD permission. Any valve cases are there? Please show us, because they'll put in the exam. For exam, they'll definitely find a case. But to learn, we don't find a case. That is what the scenario with valvular cases. I am telling all this story because there are some good memories and those will help you to remember. You'll remember for a longer period if you have some emotional component to that, right? Okay. Now we are discussing about AF, right? So AF can be rate control, the management of AF, rhythm control. Which is best? Both are equally efficacious. But you and patient, doctor and patient should discuss and come to a conclusion that this is the best. So rhythm control, young patients and paroxysmal AF. Young patients, no comorbids, no valvular lesions. This AF is for a shorter period. You can go for rhythm control. But elderly with longer periods of AF, prolonged AF, better go for rate control. Rate control we already know, beta blocker and calcium channel blocker. You can also give digoxin. Digoxin is a vagal stimulator which will inhibit the AV node. Digoxin is just for ventricular rate control. Next, coming to the rhythm, you can do cardioversion. Or you can go for antiarrhythmic drugs. Cardioversion, electrical cardioversion, you are going to shock the patient. So this patient he's conscious, he's stable, so you have to sedate him, counsel him, give anesthesia, that is sedate him and shock the patient. And antiarrhythmic drug, best chemical cardioversion is ibutylyl. Not available, you can use amiodarone. So this is about AF. And one more important thing is, do not confuse between cardioversion and defibrillation. So cardioversion, here we are doing in a stable patient. He's conscious, we are sedating him and shocking him. Here they are synchronous. With QRS, with R wave, whenever there is R wave, you are giving a shock. Whereas defibrillation is not synchronous. This you will be doing in cardiac arrest. Patient is in cardiac arrest. Unconscious patient, you have done many times. Unconscious patient, cardiac arrest, you have done CPR, you have defibrillated him in your EMD, right? So cardiac arrest, unconscious patients, you are going to do defibrillation. There you are not going to look for QRS complexes because you won't find any QRS complex only on the ECG, right? There can be VFib or like improper complexes, bizarre complexes can be seen. There you cannot give synchronous. Sometimes there can be pulseless electrical activity. In pulseless electrical activity, that is no pulse but still electrical activity, you should not shock. The shockable rhythms are only VT and VF. So defibrillation is asynchronous in cardiac arrest. Cardioversion is synchronous. You'll be giving in stable patients, stable arrhythmia patients. Okay, one more important thing about shock is any patient of arrhythmia in shock. This is the most common clinical question they'll ask you. They'll give you some clinical scenario, some arrhythmia, any arrhythmia it is. If he is in shock, that is hypotension, the next step you have to do is shock the patient. That is, you have to give cardioversion. So this is the management of AF. And one more component you should not miss is anticoagulants. Valvular AF, you should give, every one of valvular AF should receive anticoagulants. Whereas non-valvular AF, you look at a score. What is that score? In non-valvular AF, based on what score you will be giving? Yeah, it's Chadwick score, right? Based on Chadwick score, more than 1 in females and more than or equal to 2 in males, you will go for anticoagulation. And coming to valvular AF, we'll be giving conventional anticoagulants only. Because newer anticoagulants, there are no studies yet, that's why. That is heparin bridged by warfarin. Whereas non-valvular AF, it's patient wish. Warfarin has many side effects. We can give warfarin or novel oral anticoagulants like dapigatran, rivaroxaban, apixaban. So warfarin is cheaper. This NOACs, that is newer oral anticoagulants, are some costlier. They have to take daily, right? So it's important to look at the cost also. So it's patient wish, they can take anything. But warfarin, more side effects. Side effect is bleeding. So this is about AF, most important supraventricular tachycardia. And coming to VT and VF, most of the times the patient will be presenting to you in shock only. So first you have to do cardioversion, or if he's in arrest, cardiac arrest, give defibrillation, followed by antiarrhythmic drug. Next, bradyarrhythmias, AV block. So do not miss to see the ECGs of primary, secondary, and third degree AV blocks. So this is about arrhythmias, the important parts of arrhythmias. Next, coming to congestive heart failure and PCWP. This is the next important topic in cardiovascular system, is heart failure. So congestive heart failure and pulmonary capillary wedge pressure. So every topic we are doing question the same way we'll do it. Left atrial filling pressures closely approximate. So your pulmonary artery, pulmonary capillaries, pulmonary vein opening into the left atrium, right? Next, left ventricle. Here pulmonary capillaries are opening. The pressure here is pulmonary capillary wedge pressure, right? So one thing you have to remember is your pulmonary capillary wedge pressure is equal to left atrial pressure is equal to left ventricular end diastolic pressure. When there is no obstruction, for suppose there is MS, the pressures will change. The left atrial pressures and pulmonary capillary wedge pressures will increase. And with no obstruction, all these pressures are same. So by measuring your pulmonary capillary wedge pressure, you would indirectly know the pressure in your left atrium. Okay, if the left ventricle is failing, obviously the pressures due to back pressure, the ejection fraction is not good. So there is increased blood which is pulling in the left ventricle. The end diastolic volume will be more. So that pressure you are indirectly measuring with pulmonary capillary wedge pressure, and it's increased in heart failure. So how do you measure? You will insert a catheter to through the jugular vein, right atrium, right ventricle, into the pulmonary artery, into the pulmonary capillaries. That is how you are going to measure. So coming to heart failure, the important things they'll ask you in heart failure is left ventricular failure, right ventricular failure. You should be clear between the signs and symptoms of left and right ventricular failure, and the drugs. Which drugs have mortality benefit, which drugs do not have mortality benefit. So these are the important things they'll be asking in heart failure. So left heart failure, right heart failure. So what are the signs and symptoms of right heart failure? Right heart failure, patient will have elevated JVP. That too increased A wave. I told you myocardial problem, positive waves are abnormal or exaggerated. Next thing, and this increased JVP is pulsatile. See, some options are non-pulsatile, just be careful. And there can be pedal edema followed by ascites. Just gravity dependent edema, that's it. And there will be congestion of your liver and spleen. So congestive hepatitis or hepatomegaly or splenomegaly and splenomegaly. So these are the features of your right heart failure. So patient is complaining of pedal edema followed by ascites and JVP is elevated. Right heart is abnormal. Now coming to left heart failure. Here it's because of pulmonary edema. So left heart is failing, the pressures are being directed to your pulmonary artery, right? And into the lungs. So there is exudation of fluids into the lung resulting in pulmonary edema. So patient will have SOB. Shortness of breath will be the most common feature here, and that too orthopnea and PND, paroxysmal nocturnal dyspnea. And this paroxysmal nocturnal dyspnea, that is during nights, after sleeping, 2 hours after sleeping, patient will have dyspnea. He'll have air hunger, go to a fan or window, and after few minutes, like 20 minutes, his SOB will decrease. That is paroxysmal nocturnal dyspnea. It's most specific for LV failure. If orthopnea is there, okay, LV failure can be there. It's most sensitive. But other causes also cause orthopnea. But P&A is there, it's definitely left heart failure. And what are the other signs of left heart failure? That's it, all the pulmonary symptoms. And if you auscultate, you will be having bilateral fine crepes because of pulmonary edema. You can hear S3, S4. Okay, this is called gallop rhythm. Like when horses are galloping, like 4 toes, tuck, 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 like that, gallop rhythm, very fast tachycardia with S1, S2, S3, S4. You'll be hearing it's like a gallop rhythm. Gallop is present in left heart failure. These are the signs of left and right heart failure. Now coming to the drugs. So coming to the drugs used in heart failure, first you should know the pathophysiology. So in heart failure, few things are happening as a compensation. Your heart is not failing. To improve the cardiac output or to increase the ejection fraction, few compensatory mechanisms are happening. In that, few are good, few are bad. Bad things you will be blocking, good things you will be promoting. That's what we are doing in the drugs. So your sympathetic nervous system is activated. Next, your renin-angiotensin system is activated. And there is increased pressures in your heart, right? So your atrial natriuretic peptide, all the natriuretic peptides are increased. So this sympathetic nervous system and RAS, they will cause more tachycardia, more vasoconstriction, resulting in increased afterload. So they are doing more damage. So we have to block these things. Whereas your natriuretic peptide, natriuresis, some fluid is, so it's all about pedal edema, fluid overload we are discussing, right? So there is some fluid loss through natriuresis, that is good, right? So we have to promote it. So what are we doing? We are giving beta blockers here. Here ACE inhibitors, your ARBs, we are using here. And mineralocorticoid receptor agonists like spironolactone. So the ultimate product is aldosterone, right? So that ultimate product we are inhibiting. Next, ANP, ARNIs, angiotensin receptor and nephrilizin inhibitor. So what is this nephrilizin? Nephrilizin will cause degradation of your natriuretic peptide. So we'll be inhibiting that degradation by nephrilizin inhibitor. So both angiotensin receptor and nephrilizin inhibitor, that is called ARNI. This is a new component. And this is the drug of choice. It is sacubitril valsartan. So sartans is nothing but ARBs, right? And sacubitril is a nephrilizin inhibitor. This is the drug of choice. So the best drug to use is ARNIs. Not available, go for AC inhibitors followed by ARBs. These are the best things. And beta blockers, see, all these have mortality benefit. Because they are acting on the pathophysiology. Your spironolactone, your telmisartans, your prils, ramipil, captopril, your AC inhibitors, your cardioselective beta blockers, and ARNIs have mortality benefit. And one more thing that has mortality benefit is SGLT2 inhibitors. That is your glifosins, dapagliflozin, empagliflozin. Actually, by inhibiting the SGLT2, they will promote the glucose and water loss from the urine, right? This is for reabsorption of glucose, but the reabsorption of glucose is not happening, it's lost in the urine. Actually, previously, SGLT2 inhibitors were used only for diabetes or diabetic with heart failure. Now they are approved for heart failure. Even without diabetes, there is heart failure. SGLT2 inhibitors can be used. This is a new update. SGLT2 inhibitors can be used and they have mortality benefit. And one more thing, your loop diuretics, that is furosemide. Whenever a patient of acute heart failure with pulmonary edema comes to you, you will use loop diuretics just for symptomatic management, and your loop diuretics, that is furosemide, have no mortality benefit. Yes, you will use it as a treatment in acute phase, but no, it doesn't have mortality benefit, only symptomatic. Okay. So these are the drugs in heart failure, and left and right heart failure, pulmonary capillary bed pressure is increased. We are done with heart failure. So next topic we'll see valvular heart diseases. The most important valvular heart diseases are MS, MR, AS, AR. Okay. So before going into this question, somebody has asked, can we use morphine in heart failure? See, morphine, what is morphine? It's an opioid derivative, right? You will be using it for pain management in MI. In MI also, it doesn't have mortality benefit. Just for pain management in MI. In heart failure, morphine doesn't have any role. So these are the important valvular lesions. And most common cause of all these valvular lesions are rheumatic heart disease. So one important thing you have to remember is regurgitations will present with palpitation. So volume overloads can present with palpitations. So each valvular disease have each set of symptoms. What are those symptoms? We'll see. In this question, we are discussing one valvular disease. What is that? Triad of angina, syncope, and heart failure. Where do you see this triad? Angina, syncope, and dyspnea. This is a typical triad of your AS. The name itself says it is AS. And it progresses like that also. In AS, initially there is angina. As the disease progresses, there will be syncope. As the disease progresses, there will be dyspnea. Why angina and syncope? The blood supply to your myocardium, the coronary arteries are coming from the aorta. There is aortic stenosis. So the coronary supply is also decreased, resulting in angina. The same thing, syncope. Dyspnea is due to left heart failure. Which of the following sign is seen in severe disease? The opening snap. The aorta, whenever there is AS, the opening of aortic valve will be heard as opening snap. Opening of aortic valve heard as opening snap. So how much ever severe the AS is, you can hear opening snap. There is no difference in quality. There is no diastolic rumble in AS. AS is ejection systolic murmur. It's not holosystolic murmur. It will have a peak, crescendo, decrescendo, and delayed peak of systolic murmur. Yes, the severe is the AS. So whenever the AS is severe, the pressure will in the LV will build up. And when it's significant to overcome the AS, only then the blood flow will be there. Only then you will have a peak. So how much severe is the AS? The time for the LV to build up the pressure will take time, right? So the peak of your ejection systolic murmur will have a peak. The peak will be more delayed in severe disease. The more severe the disease, the peak is more delayed. So if you see here, the peak is here. Here it's delayed. Here it's more delayed. So the severity of the disease is increasing. So the peak of murmur is important. So this is the typical ejection systolic murmur. And this will have opening snap in systole. In systole, you can hear opening snap. In opening snap followed by this murmur. How do you manage AS? So the causes of AS, I told you it's rheumatic heart disease. One more thing is bivalvular aortic valve. See, aortic valve has 3 cusps. The lesser the cusps, stenosis. Greater the cusps, regurgitation. See, biunivalvular are stenosis. The tetravalvular, pentavalvular go into regurgitation. Okay. And this bivalvular seen in your Marfan's. Turners. Next thing is degenerative, age related. These are the causes of AS. And this is how they are going to present, and this is the typical murmur of AS. And how is the pulse in AS? Pulsus parvus et tartus. So you have to correlate everything, right? Coming to the treatment, if there is severe AS or symptomatic AS, you have to go for aortic valve replacement. So this aortic valve replacement can be transcutaneous or surgical. Surgical is you will be opening. Transcutaneous is transvenous. Through a vein, you will be mostly femoral vein. You will be passing the valve and replacing it. So young patient who is surgically fit. So our anesthesia people will give PAC, right? That this patient is surgically fit. If they give fitness, that is the patient is surgically fit, go for surgical. No elderly patient cannot tolerate anesthesia, not surgically fit, go for TAVR. That's the only difference. If they are fit for surgery, go for surgery. Not fit for surgery, go for transvenous aortic valve replacement. So this TAVR is also a new entity in aortic valve replacement. Not only aortic valves, they are also doing other valve replacements through this method. So that is about aortic stenosis. Coming to the next question, MI or angina. So in MI, you have to know, first thing is artery supply. Not just artery supply, the ECG leads and the walls, whether it's anterior, septal, the location, anterior, anteroseptal, inferior or lateral MIs, those things they can ask you. And the difference between stable angina, unstable angina, NSTEMI and STEMI, you should know. And the management. Just basics of management of MI. These are the most common things they'll be asking you in MI. But one more thing, when there is ST elevation, you know it's STEMI, ST elevation MI. But there are few things without ST elevation, they are almost equal to MI. What are those things? One is your Wellen sign and other is your De Winter's T wave. So what is Wellen sign? See, in leads V2 and V3, you will be having either biphasic or inverted T waves. Biphasic or inverted T waves. In type 1, it's biphasic. In biphasic also, the first component is positive and second component is negative. If it's like this, it's not valence. So you have to remember the components also. And in type 2, it's inverted. So these are valence patterns and they are almost equal to critical stenosis of your LAD. So a patient, you are sitting in the casualty, patient of chest pain or without chest pain also this can occur. You have seen this type of ECG and do not ignore this. They can progress into STEMI. So admit this patient, observe, okay. That is one importance of Wellen syndrome. So it's equal to unstable angina. Next, coming to De Winter's sign. So what is De Winter's sign? ST depression with tall peak T waves. That too sloping. Upsloping ST depression with tall T waves. This is De Winter T wave and this is equal to STEMI. So STEMI is ST elevation. Here there is ST depression, but still it's equal to STEMI. That is De Winter's T wave. Even if you find this sign, you should not neglect it. They are equivalent to your MI. And coming to the ECG leads, your 2, 3 AVF are inferior, right? Your V1 and V2 are septal, right? V3, V4 are anterior wall. V5, V6 are lateral wall. Coming to the management of MI. So you're sitting in the EMD, a case of MI has come to you. Your center is a PCI center. So yours is the tertiary center, there is a cath lab in your center, take it. If the MI was within 6 hours, the chest pain was from last 6 hours, send the patient for cath lab and the wire should pass within 60 minutes. So you should be very fast to shift. Patient has come, you have to identify it as MI and shift to cath lab and the wire has to pass within 60 minutes. And if it's a non-PCI center, do thrombolysis. But when to do thrombolysis? You have to shift the patient for cath lab anyways. If the center is more than 120 minutes to go, do thrombolysis. No, the center is within 120 minutes. Then without giving thrombolysis, send the patient for cath lab. So remember one thing, even after thrombolysis also, you have to send the patient for cath lab. Why? Those details we'll discuss. So it's 1 o'clock. We'll take a lunch break. We'll be back at 2 o'clock, okay?
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Okay, welcome back. So we are doing core 6. So 6 major subjects for your NEET-PG, which you should concentrate in the last 15 days of your preparation, right? In that, one of the major subject is medicine. So in these 6 subjects, almost 60% of the questions in NEET-PG will be covered. So many of you are asking what is the difference between last PYQ session and this session. In the last PYQ session, we have discussed the last 5 years INICET and NEET-PG questions. But here we are discussing the all important topics. So every system, I'm taking every system in that each topic, where to concentrate, which part not to miss. And we are revising it through questions. So this is like a last minute revision. I'm not teaching you the whole medicine, just reminding you where to concentrate if you have missed anything so that you can focus there. So if you've already done revision, this is the best chance to revise it again, and whatever you have missed, you can concentrate there. You have not read medicine till now or just given one reading also, it's good, it's suitable for you so that you can do a short quick revision of medicine. Okay. So let's continue. We are in the management of MI, right? So MI case comes to your EMD. If your center is PCI center or your center has cath lab, if the chest pain was within 6 hours, send the patient to cath lab. You should not do anything. You can give loading dose of aspirin, clopidogrel and atarvas. After this, you can shift the patient. So these are the loading doses you will be giving, right? Your center is not a PCI center. You can shift the patient to PCI center if the patient can go to that center within 120 minutes. No, the PCI center is very far. You have to do IV thrombolysis. I'm speaking the scenario of within 6 hours. Do IV thrombolysis and send to cath lab. Even after doing thrombolysis, why cath lab? See, this is the artery. In artery, there is a atherosclerotic plaque. This plaque has ruptured and there is thrombus here. That's the reason there is decreased blood supply and myocardial infarction. You have given thrombolysis, very good. That will clear this thrombus. But what about the plaque? That plaque can still rupture, displace, causing reinfarction, right? So even after thrombolysis, you have to refer the patient to cath lab. Okay, these timings are important. Next thing, which thrombolytics you use? Alteplase, reteplase and tenecteplase. These are the thrombolytic agents you can use. Why 6 hours? You can do until 12 hours also, but not more than 12 hours. Why? Because there will be reperfusion injury. Okay, these are the things you should concentrate in MI. Let's go to the next topic. Pericardial diseases, the most important topic of cardiovascular system. So in pericardial diseases, there can be questions from acute pericarditis, cardiac tamponade, and constrictive pericarditis. So just by doing the pulse, JVP, ECG, we have discussed all the features of cardiac tamponade and constrictive pericarditis. What are the ECG features? What is the JVP? What is the pulse? Everything we have discussed, right? So we'll do the question and discuss the pericardial diseases. Case of RTA, multiple rib fractures in the EMD. On examination, there is tachycardia, hypotension, and visible distended veins in the neck. So obviously there is a RTA, blood loss. So tachy and hypotension is explained by hypovolemia. But why distended veins in the neck? On further examination, the bilateral air entry is good. Heart sounds are barely audible. See, these patient with rib fractures, tachycardia, hypotension, they have suspected pneumothorax or cardiac tamponade. Because there is suspected pneumothorax, they have looked for air entry and it's good. If the air entry is absent and the chest movements on one side of the chest are absent, you should suspect pneumothorax and immediately you have to do needle decompression in the mid-clavicular line, left fifth intercostal space, followed by ICD insertion, right? Here, the heart sounds are barely audible, muffled heart sounds with distended neck veins, hypotension, Beck's triad. So we are discussing about cardiac tamponade. So in this clinical scenario, he can ask what can be the JVP, what can be the X-ray, what can be the ECG, all these things he can ask. So because this is a cardiac tamponade, the fluid around the heart compressing the heart, so you have to go for pericardial tap. So urgent pericardial tap, only that will decompress your heart and your BP will increase. So coming to cardiac tamponade, how does the X-ray look like? What is this? What is the sign on X-ray? Money bag appearance. And how is the JVP? We already discussed this in JVP. X wave and Y wave. What happened to the Y wave? It's absent, right? X wave is more prominent. And in 2D echo, see, you can see this pericardial effusion. In that pericardial cavity, your heart is swinging. And one more important thing, in cardiac tamponade, there are low voltage complexes, yes, but there is electrical alternance too. There are low voltage complexes in both cardiac tamponade and pericardial effusion, but electrical alternance is only seen in cardiac tamponade. So you should be more clear. You know things, but you should be more clear because every bit, every mark matters, right? To achieve our dream branch. So this is cardiac tamponade. So the presentation, the investigations and the treatment, everything has been discussed, right? Coming to acute pericarditis, there are ST segment elevations. There is ST elevation in acute pericarditis and MI. You should know how to differentiate it because there can be a question and you have to know how to differentiate it. So in acute pericarditis also there is chest pain which will be radiating to the trapezius and the chest pain will increase on movement. On ECG, there are ST elevations, but it's seen in all leads and concave ST elevations. Whereas your MI, the chest pain, can radiate to the shoulder, back, or to the jaw. It can radiate anywhere. And it doesn't increase on movement, it increases on exertion and decreases on rest and nitric oxide, right? Nitrates. And coming to the MI ECG, you can see the ST elevations only in concomitant leads. For suppose in inferior leads, 2, 3 AVF. For suppose in anterior leads, V1, V2, V3, V4. So in concomitant leads and corresponding leads only you can see ST elevation, and you can also see the negative deflections. Okay, this is how you differentiate acute pericarditis versus MI clinically and on ECG. And one more thing is, there is TP segment depression in acute pericarditis. So in acute pericarditis, you have to know one more thing is post-MI pericarditis. So this post-MI pericarditis can occur within 1 week or can occur after 3 to 4 weeks. So within 1 week, only when there is transmural inflammation, for suppose only if there is subendocardial inflammation, that is NSTEMI or unstable angina, post-MI pericarditis is not a complication. Only when there is a transmural infarct, there is inflammation under the pericardium resulting in pericarditis. For this post-MI pericarditis within 1 week, you don't have to do anything. Just increase the dose of NSAIDs. Patient is already using aspirin, increase the dose of aspirin. And here steroids are contraindicated, because the myocardial tissue is just healing. The steroids will interfere with the healing. Whereas after 3 to 4 weeks, the post-MI pericarditis is autoimmune in nature. The myocardial tissue is necrosed and has been exposed. The antigens are exposed to that. Now there are antibodies. Now they are damaging it. It's due to autoimmune. And it is called post-autoimmune post-MI pericarditis after 3 weeks is called Dressler's syndrome, right? And for this, the treatment of choice will be steroids. Most of you will be learning steroids are contraindicated in acute pericarditis, but you don't know the exact role. Within 1 week, it's contraindicated. But after 3 to 4 weeks, the autoimmune pericarditis, the treatment of choice is steroids. Okay, this one thing will be confusing. Okay. One more important thing we did not discuss is Kussmaul's sign. So what is Kussmaul's sign? On inspiration, what will happen to the JVP? In inspiration, the JVP will fall normally. So in Kussmaul's sign, in inspiration, the JVP will not fall or even elevate. The elevation of JVP on inspiration is nothing but Kussmaul's sign. And it is seen in constrictive pericarditis, not cardiac tamponade. Remember this, the Kussmaul sign is seen in constrictive pericarditis. Okay, these are the important things we should know about pericardial diseases. Next thing is hypertension. So what are the things we should focus in hypertension? Initial antihypertensive choice in a patient with stable ischemic disease. Okay. So what are the antihypertensives you know? First we'll discuss the antihypertensives and next the specific rules. They are ABCD. Your ACE inhibitors or ARBs. B is beta blockers. C is calcium channel blockers. D is diuretics. Which diuretic is the best antihypertensive? Are loop diuretics or thiazide diuretics the best diuretic which acts as antihypertensive agent. Thiazides are best. Okay, now let's optimize in this. And one more important thing is combination therapy is always better than single therapy. So if you have started one drug, yeah, you can increase the dose of the drug. But if not controlled with that, better go for combination therapy. For suppose diuretics plus AC inhibitors. So combination is always better than single. So ACs and ARBs are the best if the patient of hypertension also has diabetes, renal disease, proteinuria. Beta blockers are the best when the patient is having heart failure or stable angina. Beta blockers have mortality benefit in MI, right? And calcium channel blockers better in elderly. Elderly patient with hypertension start with calcium channel blockers. And diuretics are the best antihypertensives. Best antihypertensive agent. And young patient without any comorbs is diagnosed as a newly diagnosed hypertension. The best drug to start is hydrochlorothalidone. Thiazide diuretics. In this patient having stable ischemic disease, so beta blockers are best. Alpha blockers, if they are having urinary retention, benign prostate hyperplasia, urinary detention, better go for alpha blockers. Calcium channel blockers in elderly. AC inhibitors in a patient of diabetes. Next important thing is what is hypertension? How much BP is hypertension? So according to ESC guidelines, more than 120 by 80 is hypertension. Whereas American Heart Association, more than 130 by 90 is hypertension. So these are the cutoffs for hypertension. And your hypertension can be essential hypertension and secondary hypertension. The secondary hypertension is important. In secondary hypertension, you should know about any case of secondary hypertension. So in my post-graduation period, almost we'll be having OP weekly once. Every OP will admit one young hypertensive, mostly suspected as secondary hypertensive, and we will evaluate him. First, we'll look for renal issues. Next, while examining, we'll look for all 4 limbs pulses and limbs, any vascular disease and any renal disease. After that, we'll look for any electrolyte abnormalities. Because hyperaldosteronism is the most common endocrine cause of hypertension. And we'll ask complaints like occasional sweatings, occasional palpitations, pheochromocytoma. And very young patient, and I have seen only one case of that, very young, 20-year-old male patient have come with hypertension which is not controlled, and there is a complication of that, IC bleed. So IC bleed because of hypertension, 20-year-old male. And after examining, he's having ambiguous genitalia. After genetic examination, he's not male, he's XX. So she's a female with hypervirilization raised as a male. So this is congenital adrenal hyperplasia. I've seen only one case, evaluated only one case. I'll remember that for my life. That was 17-alpha hydroxylase deficiency. So one case was coarctation of aorta, and other case was Takayasu arthritis and hyperthyroidism. You should also look for cortisol and thyroid profile in these patients. So this is how you evaluate a case of essential hypertension. So every week, one case of young hypertension we used to evaluate. Most of the times there is some secondary cause. And the important thing to evaluate secondary hypertension is you can treat the cause. Just simply treating hypertension with multiple drugs and it's not being controlled. Okay. Where are we? Essential hypertension. So any patient with acute hypertension, rule out secondary hypertension. That is the rule. So it can be renal or endocrine. Renal, It can be glomerular or vascular. Vascular is renal artery stenosis. This can also be seen in vasculitis like Takayasu. Takayasu arthritis patient with renal artery stenosis, and you can hear bruit clinically. Whereas endocrine causes, the most common endocrine cause is hyperaldosteronism. Cushing's, pheochromocytoma, these are all adrenal. A patient of acromegaly, hyperthyroidism, even hyperparathyroidism. They all can present with endocrine hypertension. And other things are coarctation of aorta. Okay. These are the important causes of secondary hypertension. And one more important terminology they'll be asking is hypertensive emergency versus urgency. So emergency, the name itself says the BP is more than 180 by 120. Plus end organ damage. The case I told you, 20-year-old male with this much BP and IC bleed has come to the EMD. That is hypertensive emergency because there is a target organ damage. Urgency is the BP is more, but there is no target organ damage, and there can be target organ damage, so you have to control BP. In hypertensive emergency, you have to give IV antihypertensive drugs, and you have to bring the BP 30% of the baseline. Okay. Whereas urgency, you can go for oral drugs and decrease the BP. Next thing, what is malignant hypertension? So malignant hypertension is the same BP with fundus changes. That to papillary edema. Okay, so if there is fundus changes, papillary edema, flash hemorrhages, soft exudates, then you have to think of malignant hypertension. These are the terminologies. Everything is a key point. Okay, we are discussing key points. Okay, these are the things being asked in hypertension. Next, pulmonary hypertension. We have seen systemic hypertension. That we have just seen is systemic hypertension. Hypertension in the systemic circulation. But now this is hypertension in the pulmonary circulation. So in pH, you should know the classification type 1, 2, 3, 4, 5. In that, what is precapillary, what is postcapillary, and how to differentiate. This classification, investigations, and the treatment, the drugs are important. That's it, that much about pulmonary hypertension. Not seen in precapillary pulmonary hypertension. I'm saying precapillary, postcapillary is more important. Increased pressure in pulmonary circulation, yes, that's why it's pulmonary artery hypertension. Increased pulmonary capillary pressure, yes, that is only pH. RVH is there in any type of pH. This indicates pulmonary artery hypertension. Whereas increased pulmonary capillary wedge pressure is seen in postcapillary. Postcapillary pulmonary hypertension, that is heart failure. See, what is this post and precapillary? This is the heart, this is your pulmonary artery. From pulmonary artery coming the capillaries, from that the veins are draining into left atrium. So till here is pulmonary capillary. Before that, any pathology is pre-capillary. After that, any pathology is post-capillary, and the post-capillary only one thing, type 4 PH, that is due to heart failure. Sorry. Type 2 PH, 4 is due to chronic PT, right? So only post-capillary is type 2 and heart failure. Now let's look into the types of PH. After that, we'll see how to evaluate. So what is PH? Pulmonary artery hypertension. But there are two terms, pulmonary hypertension and pulmonary artery hypertension. What we are discussing is pulmonary hypertension. It's of 5 types. It's of 5 classes. The type 1 pulmonary hypertension is called PAH, pulmonary artery hypertension. That is the difference. So if you are saying PAH, it's type 1. So to commonly call it as pulmonary hypertension. So type 1 is idiopathic and it's due to bone morphogenic protein receptor 2 mutation. Type 2 is due to heart failure and it's the only post-capillary. Everything is pre-capillary. Type 3 is due to chronic lung disease. Type 4 is due to chronic PTE. Type 5, there are some specific types. Unspecified, not these things are type 5. So these are the types of pulmonary hypertension according to WHO. So how do you investigate? The best method to investigate for pulmonary hypertension is right heart catheterization. You should put a catheter to the right heart into pulmonary capillary and measure the pressure in it, the pressure in the pulmonary artery and the pressure in the pulmonary capillary. So if the pressure in the pulmonary artery is more than 20, only then it's called pulmonary artery hypertension. So remember this 20, more than 20 mm of Hg, and in Wood units it's more than 3. Okay, you can also measure the pulmonary capillary wedge pressure, right? And if it's more than 15, it is post-capillary. Not more than 15 means it's pre-capillary. That is what this whole diagram is showing. We are worried about two things. Is the pressure more than 20? Yes, it's pulmonary artery hypertension. Next, we'll go further and measure the pulmonary capillary wedge pressure. If it's more than 15, then it's post-capillary. So here the cutoff is 15. In heart failure also we'll be looking for pulmonary capillary wedge pressure, right? There it's 18. More than 18, then heart failure is confirmed. The cutoffs are different. Now coming to the treatment. The treatment is endothelin receptor antagonist, prostaglandin analogs. So what are we doing? Basically there is pulmonary artery hypertension. We are trying to dilate the pulmonary artery. Prostaglandin analogs. Prostaglandin receptor agonists. Next, PDE5 inhibitors. Next, guanyl cyclase agonist. These are the drugs we can use. So the endothelin receptor antagonists are ambrisentan and bosentan. These drugs are important. They can ask with mechanisms. Whereas PDE5 inhibitors are sildenafil, tadalafil. So why I have written PDE5 separately? Because most of the times we'll be using this combination. Ambrisentan plus tadalafil. There comes a tablet, single tablet fixed drops combination, ambrisentan plus tadalafil. Most of the times we'll be prescribing that, and this is oral. And prostaglandin analogs like epoprostinol and iloprost. Prostaglandin receptor agonist selexipag. And guanyl cyclase agonist Riocuguat. So these are the drugs we are using in pulmonary artery hypertension. So one more thing you have to remember is we will be seeing Raynaud's phenomenon in scleroderma. There also we will be giving almost similar treatment. In Raynaud's phenomenon, yes, initially we'll try calcium channel blockers. If not working, we'll go for endothelin receptor antagonists, PDE5 inhibitors, this prostaglandin analogs and guanyl cyclase agonists. Even after that it's not improving, we'll go for surgery. That is what we'll be doing in Raynaud's phenomenon. Both are vascular events, so this treatment is similar. Yes, we have covered everything in pulmonary artery hypertension. Two numbers 20 and 15. The only post-capillary is cardiac type 2. Next, coming to aortic dissection. Next topic is aortic dissection. So most of the times in aortic dissection, they will be asking you the classification and presentation. So in presentation, he'll give you a clinical scenario and he can ask you what is the diagnosis and radiological. These are the things they'll be asking you in aortic dissection. So what is aortic dissection? So this is the aortal circumference and this is the true lumen. And there is a break in the wall of the aorta resulting in false lumen. The wall has been breaked and there is a false lumen and the blood is flowing in the false lumen also. The intima media has been breaked at one point and it has been opened and there is a false lumen. This false lumen can compress the true lumen. This is the basic pathophysiology of aortic dissection. So what is the presentation? So when aorta, the lumen of the aorta is compressed. Aorta means ascending aorta can also be involved. What can be the clinical features? First important thing is the patient will present with acute chest pain or epigastric pain based on the site of the aortic dissection radiating to back. So chest pain, one of the important DD for MI, and epigastric pain radiating to back, it's one of the important DD for pancreatitis. But in this patient will be hemodynamically compromised with hypotension. Aortic acute pancreatitis patient, yes, he'll have pain, vomitings, dehydrated, but most of the times until he's landed into systemic inflammatory response syndrome and organ dysfunction, he won't be in hypotension. He would be stable. But acute pain, epigastric or chest pain radiating to back with hemodynamic compromise, you should suspect aortic dissection, especially in an elderly patient of hypertension. Elderly patient with hypertension with these symptoms. And because it's involving the root of aorta, there can be associated AR. And it can open into the pericardial space, pericardial effusion. So these are the presentations of aortic dissection. Yes, there can be pericardial effusion. Yes, there can be AR. And why there is limb ischemia? If the lumen of the aorta is, the true lumen is being compressed by the false lumen, the blood flow to the lower limbs decreases and can cause limb ischemia, and there will be absent pulses in both of your lower limbs. And this is not mandatory, absent pulses. The false lumen can or cannot compress your true lumen. It can be or cannot be there. Coming to the classification, there are two classifications, Stanford classification and DPACK classification. DPACK is 4 types, 1, 2, 3A and 3B. It is classified based on the site involved. See, if this type 1 and type 2 are dangerous because they are involving the root of aorta. See, whole aorta is involved along with the root. Root, ascending aorta, arch of aorta and descending aorta. That is type 1. In type 2, root and ascending are involved. Whereas type 3A, only descending aorta, that too up to the renal veins. Whereas type 3B, descending aorta crossing the renal veins. So this is DPACK classification. 1 is whole aorta, 2 is only ascending aorta, 3A is descending aorta above the renal arteries, whereas 3B is descending aorta below the renal arteries. So the renal arteries are the landmark for 3A, 3B. Whereas Stanford classification, it's divided into type A and type B. Type B, root of aorta is involved or ascending aorta is involved. Whatever the part is involved or not involved, they are not concerned. If the ascending aorta is involved, it's type A. If ascending aorta is not involved, it's type B. Why they have classified in this way, ascending aorta is involved or not? Because ascending aorta is involved, more chances of aortic root dilatation, AR, and it's emergency and you have to go for emergency surgery. So this is the emergency. That is why we have divided it in such a way. So Stanford's and DPACK classification. Stanford's is more easy. A is ascending aorta root involvement. B is no A. So A will be surgical management. B will be conservative management. So coming to the causes of this aortic dissection, elderly and hypertensive are the risk factors. Yes, there are other risk factors like smoking. And already there is aortic disease possible, right? Aortitis. So which of the vasculitis can cause aortitis? See, aorta is a large vessel. So obviously large vessel vasculitis like your Jane cell arteritis and Takayasu arteritis can involve. Other than this, your Behçet's. Behçet's is a variable vessel. So it can involve any type of vessel. And IgG4 vasculitis. All these can cause aortitis resulting in aortic dissection. And one more disease, syphilis, syphilitic aortitis. These things can predispose the aorta for aortic dissection. Not only this, any trauma to the aorta. So these are the risk factors and causes of aortic dissection. These are the important things to be concentrated in aortic dissection. Next, coming to cardiopulmonary resuscitation. Next topic. This is very important. I told you anything emergency will be more important. Yes, this is everyone would have done in their internship. This is very important. So they'll ask at least one question from this. This can come either under medicine, anesthesia. Which of the following rhythm is not shockable? So to do a CPR, so cardiopulmonary resuscitation is CPR, right? You should know first thing how many compressions, how many breaths, how depth should be the compressions, and at what intervals you should give the drug, and which to defibrillate, which not to defibrillate, and when to defibrillate. These things you should know. So this is the thing given here is the ACA guideline of cardiopulmonary resuscitation. So first let's look at the question which is not shockable. See your VT and VF are the only shockable rhythms. Your pulseless electrical activity. Pulse is there, but electrical activity is there, but pulse is not there. Don't shock. And asystole. No pulse, that is what it means. Don't shock the patient. In this case, you can do CPR. If there is pulse later, you can shock the patient. So these are shockable rhythms, not shockable. So in this case, these two are the answers. Asystole and pulseless electrical activity are the non-shockable rhythms. So before that, we'll see when to actually what's the procedure to do CPR. You all would have been writing CPR notes. So when I was an intern, I used to write CPR notes and I used to get scoldings. You don't even know how to write CPR notes. Because at that point of time, I don't know this exactly for how many cycles of CPR you should do, at what intervals you should give this drug. Okay. First thing is, whenever you notice a case of cardiac arrest, start CPR. The first thing you should be doing is start CPR. Okay. After starting CPR, you have to look at the rhythm, whether it's shockable or not shockable. If it is shockable, shock. You have to give defibrillator immediately. If it is not shockable, nothing you can do. Do CPR for 2 minutes. Here also, after giving shock and in between the shocks, you should do CPR. CPR for 2 minutes. And in non-shockable rhythm, for every 2 minutes of CPR, you should see whether there is a return of rhythm and the patient can be shockable. Again, you can see whether he can be shockable. Here also, if it's shockable, shock. Shockable, give shock. So after 2 shocks, you can start drugs. What? So we used to give epinephrine and atropine because in the previous CPR regimen or flowchart, there used to be atropine, adrenaline plus atropine. But now we give only adrenaline. That is, you will be giving epinephrine. Other than epinephrine, you can give lidocaine. These are the only 2 drugs you can be giving. Okay, so first thing you have to do is it shockable rhythm? Shock it. Not shockable? Continue CPR for 2 minutes, whether it's shockable or not. Okay, this is the correct method of doing CPR. And while giving CPR, cardiopulmonary, so it's both ventilation plus compressions. So what is the compression is to ventilation ratio? It should be 30:2. After every 30 compressions, 2 breaths you have to be given to the patient. And like this, 100 to 120 compressions per minute you have to do. So almost 1 minute you will be doing like 3 to 4 cycles of this 30:2. So it's very fast. Like that you have to do for 2 minutes. And how depth should be the compressions? It should be at least 2 inches or 5 centimeters. And after compression, there should be complete recoil. That is more important. So this is about cardiopulmonary resuscitation. These are the important things to know. And this is the recent ACA guideline for cardiopulmonary resuscitation. Remember this flowchart. So next question is cardiac tumors. The most common cardiac tumor is myxomas. Myosarcomas can also be seen in cardiac tissue, but common are myxomas. They are most common in the atrium, that's why atrial myxomas, that too left atrium. So whenever you say myxoma, the left atrium should be the term that you remember. So in myxomas, what can be the question? The location, the site, age, symptoms. These things they can ask in myxoma, not too much depth. So yes, it's seen in left atrium. It's common in young males. And metastases are very rare in myxomas. And yes, no, one more thing is metastasis is rare. Most of the myxomas are not familial, they are sporadic. So he's asking true statement. This is false, this is false. Most common in left atrium. And coming to males, it's seen in both young males and females. That's why this is also a wrong statement. So we have learned most of the things of myxoma, atrial myxoma. So it's most common in left atrium. It's seen as tumor plop in mid-diastole followed by mid-diastolic murmur. Same like MS, right? That is what we have learned. And there is no gender preponderance, male equals to females, that too in young age. It can be sporadic or familial. Familial is very rare. There will be multiple myxomas. Mostly it's sporadic with single myxoma in the left atrium. And after, what's the treatment? You have to go for excision. After excision in sporadic, the recurrence is very rare. It's not familial, they are sporadic. See, this is a myxoma. And this will plop onto the mitral valve during diastole, ventricular diastole. When ventricle is filling, the blood will grow like this, so that will plop, resulting in tumor plop followed by mid-diastolic murmur. Treatment is you have to excise it. So the next topic of interest is rheumatic fever, acute rheumatic fever. So we all know the criteria of acute rheumatic fever, but here in this question he is asking about erythema marginatum. So the most important thing of erythema marginatum is it will be mostly involving the extremities, and it is a late sign. And if there is erythema marginatum or subcutaneous nodules, more chances of carditis. So skin involvement, more chances of carditis. That is how you remember. So erythema marginatum is not pruritic. It doesn't involve the face. It involves the extremities and trunk, spares face. Usually associated with carditis, yes. It is not the most common manifestation of acute rheumatic fever. Acute rheumatic fever, young, that is adults, the most common is arthritis. Whereas children, the most common is carditis. Those are the most common manifestations of acute rheumatic fever, not erythema marginatum. In fact, erythema marginatum is a late complication. The most late complication will be chorea. The rheumatic chorea will be very late. So this is erythema marginatum. And this is one of the major criteria. What criteria it is? Revised Jones criteria. Okay. So we'll see what are the major criteria. I told you arthritis is common in young, carditis is common in children. Erythema marginatum and subcutaneous nodules indicate most probably carditis. And other than this, the most late complication is chorea or scent vitis glands. So these are the major criteria. So one important thing in this arthritis is what arthritis? Mostly it is polyarthritis migratory. But there are some differences. What in endemic areas with high incidence and low incidence? Because in major criteria and minor criteria, we have joint involvement. We'll see what is the difference. So coming to the major criteria in endemic areas, I told you polyarthritis is common. So not only polyarthritis, inflammation, just joint pain, polyarthralgia is also considerable, and monoarthritis is also considerable. Monoarthralgia will be the minor criteria. Whereas in low incidence setting, only polyarthritis is considered. The monoarthritis and polyarthralgia are minor criteria, and monoarthralgia in low incidence setting has no role. So these are the differences in arthritis. And in minor criteria, fever also has difference. Here it's more than 38 degrees. Here fever more than 38.5 degrees. These are the basic differences. Other criteria we will remember, but these small minor things we may miss, and they can ask as an MCQ. Yeah, we have answered this question. Okay. For rheumatic fever, so in rheumatic fever, first thing they'll be asking is the criteria, and second thing is prophylaxis. These two are the most commonly asked questions from rheumatic fever. So when do you give prophylaxis and for how many years? So for prophylaxis, we'll be giving IM benzathine penicillin for every 3 weeks. So while asking history for any valvular disease, while asking history of rheumatic heart disease, you'll be also asking patient every 3 weeks, do you take any IM injection? Yeah, this is one of the history you'll be asking. So no carditis. Carditis is there, but no residual disease. And residual heart disease is there. No carditis. Give it for 5 years, or the patient achieving until the age of 21 years. Whichever is more, give it. Patient had history of carditis, but now there is no residual disease like MS, MR, valvular disease is not there. Then 10 years or 21 years. Yes, residual cardiac disease is there with severe carditis. Then almost lifelong you have to give prophylaxis. Okay, these questions they can ask, and these are little confusing. They'll ask 5 years, 10 years, 21 years, 45 years, lifelong. These will be the options and most confusing options. Okay. So we are giving benzathine penicillin. Next question in congenital, we'll be looking into congenital heart diseases. So in congenital heart diseases, coming to the adult congenital heart diseases, first thing they'll be asking you is the syndromes. In Down syndrome, what is the most common involvement? In Turner syndrome, what is most common? Marfan's, such syndromic involvements. And next thing, ASD, VSD, PDA. In adult, you will be seeing ASD. That is the most common congenital heart disease in adult. So those questions can be there. So cardiac anomaly seen in Noonan syndrome. That is what he's asking. So Noonan syndrome, the presentation is almost like Turner syndrome, with the inverted triangle shaped face. But the difference is in Turner's, left side of the heart is most commonly involved, like coarctation of aorta, bicuspid aortic valve. Whereas in Noonan's, right side of the heart is most commonly involved, that is pulmonary stenosis followed by HOCM. Yeah, it is pulmonary stenosis. See, this is inverted face, inverted triangle like face. This is what you will see in Noonan syndrome. So now if you tell me in Down syndrome, what is the most common congenital cardiac anomaly? It is ASD, that too endocardial cushion type. In Turner's, it is coarctation of aorta followed by bicuspid aortic valve. It's nothing but AS. We have seen Noonan's. And one more thing is Holt-Oram syndrome. So this syndrome is ASD with skeletal anomalies. What skeletal anomalies? Absence of radius, absence of thumb, so all radial anomalies. So these are the important syndromes for which the cardiac anomalies can be asked. And coming to the major differences between ASD, VSD and PDA. So to know the difference, we should know the basic pathophysiology. What's happening in ASD? All are left to right shunts. If this shunt is changing from left to right to left, then that is called Eisenmengerization. So they are all left to right shunts. So ASD is left atrium to left ventricle. So the blood from the left atrium to right atrium, left to right ventricle, again to left atrium. So the blood is circulating more in the pulmonary circulation. So resulting in, so RV is also involved. In this patient, there is RVH, pulmonary artery hypertension. Whereas in VSD, the blood from LV is coming into RV to pulmonary circulation to LA to LV again. So here, initially, there is RVH followed by LVH and PAH. More blood to the LV and RV. Whereas PDA, the chambers are not involved. Directly the blood from the pulmonary artery is going to aorta. From the aorta is going into the pulmonary artery. More circulation in the pulmonary system, but the chambers are not involved. So only PAH is seen. So this is the major difference. And coming to the age of presentation, this will be like, this is most youngest presentation, and ASD will be 20 to 40 years. And VSD is less than 3 years. And coming to chances of Eisenmengerization, it's high in PDA followed by VSD followed by ASD. And if there is Eisenmengerization in these two, there is cyanosis. Whereas PDA, there is differential cyanosis. That is upper limbs no cyanosis, lower limb cyanosis is there. Differential cyanosis. How do you treat? Surgical correction. Once Eisenmengerization and RVH, there is no much treatment also. And one more important thing is ASD is wide fixed split. VSD, pansystolic murmur. PDA is continuous murmur. So these are the differences and presentations. The most important things they'll be asking in ASD, VSD and PDA. Next topic is endocarditis. So in infective endocarditis, the criteria is important. Most of the questions are from criteria. And which lesions are more prone for infective endocarditis? These are the things they will be asking in infective endocarditis. So let's take the question. Infective endocarditis is less likely to occur in. So where do you see infective endocarditis? where there is high flow, like our regurgitant murmurs, VSD, PDA. In such high flow conditions only then you can see infective endocarditis. In ASD and mitral valve prolapse, the flow is not that much high. In the difference between right atrium and left atrium is not that high. So the flow is not that fast, and there is no infective endocarditis seen in ASD or MVP. Yes, in VSD, compared to larger VSD, the small VSD more chances of infective endocarditis because more flow through the small VSD. Mitral valve prolapse, also yes, 2 options. Tetralogy of Fallot also you can see infective endocarditis. Yes, 2 options, mitral valve prolapse. Coming to the criteria. Okay, this is not clear, but we know the criteria. Major only 2 things. On blood culture, there should be organism, and on 2D echo, there should be some evidence of infective organisms. But this is not that simple. Coming to the blood culture, if it is a typical organism like Staphylococcus, Streptococcus, there should be at least 2 cultures positive. If that is an atypical organism or fastidious organism like Coxiella burnetii, 1 culture is enough. Or you can also do serology, in which the titer should be more than 1:800. See, that's the thing here. 2 separate blood cultures for typical organisms. Whereas atypical like Coxiella burnetii, 1 single blood culture or IgG more than 1:800. Because everything can be a question. So he'll be giving what are the major criteria, and that under that 1 set of blood culture of Staphylococcus, that's the option. You will think blood culture is positive and this is a major criteria. No, 1 set of culture positive of staph will be minor criteria. So in minor criteria also, there is microbiological evidence, which is not satisfying the major will be the minor criteria. Okay. Next, coming to evidence of endocardial involvement, you can see vegetations, paravalvular abscess, anything. New regurgitant lesions, not increase in old regurgitation. I want new regurgitant lesion, that is also important. New valvular regurgitation is important. So one of the options will be like change in pre-existing murmur. No, that is not considered as major criteria. Now coming to minor criteria, predisposition. Any predisposing heart disease, prosthetic valve, or he said IV drug abuse, or previously he had a history of infective endocarditis is also a risk factor. And there is fever. Next, there is embolic phenomenon and immunological phenomenon. Embolic phenomenon is this infective emboli has thrombosed, has gone into the embolism, has gone into the system and settled somewhere. What are the features of the vascular embolism? So you will be seeing splinter hemorrhages, hemorrhages in the retina, and Osler's nodes. Janway lesions. So what is the difference between Janway lesions and Osler's nodes? So we are discussing the embolic phenomena, right? In embolic, Janway lesion is one of the things. Whereas Osler's nodes is immunological phenomena. In immunological, you can have Osler's node, RA factor positive, glomerulonephritis. Okay, now if you tell me what's the difference between Janway and Osler's nodes. Janway lesions are painless, just a hyperpigmentation on the palm. Whereas Osler's nodes, painful lesions in the tips of the fingers. So painful lesions in the tips, Osler's immunological phenomenon, painless hyperpigmentation on the palm is Janway lesions, embolic phenomenon. These two are important. So one major plus one minor is enough to diagnose it as infective endocarditis. So this is about infective endocarditis. How to treat is antibiotics and any predisposing factors, any prosthetic valve. If the prosthetic valve dehiscence is there, you have to go for surgery. Any complications, go for surgery. And a few things, if refractory to antibiotics or if there is fungal infective endocarditis, you have to go for surgery. This is about infective endocarditis. So next question about carcinoid syndrome. So what is the difference between carcinoid tumor and carcinoid syndrome? This is important. And what are the cardiac manifestations of carcinoid syndrome? It's very important. It's very simple but important. So now you tell me what's the difference between cardiac tumor versus syndrome. Cardiac tumor is nothing but a neuroendocrine tumor which will be secreting serotonin. Carcinoid tumor is a NET which will be secreting serotonin. This serotonin has multiple effects like flushing due to vasodilatation, diarrhea due to increased intestinal motility. Whereas this serotonin is metabolized in your liver and lung. So no such effects. But when this carcinoid tumor is metastasized to the liver, now the liver is damaged, it's not able to metabolize serotonin. So now the features of serotonin will be seen. So when it's mets to liver, that's called carcinoid syndrome. So more features of serotonin. So what does this serotonin does? So it's in the circulation, it enters through inferior or superior vena cava into the right atrium, right ventricle. After that, it's going into the lungs. In lungs, it's destroyed. That's why left atrium and left ventricle are not involved. So this carcinoid syndrome involving the heart is only right. Why? Sorry. Why left side of the heart is not involved? Because it's being metabolized in the lung. So in which condition left side of the heart can be involved? If it is involved, the only chance is it is skipping the lung, right to left shunt. Some Eisenmengerization is there, right to left shunt, only then it's skipping. So in right side, it can involve your right ventricle, your pulmonary valve, your tricuspid valve, everything, especially your endocardium, will be fibrosed. So this is important. He'll give you carcinoid syndrome. One of the following is true or false. In that he'll give it's endocardial fibrosis. You know that it's right side. Most of us will remember. But endocardium fibrosis, is it fibrosis or not? So that will be a confusion. To be more specific, yes, it's endocardial fibrosis. And this is one of the question asked in the recent NBE exams. It's a probable question. Carcinoid syndrome, cardiac involvement. And because there is fibrosis of RV, there is restrictive cardiomyopathy. Pulmonary vein, there can be pulmonary regurgitation more than stenosis. Tricuspid valve, sorry, it's not vein, it's valve. Tricuspid regurgitation more than tricuspid stenosis. In this, the most common is tricuspid regurgitation. So, carcinoid syndrome, heart, only thing you should remember is tricuspid regurgitation, but anything on the right side can undergo endocardial fibrosis. Sorry, endocardial fibrosis, that's the thing. So it is tricuspid regurgitation. No aortic stenosis, no mitral stenosis, no aortic regurgitation. They are all left-sided lesions. And right side too, regurgitation is more common than stenosis. Okay, we are done with cardiovascular system. So these all are the important things you should be revising in cardiovascular system. Okay. Okay, we'll take a short break. After that, we'll continue with other systems. Next, we'll be doing hematology.
Ethyl alcohol 95% or the more common.
Okay, they do not have any particular shape.
It is called the Deciduar capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Okay, let's continue with hematology. So we are doing the overview of hematology. So we will be discussing in each topic. We'll take up each topic with a question. We'll discuss that and what are the other things to be covered in that topic, not to miss. So the first thing is microcytic hypochromic anemias. So your hematology, most important parts are your anemia, and your malignancies of WBC, leukemias and myelomas, and in platelets and coagulation disorder, they'll be asking you about one of the bleeding disorders. These are the important parts of hematology. Yes, along in hematology, you won't be having much of clinical features. So everything will be of, you should know the peripheral blood smear and bone marrow. The morphology of each cell they are explaining, because picture based questions are mostly seen in hematology. And there will be few differentiating features between each type of disease. For suppose hypochromic microcytic anemias, iron deficiency versus anemia of chronic disease, how to differentiate. Myelodysplastic syndrome versus aplastic anemia, how to differentiate. Okay, they're totally different, but those are the DDs sometimes. How to differentiate, you have to know, because they are the options you have to exclude. So that's the main thing you should know in hematology. So keep seeing the slides, the pictures, so that they will be in your memory. Picture memory will be there, keep seeing them. So first, microcytic hypochromic anemias. So hypochromic microcytic, what's the first thing you are getting? You will know it's an iron deficiency. First thing that comes to your brain is iron deficiency anemia, but there are a lot of causes, other causes also. We'll see the question and discuss. So it's a young female being evaluated for microcytic hypochromic anemia. How are they evaluating? With iron profile. It is showing decreased serum ferritin. What would be the probable diagnosis? All of this are the DDs of microcytic hypochromic anemias. So it's iron deficiency anemia, most common. followed by thalassemias, anemia of chronic disease, sideroblastic anemia. And one of the cause of sideroblastic anemia is lead poisoning. So these are all the causes of microcytic hypochromic anemias. Now, how do you differentiate? Iron profile helps us to differentiate all these things. How to differentiate just based on iron profile, we'll see. So this is the peripheral blood smear showing microcytic hypochromic anemia. Let's see the iron profile. In iron deficiency anemia, how is the iron profile? What happens to your serum ferritin? So ferritin is the storage form of iron, and it's the first parameter to decrease in iron deficiency anemia. If ferritin is normal or increased, it's not iron deficiency anemia. First thing to decrease in iron deficiency anemia. Next, coming to serum iron. Total iron is decreased. What happens to transferrin saturation? So transferrin will carry iron. Now there is no iron. So what happens to the transferrin saturation? It's low, right? It's not saturated. What happens to the total iron binding capacity of transferrin? Because the saturation is low, the transferrin is not bind to any iron, the binding capacity will be high. So this is in iron deficiency anemia. Now coming to anemia of chronic disease. Anemia of chronic disease, because of chronic inflammation, there is increased serum ferritin and decreased transferrin. That is why there is decreased iron utilization rather than iron deficiency. You can say decreased iron utilization. So serum ferritin is increased. That is the most differentiating feature because it's a positive inflammatory marker. What happens to the serum iron? It's normal because actually there is no iron deficiency or slightly decreased. What happens to the transferrin saturation? Transferrin saturation is decreased. What happens to total iron binding capacity? So transferrin itself is somewhat decreased. So total iron binding capacity will decrease. But the main thing which will help us to differentiate between anemia of chronic disease and iron deficiency anemia is serum ferritin, because other things can change. Okay. If serum ferritin is decreased, it's definitely iron deficiency anemia. It's increased and picture of iron deficiency anemia, it is anemia of chronic disease underlying some chronic inflammatory disease. And in thalassemia and sideroblastic anemia, the iron profile is normal. Then why there is microcytic hypochromic anemia? See, microcytic, that means the cytoplasm of the RBC is low. Why? Because the cytoplasm of RBC is made up of hemoglobin. Hemoglobin is nothing but heme plus globin. Heme is iron plus protoporphyrin. Globulins are your 2 alpha chains and 2 beta chains. So this is what the cytoplasm of your RBC contains. So if there is iron deficiency in anemia or decreased iron utilization in anemia of chronic disease, there is microcytic anemia. If there is decreased protoporphyrin like in sideroblastic anemia, there is microcytic anemia. If there is alpha or beta thalassemia, decreased chains, there can be microcytic anemia. They all will explain. You don't have to by heart, right? If you remember the contents of the cytoplasm of RBC, those contents are decreased, there will be microcytic hypochromic anemia. How to differentiate? The most common cause of microcytic hypochromic is iron deficiency. So first thing we'll be doing is the iron profile. If it's abnormal, either iron deficiency or anemia of chronic disease. It's normal, then either thalassemia or sideroblastic anemia, but these will have other features. Sideroblastic anemia, there will be sideroblasts in the peripheral smear, whereas thalassemia, there will be splenomegaly. And from childhood, patient will be having multiple blood transfusions, massive splenomegaly, other history will be there. So in this, ferritin is decreased, means it's iron deficiency anemia, nothing to consider here. One more important thing, in anemia of chronic disease, I told you it's decreased iron utilization. Why it's decreased iron utilization? Because here hepcidin is a positive inflammatory marker, ferritin is a positive inflammatory marker, and transferrin is a negative inflammatory marker. So what's happening when hepcidin is increasing? Hepcidin will inhibit ferroportin. You need ferroportin for the absorption of iron. So this is the mucosal cell. This side there is dimetal transporter. This side there is ferroportin. In the mucosal cell, if ferroportin is blocked, the iron is blocked in the mucosa. The absorption of iron is perfectly fine, but it's not being utilized. That is what I'm saying, decreased iron utilization. There is mucosal block of iron due to increased hepcidin. And transferrin is also decreased. Transferrin is the transport form of iron. The name itself says transport form. That is also decreased. So this is about anemia of chronic disease. Any chronic inflammatory condition like your rheumatoid arthritis mainly can cause anemia of chronic disease. And looking into this peripheral smear, can you see the hypochromic microcytic RBCs? How do you say an RBC is microcytic? We will compare the RBC with the nucleus of a monocyte. It should be same. If it's less than the nucleus of monocyte, then it's microcytic. How do you say it's hypochromic? The central pallor of the RBC should be less than 1/3 of the circumference. But here the central pallor is more than 1/3. It's almost like more than half of the cell. So they are hypochromic microcytic RBCs. So these are the differentials. Next, coming to hemolytic anemias. So hemolytic anemias, you should know the classification. Hemolytic anemia is a broad diagnosis. There are many conditions under hemolytic anemia. The first thing is you should know classification of hemolytic anemia. Classification means which is extracorpuscular and intracorpuscular. Extravascular versus intravascular. Hereditary versus acquired. All these things you should know. Classification of hemolytic anemias. And next thing in hemolytic anemias, most important are autoimmune hemolytic anemia, PNH, your sickle thal, hereditary spherocytosis, G6PD deficiency. In G6PD deficiency, the drugs are important, drugs causing G6PD deficiency. So these are the important parts of your hemolytic anemia. You should know these things. So here he is asking a chronic hemolytic anemia which is associated with iron deficiency. So to know that, can all hemolytic anemias cause iron deficiency or only specific hemolytic anemias will cause iron deficiency? What is the pathophysiology behind that? You should know. See, paroxysmal cold hemoglobinuria is a autoimmune hemolytic anemia. Thalassemia is a hemolytic anemia which is inherited, intracorpuscular. This is extracorpuscular. Hereditary spherosis is also due to the deficiency of ankyrin. It's a protein in the membrane of the RBC. Ankyrin followed by BAN3 deficiency, because that is intracorpuscular. G6PD is also, it's an enzymopathy, intracorpuscular. So intracorpuscular hemolysis will be resulting in, intracorpuscular defects, mostly extravascular hemolysis, whereas extracorpuscular, intravascular hemolysis. So one important thing you should remember is, in intravascular hemolysis only in intravascular hemolysis, there will be iron deficiency anemia because the RBC is broken, the hemoglobin is coming into the blood, hemoglobinemia followed by hemoglobinuria. So the hemoglobin is lost in the blood, resulting in hemoglobin contains iron, so iron deficiency. Whereas extravascular hemolysis, that is happening in the spleen, so that iron will be utilized. So in extravascular hemolysis, in fact, there is iron overload. So in intravascular, there is iron deficiency. But one thing is, your autoimmune hemolytic anemia is both intra plus extravascular. The chances of blood loss or iron deficiency is in paroxysmal cold hemoglobinuria. You got me? So to answer this, you should know which undergoes hemolysis in intravascular or extravascular. Intravascular will have iron deficiency. So this is what we have just discussed, the intracorpuscular defects and the extracorpuscular defects. Extra undergo intravascular hemolysis. Intra undergo extravascular hemolysis. So the intracorpuscular defects can be inherited or acquired. Inherited are your hemoglobinopathies, that is your sickle cell, thalassemia, globinopathies, problem with your beta and alpha chains, and enzymopathies like your G6PD deficiency, and membrane disorders like your hereditary spherocytosis and elliptocytosis. Acquired intracorpuscular is PNH, CD55 and 59 mutation. So CD55 and 59 will protect RBC from complement mediated damage. Now because these are mutated, the RBC is more prone to complement mediated damage and resulting in hemolysis. Next, hemolytic uremic syndrome is inherited. Atypical is inherited, whereas typical hemolytic uremic syndrome will be acquired. Next, acquired extracorpuscular can be drug related or it can be mechanical destruction, infectious, autoimmune hemolytic anemia. So here comes the exception. I told you all intravascular or intracorpuscular or extravascular. PNH is an exception, undergoes intravascular hemolysis. Autoimmune also undergoes extravascular hemolysis. These two are the exceptions. So every disease you cannot remember. So remember this: intracorpuscular, extravascular, extracorpuscular, intravascular, and these two exceptions, because that is very important. They'll ask you. Okay. So one more important thing is drugs. Drugs in sickle cell anemia. We'll be using hydroxyurea. What is the mechanism of action of hydroxyurea? It will increase HbF. Okay. Next thing, we'll be using N-glutamine. What is the mechanism? Glutamine will convert into glutamate. So ultimately, it will decrease the reactive oxygen species damage on RBC. Next, we will be using voxelotor. And the next thing is cranzalizumab. These are the newer drugs, that's why I'm discussing. What does voxelotor do? it will increase the oxygen affinity of HP. And cranzalizumab is a monoclonal antibody against P-selectin. So the sickle cells won't stick to each other and there won't be any thrombosis. So these are the drugs. And coming to PNH, what is the treatment of PNH? It's complement mediated damage. So you have to inhibit complements. It is eculizumab. Eculizumab is C5a inhibitor. One more C5a inhibitor is ravulizumab. Okay. These are the important things in hemolytic anemia. And one more thing is Coombs test. So whenever there is hemolytic anemia, especially in the young, we will be first considering Coombs test. And if Coombs test is positive, it indicates it is autoimmune hemolytic anemia. And this Coombs test or the antibodies can be warm or cold antibodies. See, this cold antibodies is seen in paroxysmal cold hemoglobinuria or cold agglutinin disease. So the cold antibody, two things, cold agglutinin disease and paroxysmal cold hemoglobinuria. Whereas warm antibody, the most common is SLE, and your malignancies like CLL, Hodgkin's lymphoma can cause this. And drugs like alpha methyl dopa and penicillin. So warm antibodies are active in warm temperature, that is 37 degrees, whereas cold antibodies are active in less than 37 degrees. One more important thing is warm antibodies are IgM. Warm antibodies are IgG. Warm is always good, right? Cold antibodies are IgM. Whereas there is one exception in paroxysmal cold hemoglobinuria. It's a cold antibody disease but IgG related. And in IgM type there is RBC agglutination. So these are the key points in the question you have to catch. IgG mediated or IgM mediated. Active at 37 degrees or less than 37 degrees. Coombs test positive. So a hemolytic anemia scenario is given with Coombs test positive. It's nothing. It's Coombs test. Sorry, it's at autoimmune hemolytic anemia. If Coombs test is negative, then you have to rule out all other things. All these things you have to look. Only this thing as Coombs test positive. Okay. Next important topic in hematology is aplastic anemia and myeloproliferative disorders. So aplastic anemia, myelodysplastic syndromes. Myeloproliferative we'll discuss later. But why aplastic anemia and myelodysplastic syndromes are discussed together? Are they same? We'll see. But under this, aplastic anemia and MDS both are important. The only thing you should know is hypocellular marrow or cellular marrow. What is the marrow and what are the abnormal cells you will be seeing? What are the causes? These are the important things. So first coming to the question, 38-year-old woman. So middle-aged, fatigue since 3 months, non-palpable purpura, and there is anemia and thrombocytopenia. Okay, there is pancytopenia. So what is the probable diagnosis? The aplastic anemia also presents with pancytopenia, fitting our criteria. Myeloproliferative neoplasms, there can be pancytopenia or any one cell can be increased. See, myeloid cells are proliferating. So your myeloproliferative neoplasms are nothing but your CML, polycythemia vera, CNL, CEL, all are, and your essential thrombocytosis, all these are your myeloproliferative neoplasms. In that there is splenomegaly. At least moderate will be there. Moderate to massive splenomegaly should be there. Your myelofibrosis is also a type of myeloproliferative neoplasm. In this, massive splenomegaly is there. Your hairy cell leukemia is a non-Hodgkin's lymphoma in which elderly male will be presenting with massive splenomegaly. It's a non-Hodgkin's lymphoma mostly seen in elderly male with massive splenomegaly. But here on examination there is no organomegaly. That's the thing supporting aplastic anemia. And one more thing about hairy cell leukemia is, hairy cell leukemia is a B cell leukemia. So B cell, the origin can be pre-germinal, germinal or post-germinal center. This is post-germinal center. And coming to the markers, CD25, 103 or positive. And coming to the peripheral smear, in the peripheral blood smear, there are hairy cells. Peripheral blood smear, there are hairy cells. So they're hairy. So this is the cell, the hair-like extensions. Just by seeing that cell, you can say it's a hairy cell. And bone marrow, you cannot do aspiration because there is secondary myelofibrosis. Because the bone marrow is fibrosed, you cannot do aspiration. You have to go for bone marrow biopsy. In biopsy, you will be having fried egg appearance. So this is about hairy cell leukemia. And one of the important drug we'll be giving in the treatment of hairy cell leukemia is cytarabine. Okay. So we have excluded that is completely different. So pancytopenia with no organomegaly is aplastic anemia. So what is aplastic anemia? Aplastic, that means there are no precursor cells. That is the reason there is anemia. The name says it's anemia, but all the cell lines are involved. So your bone marrow is completely replaced by fat. So there is nothing in the bone marrow. It's bone marrow aplasia resulting in anemia. Aplasia, no cells. Your bone marrow is completely replaced by fat. So all the cell lineages are decreased. So this is an example of hypocellular bone marrow with pancytopenia. So whenever there is pancytopenia, yes, organomegaly is important. Along with that, your bone marrow is important. Because hypocellular bone marrow with pancytopenia is typical example. The typical example is aplastic anemia. Whereas hypercellular or normal cellular bone marrow with pancytopenia, that is MDS. That is myelodysplastic syndrome. So they are totally different diseases but presenting with pancytopenia. Both will be DDs when you are evaluating a case of pancytopenia. That is why we are discussing them together. So now let's look into the causes of pancytopenia with hypocellular bone marrow and cellular bone marrow. It's very important. See, hypocellular bone marrow, the only thing you should know is aplastic anemia. The cause can be acquired or inherited. Any cause, aplastic anemia, it's hypocellular. Whereas cellular bone marrow, the most important thing is myelodysplastic syndrome. Other important things are your PNH, myelofibrosis, hairy cell leukemia. Or secondary to systemic diseases, because the cells are killed peripherally, for suppose SLE, autoimmune destruction of cells, hypersplenism, all the cells are being sequestered in the spleen. Your B12 and copper deficiency, cells are not produced properly. Alcohol and infections are important. Your HIV, brucella, TB and leishmania will cause pancytopenia with cellular bone marrow. Why? Because they will be infiltrating into the bone marrow. Even sarcoid will be infiltrating the bone marrow, resulting in cellular bone marrow with pancytopenia. Okay, we have known the causes of pancytopenia. In that, with hypocellular, the most important cause is aplastic anemia. So this aplastic anemia can be acquired. What is the etiology? Why bone marrow is replaced with fat cells? Acquired or inherited or constitutional. So why are we more interested in the inherited causes of aplastic syndrome? Because there are these syndromes. Fanconi's anemia. The name says anemia, but all the three lineages are decreased. So it's an inherited bone marrow disorder with decrease in all lineages, pancytopenia. That is Fanconi's anemia. Along with that, the case of Fanconi's anemia will be having increased risk of malignancies because it's a DNA repair disorder. Next, dyskeratosis congenita. It is nothing but pancytopenia or aplastic anemia with skin and nail changes. So this is the DNA repair disorder, and dyskeratosis congenita is a telomerase defect. Next thing, Swachman-Diamond syndrome. In this, the patient will have predominant neutropenia plus pancreatic exocrine deficiency. It's okay. If you have already read this, it's fine. If you have not read this, don't be afraid by seeing these names. Just remember the name and the condition, that is DNA repair disorder, Fanconi's anemia, you would have already known. It has a preponderance to malignancy and there is pancytopenia. And dyskeratosis congenita, the name itself says dyskeratosis, something with the skin and nail changes with pancytopenia. It's a telomerase defect. Swachman-Diamond syndrome, just neutropenia with pancreatic exocrine deficiency. And one more syndrome is Diamond-Blackfan syndrome. Nothing more I will tell about this. It is just congenital pure red cell aplasia. So RBCs are low in this. Congenital pure RBC aplasia. That's it. So when Swachman-Diamond is pure neutropenia, this is pure RBC. Not only that, your Down syndrome, Dubowitz and Seckel syndrome. Just remember Downs. Downs also can cause aplastic anemia. That's it. Nothing much. Don't be just worried about all these things. Just listen to them once. They'll be in your subconscious mind. If there is a question from this, you can answer. That's it. So these are the constitutional causes. And in acquired causes of aplastic anemia, idiopathic will be the most common, followed by autoimmune causes, autoimmune destruction of bone marrow cells. But it can also be destroyed after radiation, after chemotherapy, pregnancy, and infections like your HIV, hepatitis infections can also destroy your bone marrow, Epstein-Barr virus. So whenever there is a case of pancytopenia, we'll be doing bone marrow and we'll be sending the viral markers, EBV, Parvo B12, your HIV, everything will be sending, hepatitis viruses, because they are also a cause. That's it. These are all the causes of aplastic anemia. If they ask, it's fine, we know now. And coming to presentation, they'll present with pancytopenia. Coming to treatment, so this inherited, we cannot do anything. We can give steroids. plus anti-thymocyte globulin, ATG. So steroids plus ATG is the best treatment you can give. And you can also give the growth factors like erythropoietin stimulating agents for anemia and your granulocyte colony stimulating factors for your neutropenia and L-thrombopag for your platelets. You can substitute with growth factors. That's it. That's the treatment. That is about aplastic anemia. So basically you should be differentiating between aplastic anemia and MDS. Now you know what is aplastic anemia and what are the inherent bone marrow failure syndromes. So these are the inherent bone marrow failure syndromes. There can be a question from this, one question. If they ask, you are able to answer. Now coming to MDS. Myelodysplastic syndrome. The name itself says there is dysplasia of myeloid cells. So basically what's happening in the bone marrow, your myeloid cells are dysplastic. They are not normal. So they are killed in the bone marrow. So they are not coming out. So peripherally there is pancytopenia. That is what is happening here. That is why the bone marrow is cellular. I told you there are dysplastic cells. What are the dysplastic cells? In RBC lineage, they are sideroblasts. In WBC lineage, they are Pegler-Hewitt anomalies. The nucleus is like specks. So these are Pegler-Hewitt anomalies, not only seen in myelodysplastic syndromes, also in myeloproliferative neoplasms and AML it can be seen. So anything with myelo, it can be seen. Now coming to platelets. You can see microlobular platelets or megakaryocytes. This is about MDS, myelodysplastic syndrome. There are dysplastic cells which are killed in the bone marrow. That's why there is pancytopenia. What are those dysplastic cells? Sideroblasts in the RBC lineage, Pegler-Hewitt anomaly in the WBC lineage, and microlobular macrocytes in the platelet lineage. So, if there is 5q deletion, if it is associated with 5q deletion, it's good prognosis because it has some treatment. You can give thalidomide. Other than that, there is no specific treatment for MDS. You should give just growth factors. If there is anemia, you can give erythrocyte stimulating factors. That's it. Erythropoietin stimulating factors. And it's very poor prognosis because not much treatment is there and it will progress to AML. Can progress to AML, and MDS progressing to AML is a bad prognosis. This is just about MDS. We know now what is MDS, what is the mutation, what is the treatment, what are the abnormal cells, what is the pathophysiology. We also know about aplastic anemia. See, both are pancytopenias, but pancytopenia with hypocellular is aplastic anemia, with hypercellular is your MDS. Those are the things you should be concentrating in aplastic versus MDS. Now, next is myeloproliferative disorders. Next topic. So, in myeloproliferative disorders, it's a spectrum of disorders. In that, CML and polycythemia vera are important. So, other disorders are your CNL, CEL, myelofibrosis, essential thrombocytosis. But these two are important. CML very important. In CML, mostly they will be giving a clinical scenario, or they will give the peripheral smear, or they will be asking you about this Philadelphia chromosome. Most of the times these are the questions, and treatment also they can ask you. Treatment is very easy for CML. So the question is not a feature of CML. In CML there is massive splenomegaly. Yes, we know. Yes, there is basophilia because basophils are also myeloid cells, right? So there is basophilia. And there can be thrombocytopenia because this neutrophils, not neutrophils, the precursors of neutrophils, the precursors of basophils increased in the bone marrow, there is no space for platelets, so the platelet production can be decreased. It's possible. And blasts are never more than 20%. If blast is more than 20%, the only thing is AML. Myeloid blast more than 20%, then the diagnosis is AML. In any case, for suppose in MDS, myeloid blast has become more than 20%, it's AML. In CML, more than 20% blast, it's AML. In PNH, paroxysmal nocturnal hemoglobinuria, that can also progress into AML. In that condition also, if blast is more than 20%, it's AML. So nothing other things. So here it's less than 20%. So the first thing you should know about CML is translocation 922. This is fine, we all know this. So this is BCR ABL1 translocation. So BCR is on which gene? It's on 22. ABL is on 9. So 922 BCR ABL will be confused. We'll think BCR is on 9, but this is reverse. Okay. One more thing is, what is Philadelphia chromosome? This also you will be confused. So this translocation has happened. That translocation is called Philadelphia chromosome, or this chromosome 9 is called, or 22 is called. What is Philadelphia chromosome? So Philadelphia chromosome is your shortened. So because of this translocation, if you can see, the length of the chromosome 22 has decreased. So shortened chromosome 22 or shortened BCR, it's nothing but Philadelphia chromosome. Shortened abnormal chromosome 22 is Philadelphia chromosome. Even in my undergraduate, I used to think Philadelphia chromosome is translocation 922. So in my internship, I have realized that when preparing for NEET only, I realized that Philadelphia chromosome is an abnormal chromosome 22. Okay. So that is the thing. So because of this, the tyrosine kinase activity has increased. That is the thing, that because of that all the myeloid cells are proliferating. Now coming to peripheral blood smear. So basically these patients can be asymptomatic or present with dragging sensation, pain in the left upper quadrant because of splenomegaly, or this can be an incidental finding. And coming to CML, so my HOD of oncology, he used to say that if I want to choose any malignancy, let it be CML, because it has the best treatment, like diabetes, like hypertension. If you take one tablet per day, the CML, you take one tablet per day, it's in control. You don't have to do anything. It doesn't have much complications with treatment. So, and the expectancy is normal life expectancy. Because of CML, you're not going to die. Normal life expectancy. So, best malignancy. So, coming to the peripheral blood smear. So, one important thing you should know is AML, CML. Both are myeloid leukemias. Acute means more of blasts. Even in ALL, CLL, this will apply. Acute means more premature cells, whereas chronic means less premature cells or mostly mature cells. In fact, the blasts are very less. So mature cells, except your blast, your promyelocyte, myelocyte, metamyelocyte, band forms, neutrophils, these will be increased. Other than blasts, little bit mature and the precursor cells of WBC are increased. And this is looking like a party, right? Everyone has attended this party. So this is called college girl party appearance. College girl appearance or garden party appearance. And you can also see hypolobulate megakaryocyte here also. So these things you should not forget. In this, most common is band forms. So CML means the first thing you should remember is T922. Philadelphia is abnormal chromosome 22. It will have massive splenomegaly. And the good thing is, with treatment, our splenomegaly will come down, our cell count will come down, and the BCR ABL titers also will come down with treatment. That's a good thing, right? So our CML has phases: chronic phase, accelerated phase, and blast phase. Blast phase is nothing but our blasts are more than 20% and it is nothing but AML. Treat like AML. You can also give tyrosine kinase inhibitor. So chronic phase is, it's stable. Now if it's going into acute phase, why you should be worried? Because it can land in blast phase. So there are some features for acute phase. You will see what are those. So in acute phase, I'll tell you three things. It's a myeloproliferative neoplasm. So your WBCs should increase, your platelets should increase, there should be splenomegaly. Sometimes your platelet can also decrease. So that is what is explained here. Even after therapy, even after treatment, your WBCs are increasing, your platelets are increasing, your spleen is increasing. It is accelerated phase. And unrelated to therapy, if there is decrease in platelets, that is, some TKI inhibitors have myelosuppression as a side effect. So unrelated to therapy, not side effect of drug. Then it is coming under accelerated phase. One important thing you should know is basophils more than 20% and blast 10 to 19%. It's not clear, so we'll write here basophils more than 20% and blasts 10 to 19%. See, 20% is AML. It's almost nearing the 20%. So you should be careful. It's accelerated phase. Or on treatment, there are new mutations. There are new mutations on treatment. Then that is what this whole table is saying. Only this: increased WBC, increased platelets, increased spleen. And even with therapy, they are increasing. Basophils more than 20%, your blast more than 10 to 19%, and even on treatment there are mutations. That is accelerated phase. Now if accelerated phase term is removed, we'll be just using CML with high risk features. That is the term it's replaced with. But you don't need to know this because the recent edition of Harrison has not yet updated this. So for medicine, what book the examiner will follow, it's Harrison. If there is an update in Harrison, he'll follow that update. If there is no update in Harrison, he'll not follow this. It's not there in Harrison, so he'll not ask that. Now coming to treatment. Okay, how do you diagnose? We have seen the peripheral smear. You can do that. We have seen BCR ABL. If it's positive, peripheral smear showing this with BCR ABL positive is nothing but your CML. Coming to treatment, you should give tyrosine kinase inhibitors. What tyrosine kinase inhibitors you know? You would have definitely known imatinib, right? That is a first generation. There are newer TKIs. The newer are dosatinib, nilotinib, and bosutinib. This is first generation, these are second generation, and third generation are ponatinib. This ponatinib is presently not available in our India. Patient will import them from other countries. So these are your TKIs. So mostly we'll start the patient on imatinib. If not responding to imatinib, we'll go to second generation. If not responding to that, we'll go to third generation. That is how we'll be upscaling the treatment. So just one drug, he'll be maintained. That's it. That is about CML. It's very simple, right? Okay. So CML, you should know BCR-ABL, the peripheral smear features, accelerated phase, treatment. That's it. Next, what should we learn in lymphomas? In lymphomas, Hodgkin's lymphoma is more important than non-Hodgkin's lymphoma. In Hodgkin's lymphoma, he'll ask you the types, and sometimes he'll show you the picture of RS cell and ask you to identify. And staging, he'll ask you about the staging and treatment. Treatment not in detail, just you should know the drug names. That's it. So let's see the question and discuss these things. What are the important parts? So true about Hodgkin's lymphoma, except it's associated with Epstein fever and Erber staging. ABVD regimen is used as chemotherapy, and nodular lymphocyte predominant is a type of classical disease. This is wrong. We'll see. Hodgkin's is associated with Epstein fever. It's true. What is Epstein's fever? It's like a relapsing fever. For 2 weeks, patient will have fever. Next 2 weeks, he will be fever free, followed by 2 weeks fever. That is Epstein's fever. 2 weeks fever, again 2 weeks gap. 2 weeks fever, again 2 weeks gap. Epstein fever. Yes, the staging system used is Ann Arbor staging. And this is used for both Hodgkin's and non-Hodgkin's lymphoma. Yes, ABVD regimen is the most commonly used regimen. These are all true statements. The fourth statement is wrong because classical Hodgkin's is different. This is a different entity. This nodular lymphocyte predominant Hodgkin's lymphoma is different. They are not same thing. This is not a type of this. This both are same. We'll see the classification. Coming to ABVD regimen, what is ABVD? Adriamycin, bleomycin, vinblastine, and dacarbazine. So this regimen names in oncology are really confusing. The same D will have dexamethasone in one regimen. The same thing, the same V will have oncovin or vincristin, or O will be oncovin. They are all confusing. Only after joining my oncology and only after writing these treatments, I've written many chemo orders for ABVD, Hodgkin's, okay, it's adriamycin, bleomycin, vinblastine, dacarbazine. Only then I have remembered this. Until then, it was a confusion for me. V is vinblastine or not, D is dacarbazine or not. The names of the regimens will be confusing. And we won't be using chemotherapy drugs regularly, right? But suppose ACEs, ARBs, we'll be using them daily. We'll be seeing many heart failure patients. But cancers are not generally treated by the general physician. Only oncologists can do that. That's why the drugs are, we don't have that much touch with the drugs. Only the oncologists will know more things about chemotherapies. Okay, so this is a false statement I told you. Why that is a false statement? Because WHO has classified our Hodgkin's lymphoma as nodular lymphocyte predominant Hodgkin's lymphoma and classical. It's two types. Classical is again divided into nodular sclerosis, lymphocyte rich, mixed cellularity, and lymphocyte depleted. The most common is mixed cellularity. Mixed cellularity is most common in India. whereas the most common worldwide, or if they ask just most common, is also nodular sclerosis. So this, coming to Hodgkin's lymphoma, the incidence has been increasing now. It is bimodal, one peak in the young and one peak in the elderly. Young mostly 20 to 30 years, elderly 60 to 80 years. Two peaks. Of course, young will have good prognosis and they can tolerate the chemotherapy regimen well, and this Hodgkin's will just melt with chemotherapy, good prognosis. With chemo, it's very good prognosis. Now coming to the staging. Before staging, I told you they'll show you one cell and identify it as RS cell, right? So this is looking like owl eye appearance. This is the Reed-Sternberg cell. So this Reed-Sternberg cell, the incidence is 0.01%. So in 1000 cells, you can find one RS cell. So if RS cell is not seen, you cannot exclude Hodgkin's because it's very rare to see RS cell. Now the staging is Ann Arbor staging. So this staging, how am I doing it? By CT. I am taking the CT of the patient. Better take for PET CT so that you can also know the activity of the lymph nodes. And I will be looking which lymph nodes are involved based on the number of groups of lymph nodes and whether it's involving one side or two sides of diaphragm, and extranodal involvement, I will be classifying this. So stage 1 is single lymph node group. Stage 2 is more than or equal to 2 lymph node groups, but on the same side of the diaphragm, that is 2 lymph node groups are involved. For suppose cervical and axillary, so they are above diaphragm. Stage 3 is both sides of diaphragm are involved. For suppose mediastinal and mesenteric lymph nodes are involved, one below diaphragm, one above diaphragm, that is stage 3. And coming to stage 4, it is extranodal sites, especially your bone marrow. If bone marrow is involved, it's stage 4. Next, we'll be annotating like 1A, 1B, 2A, 2B, 2E. Annotations. A is no B symptoms. B is there are B symptoms. What are the B symptoms? Unexplained weight loss, unexplained fevers, and night sweats. So one more thing is weight loss. What is weight loss? More than 10% in the last 6 months. That is B symptoms. And coming to E, it's a localized extranodal involvement. See, extranodal involvement is there. It's localized. That is, I am giving a radiation. That area will fit into the radiation field is E. If it will not fit the radiation field is 4. So extranodal involvement which will fit into a radiation field is E, which doesn't fit into a radiation field is 4. Mostly bone marrow. If the multiple patchy bone marrow is involved, I cannot fit the whole bone marrow or whole body into a radiation field, right? So this is Ann Arbor staging. Coming to treatment, it's ABVD regimen. So this is about Hodgkin's lymphoma. We have covered everything. And one more important thing is, among these types, which has the best prognosis? Our nodular lymphocyte has the best prognosis. This thing is the best. One more thing, this lymphocyte depleted is the worst prognosis. And it is associated with HIV and EBV. That's it. These are the things we should know in Hodgkin's lymphoma. Now coming to acute leukemias. So your acute leukemias, I told you acute means more premature cells, that is blasts. It can be AML or ALL. AML is myeloid blast, ALL is lymphoblasts. So what is the difference? AML is mostly bone marrow involvement Whereas ALL, along with the bone marrow, lymph nodes, or other extramedullary structures like your spleen can be involved. That is the main difference. And when you examine in the peripheral smear, here you can see myeloblast, here you can see lymphoblast. And if you go for the markers, here myeloid markers are positive, here lymphoid markers are positive. This is MPO positive, this is PAS positive. That is how we are going to differentiate. This is AML, this is ALL. So as an undergraduate, I used to always confuse between ALL, AML, CML, CLL. I'll read them 100 times, but still I used to have that confusion. So you don't need to confuse AML, ALL, CML, CLL. See, both are myeloid, that is only bone marrow. Here both are lymphoid, that is lymphoid cells are there and they can involve bone marrow plus extramedullary sites like lymph nodes, spleen. Done. Now coming to acute. Acute means there are blasts. That is most premature cell blasts. Chronic means premature cells are there but not up to the blasts. Less premature cells or more mature cells. The same with ALL and CLL. So CML is seen in elderly. CLL also elderly. AML also elderly. ALL is seen in children. So ALL is acute lymphoblast. That lymphoid cell can be, lymphocyte can be B lymphocyte or T lymphocyte. So ALL can be BALL, TALL. TALL, where does the T cells mature? In thymus. So there will be thymus enlargement or a mediastinal mass in TALL, especially in an adolescent. So this is the basic difference. No need to confuse. They are totally different. So after getting a clarity, I am confused why I am confused. So no need to confuse. Okay. So one important thing is AML is more than 20% blast, I told you. If there are more than 20% myeloblast, that is AML. But there is one more thing in AML, that is recurrent cytogenetic abnormalities. If this recurrent cytogenetic abnormalities are there, even if the blast count, I am not concerned about the blast count. It can be anything. Less than 20 also, no problem. That is AML. So recurrent cytogenetic abnormalities are present. It's AML irrespective of blast count. So what are those recurrent cytogenetic abnormalities? Yes, T821. Yes, T16. Yes, T1517. This is nothing but your PML RARA mutation seen in APML, acute promyelocytic leukemia. And the treatment is ATRA, all trans retinoic acid plus arsenic trioxide. That is about T1517. So in AML, there are multiple types: promyelocytic, myelocytic, eosinophilic, monocytic, erythrocytic, megakaryocytic. Megakaryocytic is seen in Downs, we'll see that. But in those types, why APML is different? Because it has a good prognosis. By this treatment, it's completely curable. That is why APML you should identify, and the treatment is also different. For other AMLs, the treatment will be daunorubicin plus cytarabine or azacitidine. But here, this is ATRA plus ATO. The treatment is also different. That's why you should differentiate. Whereas T922 is not a recurrent cytogenetic abnormality, and in fact, it's absent in AML. So coming to our T922, it's positive in CML. It's positive in ALL. It is called pH positive ALL and it's a bad prognosis. Okay. So in AML, it's not there. So if these three are there, these three are called recurrent cytogenetic abnormalities in AML. And if they are present, it is AML irrespective of blast count. So that is what is given here. This is the new WHO classification of AML. Previously, we used to use FAB, French, American, British. That is M0, M1 to M7. We used to use that, right? But now that has changed and we are using WHO classification. In WHO, it is with recurrent genetic abnormalities. We have seen A21 and 16. And PML RARA. MDS associated AML, I told you MDS can progress to AML and this has the bad prognosis. And it can be not otherwise specified, no specific thing. Or it can be associated with myeloid sarcoma. Myeloid sarcoma is a tissue tumor, not bone marrow involvement, a tissue tumor. If suppose eye is the most common involvement where your myeloid blast will be infiltrating and resulting in the formation of tumor. That is myeloid sarcoma. That is most common in your M2. We'll see what is M2. And Down syndrome associated. Now coming to Down syndrome associated AML, it is good prognosis because it will respond better with the treatment and treatment also low doses are needed. So in Down syndrome, it is M7 or megakaryocytic type. And one more thing you have to remember is it is associated with GATA1 mutation. And they will have transient abnormal myelopoiesis. Transient abnormal myelopoiesis, GATA1 mutation, progress into AML. That is what is happening in Down syndrome and it's good prognosis. See, everything I'm telling you is a key point. It's a probable question in this topic. So this is the WHO classification of AML. In peripheral blood smear, this is how you will be, not peripheral blood smear, not only peripheral blood smear, even in bone marrow, you will be seeing these blasts. These are myeloblasts. How do I know? Very good cytoplasm with multiple granules and multiple nucleoli in the nucleus. There are OR rods, this pink color rods. If you see this cell, if you concentrate on this cell, this part, there are multiple rods there. So OR rods means myeloblast. But if this many multiple OR rods are there, that is called fagot cell. And it's nothing but promyelocyte. And it can be APML. If promyelocytes are more, it can be APML. Especially this cell is more like a promyelocyte. Here just granules are seen. So this is what you will be seeing on peripheral smear and you will be identifying this as AML. And after identifying this as AML, we will be doing genetic testing to know these translocations, just to know the prognosis. For diagnosis, we are never using these translocations. They are just for the prognosis. And if there is any target treatment, you can add the target treatment. Just by doing the bone marrow and peripheral blood smear, the blasts and the markers for that blast, that's it. The diagnosis is done. Only for prognosis, we are going to cytogenetics. Okay, before going further, we will be looking into the worst prognostic factors in AML. So increased age, leukocytosis, more increased WBC count at the presentation, and presence of FLT3 mutation. See, CEBPA mutation is good prognosis. This FLT3 mutation is worst prognosis. But this FLT3 has a target, a drug called midostaurin will act on FLT3 mutation. So any patient with FLT3 mutation, we are giving this drug. That is the reason after the invention of this drug, FLT3 has been moved to intermediate prognosis. So it's a worse prognosis, not good intermediate only, no, right? So these are the worst prognosis in AML. Elderly age with leukocytosis with FLT3 mutation. If it is CEPPA mutation or T1517, inversion 16 or T814, they are good prognosis. If there is inversion 5, inversion 3, they are bad prognostic for AML. So basically you should know this FLT3 and CEBPA mutations, that's it. And coming to ALL, we have discussed about AML. ALL can be BALL or TALL, we discussed. T is presenting with a mediastinal mass in adolescents. BALL mostly occurs in children. When there is bad prognosis for BALL, any BALL in adult is bad. If the WBC counts are more at the presentation, it's bad. If there is CNS involvement, in CSF there are blasts, it's bad. If there is hyperploidy, more than 46 pairs of chromosomes, it's bad. Next, bad response to treatment. So especially in ALL, if you give steroids, there should be a good response. The blast number should decrease. But even after giving steroids, the blasts are not decreasing. So these are all the bad prognostic in ALL. In peripheral blood smear and in bone marrow, you will be seeing lymphoblast. That is the main difference. Okay. So we'll take a short break. After that, we'll continue hematology. So most of the hematology has been done. Only few malignancies and coagulation disorders. After break, we'll meet.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Okay, welcome back. So we are doing overview. In that, in hematology, we are now at plasma cell disorders. Which parts to concentrate in plasma cell disorders? Basically, plasma cell disorder is not a single term, it's a spectrum. So that spectrum is important. What is MGUS, small ring myeloma, and what is multiple myeloma? So this is a spectrum. How to differentiate that you should know. And in multiple myeloma, you should know the criteria. That's it. Based on the criteria only, they'll frame the question, like patient is having renal failure, bone lytic lesions, and in bone marrow there are plasma cells. What is the probable diagnosis? And they can give you a peripheral blood smear which is having multiple myeloma cells, that is plasma cells. That much only that much questions. So we'll see the question. 60-year-old, elderly. So everything is important. Key points. Chronic lower backache. He's being evaluated for renal disease. So renal disease with anemia. Chronic backache. And the serum protein electrophoresis is showing M spike. So he's asking the definitive investigation. So this can be probably multiple myeloma. So to prove it as multiple myeloma, first thing, the important thing is there should be plasma cells. Along with that, there should be myeloma defining events. One of the myeloma defining events is anemia, other is renal disease, bone lytic lesions. Not just one, 3 are there. But for definitive diagnosis in bone marrow, I want to prove more than 10% plasma cells. For that, I want to do bone marrow aspiration and biopsy. So if I do cytogenetics based on some mutations, especially chromosome 14 mutations, they will have bad prognosis. Always in any malignancy, cytogenetics is only for prognosis. You don't diagnose it. Either for prognosis or any drug targets. Serum free light chain ratio, your lambda kappa ratio, if anything is increased, it indicates monoclonality. Monoclonality is there, but I want the number of plasma cells in the bone marrow. Immune electrophoresis also states that whether it's kappa type, IgGMA, which type of plasma cell it is, kappa or lambda type or IgGMA. Among this, the kappa is most common and IgG is most common. So this will be the most common multiple myeloma. So bone marrow aspiration and biopsy, in that you will be seeing the plasma cell. These are the immunoglobulin inclusions. They are grape-like inclusions, right? Just like grape. Okay. So everything here lies around the criteria. First, we'll see the criteria. So the criteria is International Myeloma Working Group criteria. So the major thing is plasma cells plus myeloma defining events. What are the myeloma defining events? CRAB we know, but recently SLIM is also added to it. We'll see what is SLIM. Bone marrow, plasma cells more than 10%, and they should be monoclonal or biopsy proven plasmacytoma. What is this plasmacytoma? Just the plasma cells, the malignant plasma cells are infiltrating into a tissue. That biopsy is showing plasma cell leukemia. Plus any one of the following. What is that? CRAB. SLIM. So we all know CRAB. C is hypercalcemia. B is bony lytic lesions. So what's happening in multiple myeloma is the osteoblasts are inhibited. The osteoclasts are stimulated, resulting in lysis of the bone or resorption of bone. That's why there are bony lytic lesions. When the bone lysis or resorption of bone is happening, there is increase in calcium. So that is what is explained. And due to excretion of this light chains, this myeloma is light chain myeloma. Many light chains are produced. Those light chains are excreted in the urine as Bence-Jones proteinuria. But it can cause glomerular damage, tubular damage, resulting in renal failure. And there can be amyloidosis, light chain amyloidosis, which can cause renal failure. Your hypercalcemia, hypercalciuria, renal stones can also cause renal failure, many causes. And anemia. Your bone marrow is full of plasma cells. There is no space for your precursors of erythrocyte to mature and to be released. That's why there is anemia. So this is CRAB criteria. SLIM is more than 60% plasma cells. So if there are more than 60% plasma cells in bone marrow, no CRAB is not needed. L is light chain ratio. More than 100. So it conveys that it's a monoclonal disorder. And M is MRI is showing lytic lesions, bony lytic lesions. Here it's more than 1. Here it's CT is showing lytic lesions more than or equal to 1. That is CRAB-SLIM criteria. And these lytic lesions are most common on the skeletal, that is your spine. You can also see it in the skull, but spine is the most common site. So this is the criteria for plasma cell multiple myeloma, better diagnosis, better term. Okay. Now I want to prove it is monoclonal. See, See, these plasma cells can be monoclonal or polyclonal. First, suppose there is some infection in your body like TB. It is both T cell and B cell mediated action on the TB, mostly T cell. For B cell to release antibodies, B cell should convert into plasma cell. Only plasma cell will produce antibodies, right? So in such infections also there will be increase in plasma cells, but that is not monoclonal, it's polyclonal. All lambda kappa chains are equally produced, but here it's monoclonal. Lambda kappa chains are specific, only lambda producing, only kappa producing. So to prove that monoclonality, first we'll be doing serum protein electrophoresis. In serum protein electrophoresis, I will know that the globulins are increasing. That in globulins, I'll get a band, M band. And I will measure that band, M protein. I will measure it. Next thing I'll do is serum immunofixation electrophoresis. This serum immunofixation electrophoresis gives me whether this is IgM type or IgG type, A type, kappa or lambda type. Next thing is serum free light chain ratio. That is what we have done here. It should be increased. So by these tests, I will be proving the monoclonality. Excuse me. Okay. So these are the lytic lesions. So these are irregular lytic lesions. These lytic lesions are different. Where do you see salt and pepper skull? Multiple small lytic lesions. You see that in hyperparathyroidism. So that is different. Here the irregular lytic lesions are different. Now coming to the spectrum. Now we know the diagnosis of multiple myeloma. Let's look at the spectrum. Monoclonal gammopathy of unknown significance, smoldering myeloma, and multiple myeloma. So multiple myeloma is your plasma cells more than 10% with myeloma defining event, one myeloma defining event. But here there is no myeloma defining event. Your crab, sling, nothing is there. Just your M protein is increased. But here it's less than 3 grams. Here it's more than 3 grams. And your plasma cells are 10 to 60%. More than 60% is multiple myeloma. More than 10% with myeloma defining event is also multiple myeloma. But here they are 10 to 60%, no myeloma defining events, but the M protein is slightly increased. Why it's important to diagnose it? Because it can progress. Next, coming to the treatment, and this renal failure is reversible. With treatment, it's reversible. Very good. Come to treatment, we can give dexamethasone, thalidomide, lenalidomide, and ponalidomide. And one more new drug, daratumumab. This is monoclonal antibody against CD38. CD38 is one of the marker of plasma cells. We'll be also giving bortezomib, protease inhibitors, bortezomib or carfilzomib. So there are various regimens in which we'll be mix and matching all these things. So these are basically drugs used in multiple myeloma. So multiple myeloma, we have seen the spectrum, the criteria, the treatment, the peripheral blood smear, and the bone marrow showing the plasma cell. We have seen the morphology of plasma cell, and the plasma cell, it's CD38 and 138 positive. So the target for this is daratumumab. Okay. Now we have done with the RBC part and the WBC part. Let's look at platelet and coagulation disorders. So in these things, there are two things, bleeding disorders and coagulation disorders. In bleeding disorders, there is decrease in platelets or platelet function dysfunction. So thrombocytopenia and platelet dysfunction disorders you should learn. And in coagulopathy, vitamin K dependent factors, hemophilias, von Willebrand disease, and DIC. These disorders are very simple to understand. These things are the important parts of this. And your PT, APTT, TT, what is the significance of those tests? What is BT, CT? You should know, that's it. Let's solve this question and discuss about the bleeding disorders. 15-year-old female, very young female. See, note down, everything is important. It's a female with left elbow hemarthrosis. So left elbow hemarthrosis, that is deep bleed. So it's a coagulation disorder or bleeding disorder. It's a coagulation disorder. So bleeding disorders, that is platelet abnormalities, they will present with superficial bleeds, mucosal bleeds, skin bleeds, and superficial early bleeds. Whereas your coagulation disorders, due to deficiency of your coagulation factors, they will present with deep bleeds, ecchymosis, your visceral bleeds, IC bleeds, splenic bleeds. See this bleeding into the joint, bleeding into the muscle. These are all coagulation disorders and they are delayed bleeds. So this is definitely a coagulation disorder in female. And there is similar family history in her brother and father. So, two consequent generations, male and females are affected. So, this is autosomal dominant. If there is skipping of generations, it's autosomal recessive. Only maternal males are involved, it's X-linked recessive. CT and BT both are prolonged. We thought it's only a coagulation disorder because of deep elbow bleed, but BT is also prolonged. CT is prolonged in coagulation disorder, BT is prolonged in bleeding disorders. In coagulation disorders, the PT is normal, APTT is prolonged, and there are normal platelets. Okay. So APTT indicates, prolongation of APTT indicates there is a problem in which pathway, extrinsic pathway or intrinsic pathway. APTT is intrinsic pathway. PT is extrinsic pathway. So now coming to intrinsic pathway, what are the factors present? Your factor 12, 11, 9, 8. So factor 12 deficiency, there won't be much bleeding because even if factor 12 is absent, factor 11 can be activated and your intrinsic pathway will continue. So absence of factor 12 is not much significant. Next, factor 11, 9, 8. These are all hemophilias. Your hemophilias are your hemophilias are X-linked recessive. So I told you X-linked recessive, only maternal males are affected. Females are only carriers. Maternal males means mother, brother, mother, father. Mother side, maternal males will be affected. Only maternal males. Whereas mother will be the carrier. So hemophilias are X-linked recessive. So that is not an option. Yes, that is a coagulation disorder, but not an option. Whereas immune thrombocytopenia, the name itself says thrombocytopenia because of immune destruction. Here the platelets are normal, there is no thrombocytopenia. Next, von Willebrand deficiency can be an option, we'll discuss. And coming to vitamin K deficiency, initially PT is prolonged because vitamin K dependent factors are 2, 7, 9, 10. In that the shortest half-life is 7. So initially PT will be prolonged followed by PT plus APTT prolongation. Here only PT is prolonged, so exclude. Why von Willebrand factor? What is the function of von Willebrand factor? See, von Willebrand factor has two things. It is important for platelet adhesion and aggregation. And it's also important to maintain the T half of factor 8. So normally with the help of von Willebrand factor, our factor 8 T half is 12 hours. If von Willebrand factor is not there, its half-life will be 2 hours. So for the function of factor 8, so it's involved in coagulation pathway. And it's also helping the platelets. So von Willebrand deficiency can be both bleeding disorder and coagulation disorder, right? That is what we are seeing it. And it is autosomal dominant. So this is an apt presentation of von Willebrand disease. So any hemophilia like presentation in a female is von Willebrand disease. That is what you can remember. So I purposefully selected this question because most of you will be answering it as hemophilia A if you have not looked at female. And one more thing is BT is prolonged. If you have not been keen about those things, you would have marked it wrong. So everything is important. Correlate everything. Just first option hemophilia A, okay, done. Next options you have to rule it. Even your first option is correct. Looking at other options, ruling out them is very important because every question matters, right? So this is your PT is measuring the extrinsic pathway. APTT is measuring the intrinsic pathway. And thrombin time is measuring the common pathway. So PT is prolonged extrinsic, APTT intrinsic, TT common pathway. If all these is normal, then factor 13 deficiency can be there. There is coagulation disorder, but still PT, APTT, TT are normal, factor 13 deficiency. For this, you have to do urea lysis test. So this is about coagulation disorders. We have discussed everything. Hemophilia, the same presentation, but in males. Okay. One more important thing is, how do you treat these things? First thing is, you can give FFPs. Fresh frozen plasma has all coagulation factors. It's good to go. Or you can go for cryoprecipitate. In cryoprecipitate, there is factor 8, factor 13, fibrinogen, and von Willebrand factor. So in von Willebrand disease and hemophilia, you can give cryoprecipitate. Or you can give recombinant factor 8. That is what we'll be giving. Or recombinant von Willebrand factor. So most of the hemophilia patient will be coming, most of them hemophilia A or B will be coming for factor 8 or factor 9. So 8 is A, 9 is B. They'll be coming for factor transfusion whenever there is bleed, right? And von Willebrand disease, one more important thing is you can give desmopressin. This desmopressin is a vasopressin analog, will act on the V2 receptors. This will stimulate the release of von Willebrand factor from the endothelium of the blood vessels. So you can also try desmopressin in von Willebrand disease. Next, coming to platelets, that is about coagulation disorders. Now let's see about bleeding disorders. BT is increased. So some problem with platelets. That can be quantitative or qualitative. See, quantitative is BT is increased and thrombocytopenia is there. Whereas qualitative means BT is increased. The platelets are normal, but the function of platelets has been decreased. So qualitative, that is thrombocytopenia, can be due to many causes. Till now we have discussed many bone marrow conditions where there can be pancytopenia. In all those conditions, there can be thrombocytopenia. Other than those in ITP, because of immune destruction. In TTP, thrombotic thrombocytopenia, we'll see what will happen in this. In DIC, there is peripheral destruction of platelets. In SLE, all these things, the platelets are destructed. And coming to qualitative, the disorder of platelet adhesion. I told you for adhesion, you need von Willebrand factor, that is absent. So in von Willebrand disease, the BT is increased and the platelets are normal because it's qualitative. The same thing we have discussed here. The normal platelets with increased BT. So the function of platelets is decreased even though platelets are normal. And for adhesion, which receptor is important? GP1B9 or 2B3A? GP1B9. Next, for platelet aggregation. What receptor is needed? GP2B3A. And we need fibrin for aggregation. So A, fibrinogenemia. So the defect in GP1B9 is called Bernard-Soulier syndrome. In GP2B3A deficiency, it's called Glanzmann's thrombasthenia. So these names are important. They can ask you what is Bernard-Soulier, what is Glanzmann's thrombasthenia. And they are autosomal recessive. So to diagnose this, we will be doing platelet function test. In platelet function test, I will be adding ristocetin. So with ristocetin, the platelet function has improved. It means it's a platelet adhesion disorder. With ADP or collagen, the function has improved, then that is a platelet aggregation disorder. Indirectly, in Bernard-Soulier, ristocetin. Glanzmann's thrombasthenia, ADP and collagen. These are the things they are going to ask you. And one more important thing is TTP-HUS. Thrombotic thrombocytopenia. So there is formation of thrombus with thrombocytopenia. Thrombosis plus thrombocytopenia, one of the important thing you should suspect is TTP-HUS along with that PNH. So why there is thrombosis plus thrombocytopenia? Only thing you have to remember is there is Adams 13 deficiency. It can be immune or congenital deficiency. What is the normal function of this Adams 13? So this is normal Willebrand factor. This long multimers are broken into short multimers with the help of Adams 13. Now if this Adams 13 is not functioning, in your blood there are long multimers of von Willebrand factor. So they will attract the platelets and they will form a thrombus. Because the platelets are in the thrombus, in the peripheral circulation, the platelets are decreased, resulting in thrombocytopenia plus thrombosis. So it's basically Adams 13 deficiency. How do you diagnose it? When do you suspect it? Thrombosis plus thrombocytopenia, you'll suspect it. Test for Adams 13. So one more important thing is this blood supply to kidneys is decreased. The same thing, thrombus in renal artery, kidneys, the blood supply is decreased and there can be renal failure. So thrombocytopenia, renal failure, and through this narrow passages our RBCs are traveling. There will be shear stress resulting in hemolytic anemia. That is called microangiopathic hemolytic anemia, MAHA. And this triad is typical of TTP, thrombocytopenia, renal failure and MAHA. Whereas HUS, it's a pentad. It's fever, altered sensorium, thrombocytopenia, renal failure and anemia. This is hemolytic uremic syndrome. It can be atypical or typical. Typical is acquired following Shigella infection. Atypical is complement factor deficiencies. So this HUS and TTP are like a spectrum. That's why we'll be using a term TTP HUS, not separately. Okay. So this is TTP. What's happening in DIC? Disseminated intravascular coagulation. The name itself says. Due to some pathology, some insult like sepsis, pneumonia, burns, due to some insult, your vascular endothelium has been damaged. When there is damaged vascular endothelium, there is a clot formation. For this, platelets and clotting factors are utilized. They have been utilized. Consumption. So in the peripheral blood, your platelets and coagulation factors are decreased. So in other sites, there will be bleeding. So in some other site, there will be bleeding. Why? Because of consumptional coagulopathy and consumptional thrombocytopenia. It's consumptional. What happens to serum fibrinogen? Serum fibrinogen is also a coagulation factor that has been utilized for thrombus. It will decrease. What happens to serum D-dimer? So what is D-dimer? Whenever there is a thrombus and the thrombus is lysed, you can see a D-dimer. D-dimer is nothing but fibrinogen degradation product that is increased because more fibrin formation. So this is a typical scenario for suppose in a case of sepsis or a case of intrauterine death of fetus, a case of burns presenting with multiple bleeds, the platelet has decreased, the PT, APTT prolonged. You will be looking for serum fibrinogen and D-dimers, and if they are in such ranges, you will suspect DIC. Of course, the treatment is symptomatic and treating the cause. So this is DIC. These are the important things you should know in coagulation and bleeding disorders. So this is about hematology. So 3 parts, your anemias. In anemia, you should know classification of anemias: microcytic, macrocytic, micro iron deficiency, macro your B12 deficiency, your hemolytic anemias. In that, autoimmune hemolytic anemia and PNH, sickle thaler are important. Next, coming to your WBC, your acute and chronic leukemias, myeloproliferative disorders, MDS, aplastic anemias, all are, and multiple myeloma. These are important. In platelets, your bleeding and coagulation disorders are important. These things you should not miss before going to the exam. Okay, there is one more topic in hematology. We'll see that and go to next thing. This is very simple. All are hypercoagulable states. So hypercoagulability is one of the risk factor for thrombosis, thrombus formation. Wherever there is stasis and hypercoagulability, there is thrombus formation. So what are those hypercoagulable states? So this thrombus can be in the veins of your lower limb causing DVT, or this can be in the cerebral venous sinuses causing CSVT, your pulmonary artery PTE, or your hepatic veins Budd-Chiari, or your portal vein thrombosis. These are the most common presentations, but it can be in any artery or vein. Artery or venous thrombosis. Few diseases produce arterial thrombosis commonly, few diseases produce venous thrombosis commonly. So why there is hypercoagulable state? Protein C deficiency, protein S deficiency, factor V latent mutation, and ITP. So in ITP there is immune destruction of platelets, that's it. No, not prone for thrombosis. If this option would have been TTP, that would have been correct. So causes decreased anticoagulation factors. The factors which normally decrease coagulation are decreasing, like your protein C, protein S, and factor V laden mutation. What is this factor V laden mutation? See, normally your factor V will be inhibited by protein S. That's a normal thing. Now, because of this laden mutation, this thing is not happening here. So, factor V activity is increased, resulting in coagulation, more thrombosis. Antithrombin 3 deficiency. So, these are decreased. And prothrombin mutations. Prothrombin mutation resulting in more thrombin formation. So these are the decrease in anticoagulation factors. And there are some systemic conditions which are prone for thrombosis, like our PNH just now discussed, and TTPs, APLA. These are the disorders more prone for thrombosis. And other thing is hyperhomocystinuria or cystinemia. Homocysteine is increased. So whenever you are evaluating a case of unprovoked thrombosis, for suppose DVT, a case of surgery or more prolonged bedridden cases presenting with DVT, okay, that's a provoked DVT. But without any risk factor, there is DVT, deep venous thrombosis, or any thrombosis, you have to look for all these prothrombotic conditions. We will be sending for protein C, protein S, antithrombin 3, prothrombin mutations, factor V laden mutation. We'll be sending for homocysteine levels, and we'll be looking and ruling out all the systemic conditions. Not only this, malignancies. Few malignancies are prone for this. Okay. Here, it's not ITP, protein C deficiency, S deficiency, and factor V laden mutation. Yes, they are hypercoagulable states. Coming to APLA, only two things, recurrent pregnancy losses and thrombosis. So recurrent pregnancy loss plus thrombosis. The thrombosis is more venous more than arterial. If these two are present, you will be testing for anticardiolipin, anti-beta-2 microglobulin, and anti-lupus anticoagulant. All these antibodies will be testing, and if they are present along with these things, it is APLA. That's it. This is about hematology. Next system, most simple system is respiratory system. So in respiratory system, what should you learn? The infections are most common. So previously there was a COVID pandemic, so they asked questions on COVID. Maybe this year they may not be asking. So there were many questions on COVID and TB. TB is most important. And previously they used to ask more questions on asthma and COPD, but now it's all about respiratory failure, ARDS, your lung malignancies. So these topics you should not miss. They are very easy. Anyways, asthma, COPD we will be reading. They are important, but the question trend has changed in respiratory system. So these topics we should not miss. Okay, coming to respiratory failure, the first topic of the respiratory system, you should know the types of respiratory failure and the differences between type 1 and type 2. So the question, so each topic will be taking up the question and looking into the important things. False statement about type 1 respiratory failure is, so type 1 is hypoxemic. So decreased PaO2 is fine, but increased PCO2, no, hypercapnia is not there. It's not a feature. We'll see why. Increased AA gradient, yes, it's a diffusion defect. That's the reason the AA gradient has increased. So that is the same thing given here. Basically, type 1 respiratory failure versus type 2. Yeah, you answered it correct. Type 1 respiratory failure is hypoxic. Type 2 is hypercapnic. So this is your alveoli and this is your pulmonary artery. So in lung, everything is about ventilation, perfusion. So ventilation is the air entering into the alveoli and perfusion is the blood flow in the pulmonary arteries. Ventilation, perfusion. Your type 1 is diffusion defect. The oxygen from the air in the alveoli is not diffusing into the pulmonary artery. Whereas type 2 is ventilation defect. The air is not entering into the alveoli. So type 1 is diffusion defect. Type 2 is ventilation defect. So A is the oxygen in the alveoli. Small a is the oxygen in the artery. So when you look at the oxygen in the alveoli versus artery, here because it's a diffusion defect, it's increased. For suppose here there is 90. The diffusion is abnormal, so it will be 40 here. In ventilation defect, the oxygen reaching the alveoli itself is very low, but everything is perfused. The AA difference is low or normal. That is the AA, alveolar arterial oxygen gradient. So this is alveolar arterial oxygen gradient. So what happens in type 1 is your oxygen diffusion is affected. So there is hypoxia. But even though there is diffusion defect, your carbon dioxide is more soluble. So somehow the carbon dioxide is expired out. So normocapnia. Carbon dioxide in the body is not increased. Whereas in hypercapnic or type 2, your oxygen diffusion is good, your carbon dioxide diffusion is good, but the ventilation is not there. The air is not coming into the alveoli only. So the carbon dioxide is not going out, oxygen is not coming in, resulting in hypoxia, hypercapnia. Got me the difference? So hypoxia is there in both, but hypercapnia, type 2 respiratory failure, increased carbon dioxide. So type 2 respiratory failure, that is what? Hypercapnic. Respiratory acidosis. So respiratory acidosis, type 2 respiratory failure, hypercapnia, everything is same. There are other types also. Type 3 is post-op anesthesia related respiratory failure. Type 4 is due to shock. Due to shock, the blood supply to the lung is decreased. That's why there is respiratory failure. So these are type 3 and type 4. Not much important, but you should know the difference between type 1 and type 2. So which diseases are causing type 1 respiratory failure? That is diffusion defect. For suppose there is fluid in the alveoli, consolidation, the diffusion is decreased. And there is pulmonary fibrosis. There is interstitial fibrosis and thickening of the interstitium. The diffusion is affected. Where do you see type 2 respiratory failure? The ventilation has decreased. Severe asthma, bronchoconstriction, the ventilation to the alveoli is decreased. And COPD, chronic obstructive pulmonary disease. This is also airway disease, but this is a terminal airway disease where the ventilation of the alveoli is decreased. Next, central apnea. There is respiratory depression, respiratory center depression due to damage or nerve palsy. All these causes can cause ventilation defect. All these causes can cause diffusion defect. So if you know it's a diffusion defect, it's a ventilation defect, everything is sorted out. So hypercapnia is seen in type 2 respiratory failure. The same thing is given here. Okay. Next question. Obstructive restrictive pulmonary diseases. So you should know the difference of pulmonary function tests in obstructive diseases versus restrictive diseases. And what are the obstructive diseases? What are the restrictive diseases? The main important thing is FEV1 by FVC. FVC is forced vital capacity. What is forced vital capacity? You will take a deep inspiration and will do a deep expiration into the spirometer. Your forced inspiratory volume, your expiratory volume, your tidal volume, everything is there in this. That is forced vital capacity. So in this thing, I will be looking at in the first minute how much you are able to blow out. That should be more than 70%. If that is decreased, for suppose there is some airway disease, there is some expiratory obstruction, he will blow out everything, but it will take more time, not in the first thing. So in obstructive diseases, let's write it properly. Normally is more than 70%. Obstructive versus restrictive. FEV1. In obstructive, it is decreased. In restrictive lung disease, for suppose interstitial fibrosis of lung or some chest wall disorder, your lung volume is decreased. That's why there is restriction to lung expansion. But the airways and everything are normal. So your FEV1 will be normal. Now coming to forced vital capacity. The capacity of the lung to expand. The airways are problem here, but the lung can expand, right? So this FVC is normal here. Here, the lung expansion is problem. So this will decrease. So what will happen to the FVV1 by FVC? Here it's decreased. Here it's normal or increased. That is the basic difference. What are your obstructive diseases? It is COPD. So COPD can be both emphysematous or bronchitis type. And your asthma and bronchiectasis. These are your obstructive diseases. What are your restrictive diseases? Your restrictive diseases are ILD, your chest wall disorders, and neuromuscular disorders. Those are the restrictive disorders. So the muscle disorder, not able, so the lung is restricted to expand. So here FVV1 by FVC is decreased in, so definitely obstructive. Obstructive is asthma. So your skeletal disorders and interstitial fibrosis of the lungs all are restrictive. So this is what is the forced vital capacity I was telling. Inspiratory capacity, not inspiratory capacity. Your inspiratory reserve volume plus tidal volume plus expiratory reserve volume is nothing but your forced vital capacity or vital capacity. So you will be taking a deep breath and expiring against the spirometry. You would have seen patients doing spirometry, and immediately after doing spirometry, it will give you the report. What is the FVC, what is the FEV1, what is the tidal volume. And one more important thing here is diffusion capacity of lung for carbon monoxide. So the diffusion capacity of the lung is nothing but the diffusion. So anything with type 1 respiratory failure, the diffusion defect, it will decrease. And one important thing you should remember, in asthma, the DLCO will increase. Why? Because the neutrophils in asthma, it's a reactive airway disease with eosinophils and neutrophils in the airway. Those neutrophils will produce nitric oxide. Because of nitric oxide, your airway is dilated and there is more diffusion in the lungs. This DLCO is also important. They can be a question. FEV1 by FVC. Now coming to pneumonias and tuberculosis, which is the most important topic. So what is multi-drug resistant TB? So TB can be monodrug resistant, multi-drug resistant, pre-XDR TB, pre-extensive drug resistant TB, and extensive drug resistant TB. So mono means any single first line drug. Maybe your isoniazid. But the important thing to remember is, if it is resistant to rifampicin, just the single rifampicin, it is equal to multi-drug resistant. The treatment will be same. So multi-drug resistant or rifampicin resistant TB, both of them, the treatment is same. And what is multi-drug? Two important first line drugs, that is your rifampicin and isoniazid. If it's resistant to both, it is multi-drug resistance. Next, pre-XDR TB is your MDR TB plus your fluoroquinolones. Whereas XDR TB, your MDR plus fluoroquinolones plus group A drugs. So recently for drug resistant TB, they have divided the drugs. So what are the group A drugs? They are bedaquiline, clofazimine, and cyclosporine, and fluoroquinolones. Anyways, resistant to fluoroquinolones is pre-XDR TB. If it's resistant to oral bedaquiline or clofazimine or cyclosporine, it's called XDR TB. So now the definitions have been changed. Previously there used to be only XDR. Now it's pre-XDR, XDR. Okay. What is the treatment of drug resistant TB? So drug sensitive TB, you know the treatment. HRZE, HRE. 2 months, 4 months. It's same for everything. But drug resistant TB, the treatment is different. So we can give shorter oral regimen. This shorter oral regimen is a newer regimen. It's important to know. So shorter oral regimen, when can you prefer this? When there is rifampicin resistance, when there is isoniazid resistance, but only through one gene, INHA or CATG, not both. And patient have not been exposed to these drugs, no exposure. And the disease is not severe. In all these cases, you can use shorter oral regimen. So what is this shorter oral regimen? So this is 6 months plus 9 months. So what are the drugs? There are many drugs. I'll be writing a list. Okay. So these are the drugs we'll be using for first 6 months. 6 months. It's isoniazid, bedaquiline, clofazimine, ethambutol, ethionamide, and fluoroquinolone. And next, it's first 9 months, next 6 months. Next 6 months, we'll be just using clofazimine, 4 drugs, plus ethambutol, plus levofloxacin. So fluoxetine you are using is levofloxacin, plus pyrazinamide. We are also using pyrazinamide here. Yeah, very long list of drugs, but this is the shorter oral regimen. So how to remember this? See, almost the first line drugs. High dose isoniazid is there. Your ethambutol is there. Pyrazinamide is there. Other than that, your group A drugs, bedaquiline and clofazimine is, and levofloxacin is there. Extra ethionamide. So in the next 6 months, it is SELP, clofazimine, ethambutol, levofloxacin, and pyrazinamide. And there is one more thing called, if the patient is not able to tolerate orally, we can give shorter injectable regimen. In injectable regimen, it's the same thing. We'll be replacing the oral drugs by IV drugs. What are the oral drugs here? Bedaquiline. Bedaquiline will replace by amikacin. And levofloxacin will be replacing by moxifloxacin. because this is the newest update in TB, this can be the question. Okay. In TB, mostly the question will be from the drugs only. The drugs are very important. Not only the regimens, the side effects of especially the first line drugs, the side effects, mechanism of action, the newer drugs should be known. They are for sure going to ask in the exam because TB is the most important topic and we are in TB endemic area. Next, coming to sarcoidosis. So, sarcoidosis is a infiltrative disorder. It can involve any organ, we know that. But we are discussing it in the respiratory system. So, what questions they can ask you in sarcoidosis? First thing is organ involvement and the signs. Mostly they will be asking you the signs in sarcoidosis. So the most common organ involved in sarcoidosis is lung. So it can basically involve any organ, but lung is seen in 90% of cases. Only after lung, everything is involved. For suppose if you are suspecting cardiac sarcoidosis, you should look for lung. If lung is not involved, just remove the diagnosis of sarcoidosis. So the lung involvement is that important. And what involvement of lung? First thing is lymphadenopathy. Your paratracheal and paracarinal lymph nodes are enlarged. Plus infiltrative lung disease. There will be infiltration or fibrosis of the lung. So this is the typical lung involvement of sarcoidosis. And one more important thing, it can also cause parotitis. It can also cause bilateral facial nerve palsy. And it can also cause typical skin lesions. So these things are important. Your signs are important. What is this? Your right paratracheal lymph nodes and bilateral mediastinal lymph nodes are involved. This is Garland sign. Next, the same thing is seen as lambda sign here. Paratracheal right paratracheal lymph nodes and bilateral mediastinal lymph nodes. And in the face, due to the uptake in lacrimal and parotid glands, it appears as panda sign. So these signs are important. Garland, lambda sign, panda sign. Treatment, we'll almost treat it like a connective tissue disorder, steroids plus steroid sparing agents. So coming to TB, all drugs are important. In TB, the first line drugs are important and the group A drugs are important. Those things you should not miss. Next, coming to ARDS. In ARDS, Berlin's criteria they will ask, causes and treatment strategies of ARDS. So what is ARDS? It's acute respiratory distress syndrome. So same like pulmonary edema, there will be fluid in your alveoli, but this is non-cardiogenic. That's why this is called non-cardiogenic pulmonary edema or shock lung or wet lung ARDS. So it presents with type 1 respiratory failure. It's a diffusion defect. So definitely pulmonary edema is not a feature. Non-cardiogenic pulmonary edema would be a best thing. Hypoxemia, yes. Hypercapnia is not seen. And reduced lung compliance is seen. See, what is lung compliance? If you have taken a balloon and you are inflating the balloon, so you are blowing the volume, air volume into the balloon. For some unit of volume, the pressure in the balloon or the volume of the balloon should increase. So for some volume, so for some pressure difference, the volume in the balloon should increase. You have done some work and the volume in the balloon is increased. If for some little work, volume is increased, more compliance. Even if you are blowing, the balloon is not inflated, that is less compliance. So compliance means how much the lung is able to expand. So because of the fluid in the lung, it won't expand much and reduced compliance. So the best option would be hypercapnia. So to choose one option, it's hypercapnia. Pulmonary edema, non-cardiogenic would be the best description. So what's happening in ARDS? Due to some inflammatory process, most common will be sepsis and pneumonia. It is also seen in burns, drowning, and many other causes. Your acute pancreatitis, anything which will cause systemic inflammatory response syndrome will cause ARDS. Most common will be sepsis and pneumonia. So almost any sepsis case with bilateral infiltrates, decreased saturations, will be labeling it as ARDS. So it's just inflammatory exudate. Because of inflammation, there is inflammatory exudate in the alveoli, which will be looking like pulmonary edema, but not typical bat wing appearance, just bilateral infiltrates. So pulmonary edema, there will be typical bat wing appearance, but here that is not there. Okay. And it will progress. Initially, there will be edematous type, followed by interstitial inflammation, followed by fibrosis. So ARDS will heal by fibrosis in 3 weeks. So this is important. The fibrotic phase will end, or it will be in 3 weeks. And coming to the causes, I told you pneumonia and sepsis are the most common causes, but there are lot other causes of ARDS. And coming to the diagnosis, the Berlin's criteria. So what is there in the criteria? After the event, what event? This event. Within 1 week, patient should have SOB. Within 1 week, he should have SOB. And it should be non-cardiogenic. And there should be hypoxemia. In X-ray, there should be bilateral infiltrates. Everything we discussed. How do you prove it's non-cardiogenic? Ideally, you should just test for pulmonary capillary wedge pressure. Bilateral infiltrates and hypoxemia. How are we testing hypoxemia? It's PaO2 by FiO2 ratio. So PaO2 is, you will take the ABG and you will be looking at the PaO2. How do you know FiO2? If the patient is in room air, FiO2 is 20%. And based on the oxygen you are giving, you will be calculating the fraction of inhaled oxygen. If that is less than 300, then that is ARDS. So less than 300 is mild. Less than 200 is moderate. Less than 100 is severe ARDS. How do you treat ARDS? Mechanical ventilation is the best thing. If not, if the patient is tolerable, you can also give non-invasive ventilation. In that, the best strategy is high PEEP, low tidal volume. Why I am giving low tidal volume? Because to prevent volumotrauma. If you are giving high volumes to your lung, because of that volume, your lung will be damaged. So decreased volumotrauma. Why I am giving high peeps? So once your alveoli are collapsed, it will take more work of breathing to open them. So to prevent your alveoli from collapse at the end of expiration, we are giving constant positive expiratory pressure. That should be high. This should be low. Low tidal volume, high peep. You can also try prone position. These are the best management. And because it's a pulmonary edema, it's better you are avoiding fluid excess states. Not give much IV fluids. If possible, give loop diuretics. And you can also give steroids. No evidence, but can be given. Especially COVID related ARDS, steroids work the best. This is the management of ARDS. So the Berlin's criteria, 4 things: time within 1 week, X-ray bilateral infiltrates, hypoxemia proven by PaO2 by FiO2 ratio, and non-cardiogenic pulmonary edema. Causes sepsis and pneumonia. It's an inflammatory edema. That's why you can see as bilateral infiltrates. Treatment, ventilation. If first you should give oxygen. If not required, you can go for ventilation. In that high PEEP, low tidal volume is the best. So low tidal volume means 4 to 6 ml per kg is enough. And it has phases: exudative, proliferative, and fibrotic. Fibrotic will be at 3rd week, at the end of 3rd week. This is about ARDS, Berlin's criteria, causes, and treatment. Everything is done. So hypercapnia is seen in type 2 respiratory failure. Here, because there is fluid in the lung, alveoli, it is type 1 respiratory failure, diffusion defect. Next thing is the pleural disease. So we have done the airway diseases, restrictive, obstructive airway diseases. Next, parenchymal diseases like our ARDS, pneumonias. Now, pleural diseases. So in pleural diseases, most commonly they will be asking about pleural effusion. So in pleural effusion, presence of cholesterol crystals in pleural effusion is a feature. That is what he is asking. So any pleural effusion, first thing we'll be doing a pleural tap. You have done many times pleural tap, right? Can be diagnostic or therapeutic. We want to know whether it's exudative or non-exudative, transudative. For that, we will be sending pleural fluid protein and pleural fluid LDH along with serum protein and serum LDH. If the protein in pleural fluid is more, or if the LDH is more, it is exudative. And that is given by the Lights criteria. So this Lights criteria is also important. So he will be giving some findings in this Lights criteria. And in options, either exudative or transudative. That's how you have to select the options. In that way also, he may be framing the question. This is important. So in transudative, the protein is low, less than 0.5. LDH is low, less than 0.6. And other way is less than 2/3 LDH. Okay. In exudative, if any one thing is present out of 3, 1 out of 3 is present, it is exudative. Nothing is there, it is transudative. That is one thing. And next important thing is, for exudative, transudative, we have seen Lights criteria. Good. Next, we'll see the glucose content. So in exudative, if the glucose content is very low, less than 60, you should suspect RA related pleural effusion. RA. And malignancies. So the question may be like very low glucose contents with cholesterol crystals. We'll see what is cholesterol crystals. The answer would be RA. And this is very low. Low glucose is seen in any infection. For suppose there is empyema, pleuritis. There will be any infection, there will be low glucose, but very low in these two conditions. Next thing is the cholesterol crystals. Where do you see the cholesterol crystals? In exudative only. When there is long standing. So you have pleural effusion for a longer period, since months. For suppose malignant pleural effusion or rheumatoid arthritis related pleural effusion or any chronic inflammatory condition. In those, there will be deposition of cholesterol and the cholesterol will be more than 200 and that cholesterol will saturate to form crystals. So the pleural fluid cholesterol more than 200 or presence of cholesterol crystals indicate that this is a cholesterol pleural effusion or long-standing pleural effusion. It is seen in RA, hypothyroidism, malignancy. Yes, in hypothyroidism, you can see cholesterol crystals in the pleural effusion. Hypertriglyceridemia. The triglycerides are more than 150. It indicates it's a chylous. Maybe the chylous duct has rupture and it's a chylous pleural effusion. It's a milky white pleural effusion. Hyperthyroidism, no. Sarcoidosis, we don't see pleural effusion. It's very rare in sarcoidosis. We'll be seeing interstitial or parenchymal lung disease with lymphadenopathy. That is the most common presentation of sarcoidosis. So what is important in pleural fluid? Your pleural fluid analysis. So do not miss to read pleural fluid analysis. In that, these are the key points. When these key points are given, you have to think of those diagnoses. So this is the pleural effusion. Your right CP angle is absent. Cardiophrenic angle. Okay. We have discussed about prothrombotic conditions, right? In that, one of the thing is pulmonary embolism. So pulmonary embolism, the most important things they will ask you is the Wells criteria. How do you diagnose? The investigation of choice, the ECG findings of pulmonary thromboembolism, and they can give you a CT angio image. So in investigation is the investigation of choice is CT angio, right? They can give you a CT angio image where there will be a saddle-shaped thrombus in your pulmonary artery that you have to identify as a filling defect. So these are the things which will be asked in pulmonary embolism. So the best investigation when there is suspicion of pulmonary thromboembolism is CT angio. So when there is low risk, we'll see what is low risk. Low risk, go for D-dimers first. So any prothrombotic condition, there is formation of thrombus, D-dimers will be elevated. If there is thrombus in deep veins, D-dimers are elevated. There is thrombus in portal vein, D-dimer is elevated. So D-dimer increased indicates that there is a clot formation, but it doesn't indicate that the clot is in the pulmonary. Okay. So it's a screening test. If D-dimers are positive, again you have to go for CT angio. No Doppler ultrasound we cannot do. One more thing is ventilation perfusion scan. If there is pulmonary embolism, the perfusion is decreased. And this is the best in pregnancy because angio, there will be contrast exposure. In pregnancy, To avoid contrast exposure and radiation exposure, CT is radiation exposure, better go for VP scan in pregnancy. So this is the Wells score. So based on this score, we will be deciding that, okay, this case has high probability of PTE. When there is high probability, go for CT angio. Low probability, do D-dimers first. If D-dimer is positive, go for CT angio. If D-dimers are negative, then there is no chance of pulmonary thromboembolism. So in Wells score, 3 points are given to two things. So 3 points, highest thing. That is, there is DVT or no other sign, no other diagnosis other than pulmonary embolism. 3 points for two things. Next, 1.5 points we are giving for 3 things and 1 point for 2 things. In 1.5, there is tachycardia. I told you there is tachycardia and pulmonary embolism, the most common ECG sign. Recent surgery or immobilization or history of PTE or DVT. Give 1.5 points. There is hemoptysis or malignancy, give 1 point each. If it's more than 4, it is PTE. But if it's more than 7, high risk of PTE, high probability of PTE. So in this case, you have to go for CT pulmonary angio. Less than 7, first do D-dimers, then if it's positive only, go for CT pulmonary angio. Yeah, the same thing, Wells score. So in a case scenario, he can give these things and he can ask you the investigation of choice. You should be able to calculate this score. And you should know the components of this score. And ECG, sinus tachy is most common. S1Q3T3 is most specific. Next important thing of respiratory system is disorders of ventilation. Your sleep apnea, obstructive sleep apnea and obesity hyperventilation syndrome. These two are very important. And how do you differentiate these things? You should know the differentiation. Only then you can answer the question. So we'll see the question and then we'll discuss it. Before going to the question, he can ask about OSA. So the definitions of OSA, we are seeing apnea. Apnea is cessation of breathing. For how many seconds? For how many minutes? So the definition of apnea, hypoapnea, you should learn it very specifically. That 10 seconds, 20 seconds, 30 seconds, the timing is important. We won't read it specifically. That will be asked in the exam. And apnea, hypoapnea index, he'll ask. The treatment. That's it. And he can give you the polysomnography. The chart he can give you and ask. So you should be able to identify it. We'll see that also. And obesity hypoventilation syndrome, that is completely different entity. We'll see all those things. So duration of apnea in OSA, that is what I'm asking. The duration is very important, right? So everything in a single table. This is the beautiful table and the most important table. Apnea, hypoapnea and RERA. So apnea is complete cessation of flow. Hypoapnea is decreased flow. So here complete cessation of flow more than 10 seconds. Hypoapnea, there is more than 30% decrease in airflow for 10 seconds, resulting in more than 3% desaturation or arousal. Everything is important. Apnea, more than 10 seconds, your breathing has stopped. Very simple. Hypoapnea, your breathing has decreased. How much? More than 30%. For how much time? For 10 seconds. What is the result? You are desaturated more than 3%. In saturation probe, your SpO2 has decreased by 3%. Or there is an arousal because of apnea or hypoapnea. You will be having an arousal. You will wake up in the sleep. And what is RERA, respiratory effort related arousal? There is obstruction. Because of obstruction, there is an arousal, but that is not meeting the criteria of hypoapnea or apnea. That is RERA. Based on this, we'll make an index. Apnea, hypoapnea index is apneas plus hypoapneas. Respiratory disturbance index is apnea plus hypoapneas plus RERAs. So this is per hour of sleep. Per hour of sleep. That is very important. So if it's more than 5, these events more than 5, it's apnea. 5 to 14 is mild, 15 to 29 is moderate, more than 30 is severe apnea. Every line of this table is important. It's a potential MCQ. And how do you investigate? It's polysomnography. So we are doing the sleep study. We are inviting the patient to our lab. We are asking them to sleep. We are connecting all these things. EEG, ECG, EMG, EOG. And we'll keep a mic for snore. We'll look at the flow of air in the nasopharyngeal. Only then I can say more than 30% reduction in flow. I have told the definition of hypoapnea. How do I know? Because I'm measuring the flow. The chest and abdominal movements and a saturation probe for SpO2. I'm measuring all these things and then I'm telling that in this much hours, in 6 hours of this sleep, this patient had 2 apnea episodes, 3 hypoapnea episodes, 4 RERA episodes. That is how the report of your sleep study will be based on all these things. So here, if you see, the flow at one point, the flow has decreased. Your nasopharyngeal flow has decreased. So there is obstruction. But your respiratory efforts are there, your chest and abdominal movements, efforts are there. That is obstructive sleep apnea. If the efforts are absent, then that is central sleep apnea. So this is the polysomnography. These are the components and this is how it will be seen. Obstructive sleep apnea. So we are done with the definition, diagnosis, the indices, treatment. There is obstruction to the airflow. First thing, you have to take an MRI and look for any obstruction. If the obstruction is there, go for plasty, uvuloplasty. No, if that is not significant, go for positive end expiratory pressure. Go for NIV with PEEP. So any obstruction is there with positive pressure, will be overcoming that. So every day night while sleeping, patient will keep non-invasive ventilator, a mask with a positive pressure, and he'll sleep. So treatment, first thing is lifestyle modification, exercise, food. Next thing is NIV with PEEP. Next thing is surgery, that is uvuopharyngoplasty. Uvuopalato-pharyngoplasty. Wherever there is obstruction, you are going to change that, plasty. That is OSA. Now coming to obesity hypoventilation syndrome. So this answer is 10 seconds. We got the answer. So I'll just give you a gist of obesity hypoventilation syndrome after a short break.
alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Okay, so welcome back. Let's continue with lung tumors. So we are looking into the important parts of each topic here. Now we are taking lung tumor. In lung tumors, what are the important things to be covered? So basically, what are the lung tumors you should know? Non-squamous cell, non-small cell and small cell. In non-small cell, it is adenocarcinoma or squamous cell carcinoma. So you should know about the differentiation of these three things. Maybe the cytological markers and the complications, the paraneoplastic syndromes, they're all different and those things we should know. So we'll take up the question and discuss all those things. Tumor most commonly associated with SVC syndrome. The SVC syndrome is one of the complications of lung malignancy. And it's most commonly seen in, see if you observe, these all are mediastinal masses. Only the mediastinal masses, even in lung carcinoma, only which can cause mediastinal mass will result in SVC obstruction, and in lung carcinoma it's more specific to squamous cell carcinoma. So this is squamous cell, sorry, small cell. It's small cell carcinoma. So we'll be looking into SVC obstruction syndrome. So basically your superior vena cava is getting your blood, all the venous supply from the head and neck through SVC into the RA. Now your SVC is blocked. So there is increased congestion in the supply of your superior vena cava, right? The skin of the head and neck and upper part of the chest. Your brain, there is increased congestion. There can be cerebral edema and coma. That is the worst complication of SVC. That would be an emergency. So SVC is one of the most important oncologic emergency. 95% causes are malignancies. Only 5% are non-malignant causes. In oncologic, the most common is your lung. In lung, it's more specific to small cell carcinoma, followed by squamous cell carcinoma. So what do you understand by this? Both of this can cause SVC syndrome, means these both are central tumors. That is more near to the airway, more central tumors, whereas your adenocarcinoma is more peripheral. So there is no chance an adenocarcinoma can cause SVC obstruction. And next thing is your lymphomas. It's very rare for Hodgkin's lymphoma to cause, mostly non-Hodgkin's lymphoma followed by Hodgkin's lymphoma. These in malignancies, these are the primary causes of your SVC obstruction. And your non-pulsatile JVP elevation, that's what we were discussing, right? That is also seen. See this facial edema and plethora. venous distension, and there is a tumor obstructing the superior vena cava. That tumor should be central. Okay. Let's see the features of squamous cell. Important features. Small cell, squamous, and adeno. So central lung malignancy. These two are central. This is periphery. Adenocarcinoma is peripheral tumor associated with smoking. The central tumors are associated with smoking. This is the strongest association, followed by squamous, no association in adenocarcinoma. Next thing, complications. Small cell SVC obstruction. Here also SVC obstruction, but here it's more. And squamous cell, mostly cavitatory. They can form cavitatory lung lesion. So a cavitatory lung lesion, not only infections, but your malignancy is also one of the DD, and that is squamous cell carcinoma. And adeno, not much complications. Next, paraneoplastic syndromes. Squamous cell, most common is hypercalcemia. Whereas your small cell carcinoma, it can cause SIADH and Lambert-Eaton syndrome. So these are the paraneoplastic syndromes of small cell and squamous cell. Next, coming to the markers. Your small cell carcinoma is a neuroendocrine tumor, and one of the most important feature of neuroendocrine tumor is metastasis, that too bony metastasis. So your squamous cell carcinoma, mostly there will be bony mets. And the markers of any neuroendocrine tumor will be synaptophysin, chromogranin. Whereas markers of squamous cell carcinoma is P16 positive, cytokeratin positive. And adenocarcinoma is TTF1, napsin positive. Okay. So these are the lung carcinomas, and this is how you have to differentiate. Why we should differentiate? Because the treatment, the prognosis, everything differs. So this is one of the complication, SVC syndrome. And one more important thing, Pancoast tumor, this also they'll be asking. So Pancoast tumor is the tumor in the apex of the lung. Why is it important? What are the structures in the apex of lung? One important thing is your brachial plexus. And other thing is your sympathetic plexus. So compression of brachial plexus, that to the lower trunks, resulting in atrophy of the muscles, small muscles of hand. And sympathetic plexus, Horner's syndrome. With apical tumor. Most commonly squamous cell carcinoma. So that is Pancoast tumor. These are the complications. So these are the things you should know about lung carcinoma. Never miss them. Next, syndromes. Cardiovascular syndrome. So basically, what is Cardiovascular syndrome? You should know the definition and the triad, that's it. And what is defective? That's it. All of the following are true about Cardiovascular syndrome except dextrocardia is there, infertility is there, bronchiectasis is there, But mental retardation is not a feature of cardiac syndrome. The intellect is intact. So what is cardiac syndrome? It's a primary ciliary disorder. The cilia are abnormal. So when the cilia are abnormal during embryogenesis, there can be situs inversus. And dextrocardia. So situs inversus, everything which should be on the left side of the body now are in the right side. Dextrocardia, your cardiac apex on the right side. Next, the same ciliary disorder in the lungs or airway will cause recurrent lung and sinus infections. What happens when there is recurrent lung infections? Damage, again infection, damage, more prone to infection, resulting in bronchiectasis. And the same ciliary dysfunction in your genital tract can result in azoospermia and infertility. So it's a triad of situs inversus, dextrocardia, bronchiectasis and infertility. That is cardiac. It's due to primary ciliary disorder. That's it, very simple. So the one important thing you should not miss in respiratory and renal disorders is your acid-base disorders. So one question from acid-base is for sure. So how to read an ABG? That's a basic thing. We'll see. Most of you have known it, but if you have any lapses, this is the best time to fill it. ABG analysis showing pH is 7.2, bicarb is 36, PCO2 is 60. Identify the anomaly. So there is definitely acidosis. Bicarb is increased, PCO2 is also increased. Okay. So what is the diagnosis? So first we'll see the pH. pH is 7.2. So there is acidosis. Next thing, we'll be looking at bicarb and carbon dioxide. Your bicarb is 36, that is increased. And your PCO2 is 60, that is increased. Everything in the same direction. Definitely there is respiratory acidosis. Bicarb somewhat in the normal range. Next, for PCO2, 10 mm of Hg increase in PCO2. If it is acute respiratory acidosis, 1 bicarb should increase. Or if it's chronic acidosis, 2 should be increased. That is the compensation. Okay. Sorry, this is metabolic acidosis. Everything in the same direction. Okay, normal bicarb is around 26, right? So bicarb is increased, carbon dioxide increased, and pH is increased. Everything in same direction is metabolic acidosis. Now we have to look for compensation. For metabolic acidosis, how will we look for compensation? 1.5 into bicarb plus 8 plus or minus 2. So your PCO2 is very high if we look at the compensation. See, almost 36 plus 10. It should be 40 to 50, 46 to 50. That is the PCO2, but it is very high. So plus respiratory acidosis. So the best option would be respiratory acidosis plus metabolic acidosis. Yeah, that option is, it's a printing mistake. And one more thing you have to do is, you should look for anion gap. Whenever there is metabolic acidosis, you should look for anion gap if available. So what is anion gap? Your sodium minus bicarb plus chloride. If anion gap is more, it's hugma. If anion gap is less, it's nagma, normal anion gap, high anion gap. And if there is high anion gap, you should look for delta gap. So the first step we are doing is look at the pH. Second step is compensation. And the third step is anion gap if there is metabolic acidosis. And the fourth step is delta anion gap if there is high anion gap metabolic acidosis. What is delta gap? Difference in anion gap by difference in bicarb. If it's 1 to 2, then it's pure hugma. If it's less than 1, it is high anion gap plus normal anion gap metabolic acidosis. If it's more than 2, it is high anion gap metabolic acidosis plus metabolic alkalosis. Let's write it in a proper way. So how do you calculate an ABG? First step, look for the pH. Based on that, you would know it is acidosis or alkalosis. Next thing, you will be looking at bicarbonate and carbon dioxide. Based on that, you will be knowing respiratory or metabolic. Everything in the same direction, metabolic. If pH in one direction, PCO2 and bicarb in opposite direction, it is respiratory. Next, look for compensation. If it's compensated, pure respiratory or metabolic. Not compensated, associated alkalosis or acidosis. Fourth, so here I told metabolic acidosis plus respiratory acidosis. Why? I've looked at the compensation. For this much metabolic acidosis, for this much increase in bicarb, your PCO2 should increase this much, right? So looking at the compensation for metabolic acidosis, the compensation formula is 1.5 into bicarb plus 8 plus or minus 2. For metabolic alkalosis, it is just 1.5 into bicarb. For respiratory acidosis, we have seen. And the next step, if there is metabolic acidosis, look for hugma, anion gap, hugma or nagma. If there is hugma, look for delta anion gap. Delta anion gap is also a question. Based on delta anion gap, you can say whether there is associated nagma or metabolic alkalosis. So I'm extremely sorry, I've just seen the mistake. So I thought bicarb is decreased. So pH is acidosis, bicarb is increased, PCO2 is increased. So bicarb increased means there should be alkalosis, but the pH is definitely showing acidosis. So this is respiratory acidosis. So respiratory acidosis. To compensate that, the bicarb has increased. That is metabolic compensation. Here we have to look for the compensation. When we are calculating the compensation, the bicarb is more. So it is metabolic alkalosis. Yeah, this option is correct. The bicarb is high. Okay, so basically this is what we have to do. Look at the pH based on the PCO2 and bicarb, whether it's respiratory or metabolic, and compensation based on these formulas, you have to derive it. If it is metabolic acidosis only, then look for anion gap. Only if it is hugma, look for delta anion gap. That's it. Very simple. So in exam, most of the times they'll be giving you simple things only two things. Like this, they'll be giving you to calculate. So coming to respiratory acidosis and alkalosis. Alkalosis is washout of CO2. You will be seeing that in hyperventilation disorders. Respiratory acidosis, type 2 respiratory failure, we have seen it. So yeah, this is all about respiratory system. The most important things are ABG, infections like TB. Yes, your asthma, COPD are also important, but nowadays they are asking more questions on TB, COVID, and your ABG. Let's move on to next topic, GIT. So in this course 6, we are doing the overview. Of that, we have come to GIT. We'll be taking up each topic from each topic, each system, each topic, each question, and we'll be discussing which part to concentrate on. We are not covering the whole medicine. I'm not teaching the whole medicine. Okay. Esophagus in GI tract. So esophagus, from above, it's esophagus, stomach, your small intestine, large intestine. So this is how we'll be covering. So GIT, there is a large overlap between medical and surgical GIT. So whatever is possible from the medical thing we are covering, and your surgical part of GIT will also be covered in surgery. Okay. So whatever the important things for the exam, you should concentrate from medical GIT. We are covering most of the things, whatever is possible. Esophagus, first thing is dysphagia. So in dysphagia, most of the times, most of the questions will be approach. He wants you to identify whether it's structural dysphagia or functional dysphagia. That's it. That's the only thing you have to learn in approach to dysphagia. So investigation of choice for dysphagia to solids. It is endoscopy. Barium swallow, any dysphagia, initially we will be doing barium swallow.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Sorry for the interruption. So we'll continue. Lung tumors. So where are we? We are looking into the important points of each topic, right? Now we'll be taking up lung tumors. First, we'll see the question. Tumor most commonly associated with SVC syndrome, that is small cell carcinoma. If you observe, all these are mediastinal tumors. So the thing is, SVC syndrome, the most common, 95%, the most common cause is oncological. Only 5% is non-oncological. In that 95%, the most common, it's caused by mediastinal masses. That too most common lung cancer. In lung cancer, small cell carcinoma, followed by lymphoma, non-Hodgkin's lymphoma. So whenever there is SVC syndrome, the first thing you have to think is malignant obstruction only, because most common is malignant, right? SVC obstruction. But when do you suspect SVC obstruction? What are the symptoms? So SVC drains from your head, neck, upper part of the chest. So whenever there is SVC obstruction, there are increased congestive symptoms of all these things. So there is swelling, flushing of the skin of head, neck and upper part of chest. And there is edema of your airways, edema of your brain. That is the emergency. Edema of brain resulting in encephalopathy, coma. That is why this is an emergency. One of the oncological emergency is SVC obstruction. Most common is lung carcinoma. Small more than non-small, that too squamous cell. So when I'm saying the lung cancer which are causing SVC obstruction or small cell and squamous cell, I'm indirectly saying that they are central or mediastinal. Whereas your adenocarcinoma is a peripheral tumor. It won't come and cause SVC obstruction. See, SVC is here. If adenocarcinoma, the mass of adenocarcinoma is here, it's impossible for it to cause SVC obstruction. Whereas your small cell carcinoma and squamous cell carcinoma are central tumors, mediastinal tumors. There are more chances that they can cause this. Remember that. And followed by lung carcinoma, second thing is lymphomas. Non-Hodgkin's lymphoma more than Hodgkin's lymphoma. So till now, most of the cases in which I have seen SVC is lung carcinoma only. That too small cell. So we are discussing about SVC syndrome. Now we'll see about the lung carcinomas. What important things you should know about lung carcinoma. The same thing we discussed, the symptoms are here. So it is small cell, squamous,
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduous capsular.
600 grams would give
completely opposite to the pressure abrasion. Here,
The wall of the forebrain.
Sorry for the interruption. So we'll continue with our lung malignancies. So there's small cell squamous and adenocarcinoma, right? So we know one thing, these two are central and adenocarcinoma is peripheral. So the risk factor for lung carcinoma, the major risk factor is smoking, right? Smoking is the main risk factor for small and squamous. And it's the strongest risk factor for small cell carcinoma. Coming to the complications, the SVC obstruction. So just now we have discussed the SVC obstruction is most common in small, right? Followed by squamous. And in adenocarcinoma, there is no chance. In a case of SVC syndrome caused by lung carcinoma obstruction, you diagnosed it as adenocarcinoma. It's completely blunder. And coming to paraneoplastic syndromes. So the most common paraneoplastic syndrome in squamous cell is hypercalcemia. And hypercalcemia is not seen in small or adeno. Whereas small cell carcinoma, there can be SIADH, Lambert-Eaton syndrome, and in squamous cell carcinoma, it is cavitatory lesions. It can present as cavitatory lesions. So most common cavitatory lesions of the lung, will be diagnosing it as infections, right? So one of the important DD will be your malignancy, that to squamous cell carcinomas. And important thing, ultimately you diagnose it by biopsy. On biopsy, we will be looking at some markers. If those markers are positive in immunofluorescence, IF markers, then this malignancy, that is how we'll be diagnosing it, right? So on biopsy, small cell carcinoma is a neuroendocrine tumor. So what are the markers of neuroendocrine tumor? Synaptophysin and chromogranin, right? The same things are present here. And small cell carcinomas, they tend to metastasize by blood. So more bony metastasis. Whereas squamous cell carcinoma, mostly lymph nodal metastasis. And the markers is P60 is positive. Your adenocarcinoma, the most specific markers are TTF1 and napsin A. So when you are reading a biopsy report, we'll be seeing most of the lung carcinomas. Along with the morphology, we are also interested in the markers that will differentiate whether it is a small cell, squamous cell or adenocarcinoma. Why is it important to differentiate? Because the prognosis and treatment varies. That's why you have to differentiate. And one more complication of malignancy, that is Pancoast tumor. So basically, what is Pancoast tumor? It is a apical lung tumor. So what are there at the apex? Brachial plexus and your sympathetic plexus, both are compressed. Brachial plexus lower trunk is compressed, resulting in atrophy of the muscles of the small muscles of hand. And your sympathetic plexus, there will be Horner syndrome. So wasting of muscles, small muscles of hand. And Horner syndrome. This is brachial plexus. This is sympathetic plexus. So Pancoast tumor is a apical tumor. The most common morphology is squamous. So these are the things you should know about lung tumors. Next, let's see what is cartilaginous syndrome. What should you know about cartilaginous syndrome? So basically, it's very simple. What is cartilaginous syndrome? Where is the defect? And what is the triad? All of the following are true about cartilaginous syndrome except, yes, you can see dextrocardia, infertility, bronchiectasis, but not mental retardation. The intellect is preserved. So what is cartilaginous syndrome? It is primary ciliary dysfunction. So the cilia are not functional. Because there is ciliary dysfunction during embryogenesis, there is dextrocardia. In lung, recurrent infections leading to bronchiectasis. In genitourinary system, leading to azoospermia and infertility. This is the triad. So primary ciliary dysfunction. Embryogenesis results in situs inversus and dextrocardia. What is situs inversus? So everything which should be present on the right side of body will be in the left side. Dextrocardia. Your cardiac apex is right side. Next, the same dysfunction in your respiratory system. So basically, in your respiratory system, why do you need cilia? To clear the secretions, right? Now the cilia are dysfunction, the secretions are not cleared, in fact pooled. So there is stasis of secretions, more bacterial growth, recurrent infections. So recurrent sinusitis and bronchiectasis. Sinusitis and LRTIs which will lead to bronchiectasis. Okay. Now the same ciliary dysfunction in the genital tract. Resulting in azoospermia. So infertility. This is the typical triad of cartilaginous syndrome. Okay. Next, the most important topic. Acid-base disorders. At least one question. One question is your acid-base disorder. They will give such values and most of the times the question will be they'll give the values and you have to calculate it. And it takes some time. You should spend some time because you will get the correct answer. There is nothing wrong you're doing in ABG calculation, right? So give that some time and calculate it, put the right answer, okay? So coming to ABG, so how to approach an ABG? We'll approach this question and we'll see. So coming to the first step, I'm interested about pH. So what is the pH here? It is 7.2. Normal pH 7.35 to 7.45. Less than 7.35 is acidosis, more than 7.45 is alkalosis. So here the pH is decreased, so it is acidosis. Now once it is acidosis, I want to know the primary defect, whether it's respiratory or metabolic. Okay, here what is happening to bicarb? Bicarb is increased, PCO2 is increased, pH is decreased. Bicarb should be around 26 and your PCO2 should be around 40. It should be around 36. So your bicarb is increased and PCO2 is increased. So if your pH and the parameters are going in the opposite direction, it is respiratory. If they are going in the same direction, it is metabolic. So it is respiratory acidosis, that is for sure. So type 2 respiratory failure. So bicarb 60 means it's a bit high. Next, I want to look for compensation. Whether it's compensated or secondary acid-base disorder is there or not. For compensation, for each metabolic disorder, for each acid-base disorder, it's different. For acidosis, how I calculate? For 10 PCO2 increase. Acidosis is nothing but increase in PCO2. In acute condition, 1 bicarb, or in chronic, 2 units of bicarb should increase. Here, from 36 to 60, almost 22 times. 20 PCO2 is increased means your bicarb should maximum increase by 4, but here it's increased by 10. So your bicarb is higher than expected. So increased bicarb, metabolic alkalosis. So secondary metabolic alkalosis is also there. And because there is metabolic alkalosis and respiratory acidosis, it stopped here. But if there is metabolic acidosis, you have to calculate the anion gap. How do you calculate anion gap? It is sodium minus bicarb plus chloride. If the anion gap is high, it is HAGMA, high anion gap metabolic acidosis. If it's normal, it is normal anion gap metabolic acidosis. Next step, if there is HAGMA, you should calculate delta gap. Delta gap is also important. So delta gap is change in, that is difference in anion gap by difference in bicarb. If it is 1 to 2, this delta gap, fine. It's good. It's just HAGMA. But if the delta gap is less than 1, it's HAGMA plus NAGMA. If it's more than 2, it is HAGMA plus metabolic alkalosis. So this is how you are going to calculate ABG. These steps you should follow. So if you go step by step, you will be doing it fast. So one question in exam is from ABG. Just go through this approach. That's it. Before exam, you will be able to do it. Okay, we are done with respiratory system. So in respiratory system, these are the things you should not miss, mainly the TB, the newer treatment, and ABG. So let's stop the session today. Let's end it. GIT hepatology in this part, and day 2 part will cover tomorrow.
Ethyl alcohol 95% or the more common
Okay, they do not have any particular shape.
It is called the deciduum capsular.
600 grams would give
Completely opposite to the pressure abrasion. Here
The wall of the forebrain.